Calcitriol has a long track record of safe use, whereas PTH has been recently recommended. Hypercalciuria can be managed with monitoring. There are safety concerns with PTH. There's a black box warning declared on the carton of PTH which says osteosarcoma in animals, although not yet found in humans. And it requires regular lab testing as well as we do for calcitriol. So long-term data is available for calcitriol. It is a proven drug in congenital as well as acquired hypothyroidism. It causes sustained symptom control, so not very bad. Oral versus injection is the biggest drawback of PTH, that it is an injectable therapy and hence compliance is an issue in a chronic disorder. Easier adherence with calcitriol. And leave apart what I believe, but all over the world, across the globe, even the Endocrine Society recommends calcitriol as the first-line therapy. So why was PTH anyways brought up in the market? It is considered in cases of refractory hypocalcemia. So I am not against PTH, but it should not be used as a first-line therapy in all the cases of hypoparathyroidism. It needs to be reserved for refractory cases not responding to calcitriol. Patients who are poor tolerance to oral therapy and limited to selected patient groups. So talking about global availability, again, calcitriol being an oral formulation does not require a cold chain maintenance. It is available widely in most pharmacies. There is cost effectiveness and hence it is covered in many of the government health schemes as well. The only limitation that I consider for calcitriol is it requires frequent monitoring for prevention of hypercalciuria and nephrocalcinosis, and it often needs calcium co-therapy. So even with these limitations, I still go ahead with calcitriol being the first-line therapy. So my final verdict will be calcitriol is effective, safe, affordable. It remains the first line in most patients, and PTH needs to be reserved for special cases and not to be used as a first-line therapy in all the cases, owing to its limitations such as being injectable formulation, expensive, and hence poorly adherent with the patients. Over to the Jude.
Thank you so much, Dr. Neha, for such a short, switch, and a crisp presentation. I think a business strategy is to credit your product and discredit the opponent's product. To credit of her product, she has said, number one, it is endorsed by the experts as a first line of treatment. Number two, it is convenient. Number three, it is easily available. It is a reasonably good treatment option and cost effectivity. She has credited to her product, and to discredit her opponent, she has said there is a risk of osteosarcoma, black box warning, the risk of hypercalcemia, the need for injections, the high cost, and the need to maintain a cold chain. She has brilliantly brought out that old is gold. To refute her arguments, I request the opponent to come and speak in terms of there is a need for change.
I will be talking about, as is already discussed, hypothyroidism. I will not go with this. What is hypothyroidism? So what is the limitation of conventional therapy? If we see that there is a wide fluctuation in serum calcium with conventional therapy, there is a high pill burden, there may be poor quality of life with this, there may be renal complication because of increased urinary loss of excretion in the absence of PTH, and in activating calcium sensing receptor mutation, calcitriol therapy may even increase urinary excretion of calcium, may cause polyuria and nephrocalcinosis. So if we see the complications with this conventional therapy, with long-term treatment is required with the calcitriol, the complications which are found in various studies are hypercalcemia, hypercalciuria, nephrolithiasis, nephrocalcinosis, and even renal failure. These are the complications which may be encountered, which are encountered with the conventional therapy with long-term use. So, as Dr. Neha has already discussed, the aims of chronic management of hypoparathyroidism, we know that we have to prevent the symptoms of hypocalcemia, and at the same time, we have to avoid hypercalcemia. We have to maintain serum calcium at the lower normal range, and serum phosphate within a higher normal range. We have to avoid hypercalciuria and maintain the calcium phosphate product below 55 milligram per deciliter. Avoid renal calcification. So these are the aims which were not taken care by the conventional therapy. All the aims were not properly taken care by the conventional therapy. So it led to the use of PTH in this disease. So if we see the history, major change was brought by the phase 3 trial replace study, which was done in 2030 and published in Lancet, which was done in 134 patients aged 18 to 85 years from 8 different countries. And they found that there is a significant improvement in biochemical marker as compared to the conventional therapy, and the symptoms also improved, and the side effects were the same in both the groups. So this led to the use of PTH in 2015. US FDA approved PTH 1 to 84 for the treatment of selected cases of hypoparathyroidism. And one preparation was also registered in European Union in 2017, and it has been allowed for marketing in March 2022. Teriparatide, which is widely available, is still not approved for treatment of hypoparathyroidism. So it's a problem. If we see the types of PTH, PTH is a 84 amino acid peptide with full biological activity in first 34 residues. PTH is called teriparatide, which contains N-terminal, which is important for the physiological action. If we see the full molecule, PTH 1 to 84 is a full molecule which is approved for hypoparathyroidism in cases. There are 2 more molecules. One has been approved, that is Pelopec teriparatide, which is also called Transcon. It is a pro-drug with a sustained release PTH. So the use, all these, both the PTH 134 and PTH 184, both are short-acting. With the use of this Pelopec teriparatide, this is a long-acting drug, so multiple injections, the use was decreased. And eniboparatide, this is one of the drug which is under investigation, which acts on PTH receptor agonist. Now, if we see all the comparative studies, PTH, all the PTH which is available and under investigation are injectable, are given subcutaneously. PTH 134, if we see the effect on 24-hour urinary calcium, it only is reduced while giving a continuous infusion, continuous like we give in diabetes, and the effect in quality of life is improved in some open label trials. If we see PTH 1 to 84, it is both approved by FDA and European medical agencies, and it has seen in some observational studies that 24-hour urinary calcium may decrease with the use of recombinant human PTH. And observational studies also show that the quality of life is improved. Pelopec teriparatide is one of the newer agent, also called Transcon. It is long-acting, and RCTs have shown that it reduces 24-hour urinary calcium and also improves the quality of life. Eniboparatide, which is an investigational drug, is also a long-acting drug, and phase 2 trial has been shown that it significantly decreases the 24-hour urinary calcium. Now, what are the concerns with the use of conventional this PTH? Is this PTH safe in children, and is this effective in children in long-term use? Now, what are the evidences? One of the study which is done by Watts NB et al., which is a large study but only done in 49 adults, no pediatric studies seen. It shows that there is a significant improvement in biochemical parameters and renal functions, and it is well tolerated as well. Saraf et al. Did an observational study in 4 children. This is a pediatric study in which continuous subcutaneous recombinant human PTH 1 to 34 was used, and it was followed for 3 to 8 years with a long follow-up period was done, and it was found that it is both effective and safe. Winner KK et al. Did an open label study in 14 children, which shows that long-term parathyroid hormone 134, if given twice or thrice daily for 2 to 10 years, was effective replacement therapy for up to 10 years. Sometimes nephrocalcinosis progressed in 5 patients out of the 14 patients, but the KFT remained the same. Another study in 2021 by Winner, they did a pooled analysis of 10 current and the past study over 27 years, and they found in 192 patients from 2 to 74 years of age. The age group was very wide, and they compared and they found the significant difference between 134 and there is a significant improvement in biochemical markers as well as the pharmacodynamic profile. KFT remained stable in both the groups. In 2022, Tuliji et al. Also studied in 6 pediatric patients with teriparatide and found a significant reduction in the calcium supplementation. At least the pill burden was decreased with this. Renal ultrasound worsening was seen as 3, but 3 remained normal, but the RFT remained normal. Another study in 2022, they did a systemic analysis and meta-analysis in 7 RCTs, and there was only one pediatric study in this meta-analysis, in which they found that some benefits in the quality of life, and with TransCon, there might be a discontinuation of calcium and active vitamin D therapy. PTH also reduces the phosphate levels so that ectopic calcification, the risk of ectopic calcification is decreased. And some studies in this meta-analysis shows that there is increased risk of hypercalcemia with parathyroid therapy. Liu XX et al. In 2016 also did a meta-analysis, both pediatric and adult studies, in which they did found that PTH therapy can maintain the serum calcium level, and a 24-hour urinary calcium is decreased with PTH. Another study in 2022, it was a meta-analysis. 4 RCTs were analyzed, in which they found no difference between the PTH and the conventional therapy, and the incidence of adverse effects was same. So this is one of the meta-analysis, although all the studies were done in adults, which found no difference between PTH and this. Bhatt et al. Did a case report in a 4-month-old infant in which they used teriparatide for severe refractory hypoparathyroidism, and they found it effective they used about 1 to 2 years, and they found it effective and safe during the study period. So what are the current recommendations for the use of PTH? As Dr. Neha has already told, that it is used for children or patients who are not adequately controlled on conventional therapy. So this is one of the options where we can use it, the treatment where it is not controlled by conventional therapy. Like if the individual is on conventional therapy, is having a wide fluctuation in calcium level, those requiring repeated emergency intervention, patients with hyperphosphatemia, with renal insufficiency, with significant hypercalciuria, nephrocalcinosis, and nephrolithiasis, for patients with gastrointestinal pathology and malabsorption, or with gastrointestinal side effects with oral calcium and calcitriol, for individuals with osteoporosis who require pharmacological interventions. This can be used in children or patients with reduced quality of life, and in patients with poor compliance with high pill burden, we can use PTH therapy. And one of the indication is calcium sensing receptor activating mutation, in which calcitriol therapy per se may cause increase in excretion of urinary calcium. So this is one of the area where we can use PTH. So what are the conclusions with all these studies been done? There are only few studies in children. We need more study to enhance the use of PTH. Study shows beneficial role in decreasing the dose of calcium and phosphate, but still we need more evidences. Serum phosphate level decreases the PTH therapy. This is one of the, and decrease the ectopic calcification. One important thing, that 24-hour urinary calcium is reduced during with the use of PTH therapy. It is well tolerated, as seen in most of the study. It is well tolerated in all the age groups, so we can use safely in children also. And there is need of more RCTs, obviously.
So thank you for that presentation. And I see, if we look at endocrinology, it is all about hormone replacement therapy. In type 1 diabetics, we replace hormones, and Similarly with hypothyroidism and all. So one might think that once you have hypoparathyroidism, might as well replace with parathyroid hormone, and it will be absolutely physiological. But there are few things which
So I think
which
they
use
can rebut, they have to rebut each other. Yeah, the 2 minute rebuttal, and
Yeah.
then your decision will come.
Yeah, I think we request Neha to come and fight back.
Both of them, yeah, right.
So I think my dear respected opponent herself concluded with the first thing that there are relatively very few studies in children with PTH and more RCTs are needed. So unless and until we have a long-term data for a drug, as physician, are we comfortable in prescribing our children with PTH? Do we have any hands up for PTH after these 10 minutes talk? For calcitriol? Are we going to prescribe calcitriol for hypoparathyroidism? Are we going to prescribe PTH for hypoparathyroidism? So I don't see any hands. So unless and until physicians are safe for a drug, how can we prescribe the drug for our children? So my rebuttal ends here that calcitriol is still the first drug of choice. In reserved cases, I agree, in reserved cases, we need to switch to PTH. Thank you.
Manisha, do you want to fight back?
Yes, sir. I think in the effect in 24-hour urinary excretion, PTH is better than calcitriol therapy as seen in most of the studies. And sometimes we are in a improving, we are advancing, and we need to advance also, because there has to be a replacement therapy with the actual drug which is not there in the body, actual hormone. So this has to be, studies are going on, a better agents may come sometime. So we have to have in the back of the mind, we have to be ready for a newer drug and the better opportunity for the children.
Yeah, very nicely.
Yeah. Actually, both presentations were complementary to each other. And she has presented the current treatment and she is presenting the future treatment. And as you said, now the treatment is calcitriol and calcium. But in your mind, are you comfortable with that treatment? So, so if you follow up the patient for a long time, I am not that happy because he may develop hypercalcinosis, nephrocalcinosis, and all this. We have to monitor the child. And actually, we are thinking for a correct drug in the future. And she was describing about that future trends and all these things. So I think both are contributory to each other. Not much trials in children, but it may be a drug of future actually. So both are complementary to each other.
Right, thank you. I think to sum it up, calcitriol, PTH, both have pros and cons. The pros of calcitriol is, yes, it is endorsed by the Endocrine Society. It is convenient, it is available, it is cost effective. The cons would be the impact on quality of life, the need for second line of treatment, the renal complications, risk of ectopic complications, and some impact on bone health also, which is related to, and the risk of fractures. Coming to PTH, the pros would be it's physiological, better long-term. Till 10 years, data is available in your Wiener study. And another thing which I want to support, Manisha, is the use in acute situations. When you're really desperate in the ICU, a short course of PTH may help you tide over the crisis at least. The cons would be the need for injection, the risk of osteosarcoma, the risk of hypercalcemia, the need for cold chain, and the cost effectiveness. I think a note about osteosarcoma, the doses that is prescribed in these children are much lower than the carcinogenic doses that is described in the literature. So it might not be that bad a drug, maybe more pediatric data. Dr. Devi Dayal has written a very nice review summing up the data of about 100 children with hypoparathyroidism treated with PTH. It's a free article. All of you can go through. I think start with old is gold. Don't be resistant to a new drug in the future. I think that would be the take home from this debate.
It was a wonderful discussion. And I think clearly, as we say, hypophosphatemic rickets, its always treatment has been phosphorus and calcitriol. So we are trying, it's like central DI if you're treating with hydrochlorothiazide. AVP is not available, you're treating with hydrochlorothiazide and amiloride. You may be doing okay, but you're not doing great. So here, these situations, if you have a specific drug coming up, maybe a new analog, which is safe, which is more effective, will be the way forward. So I think with this, we'll move to the second debate. The HbA1c one here. HbA1c.
So I'd like to invite Dr. Pradeep for next debate as a first contender, and he'll be talking about HbA1c against Dr. Manoj, who will be speaking on OGTT.
Thank you, Dr. Hari. Good morning, all. So my product for promotion is in support of HbA. So whatever evidences I have collected in a couple of days, I'll fight on the ground of that. So as we all know, this is a point of care test. You don't need to have fasting of 8 or more hours. You just have the child and do it. You will have the result in the same day. It is very convenient. No fasting is required. It predicts the insulin resistance in the child. So James Megatal, he did a study in almost more than 2,000 children, and there was evidence in support of HbA predicting insulin resistance in predicting type 2 children or the children who were obese and had comorbidities. Another study from published in African Health Sciences, they also support the association of glycosylated hemoglobin with the increase in insulin resistance in obese children. So they did this study in 70 obese children and 60 normal weight children aging from 3 years to 15 years, and concluded that high HbA level in obese children can be used as a screening tool to detect insulin sensitivity as well as resistance. HbA predicts high BMI also. So as the obesity or BMI increases, there is increase in HbA also. So this study, this is published in Pediatric Diabetes, and this concluded that there is established HbA reference values based on large sample of healthy German children and adolescents. So age, gender, socioeconomic status, pubertal status, as well as BMI were also predicted by rise in HbA in these children. So significance of HbA in diagnosing and prognosticating diabetes children. This was published by this Sharik et al. We can show this predicts the there is positive correlation with fasting blood glucose and HbA here. Endocrine Society also supports in this association with American Diabetes Association that comorbidity screening can well be done with HbA in obese children. So as HbA increases, you can see that this 5.7% to 6.5%, it can predict the pre-diabetes in obese children. And if it crosses more than 6.5, it also, it is included in the guideline of diagnosing diabetes. SPAD also supports that in high specificity in diagnosing diabetes, the level increases more than 10% over 3 to 15 months. And as it increases more than 5.7%, the clinical diabetes risk can increases. It also, SPAD guideline says that as it increases more than 5.7% to 6.5, you can also predict the child going into pre-diabetes. A study published in Clinical Diabetes, where comparison of HbA with oral glucose tolerance test was done. Taking in account of all the parameters like BMI scores, HbA, and HOMA-IR, it predicts, pre-diabetes and diabetes well, and has shown the positive predictive value. SPAD guideline supports that it can be used as screening for diabetes here when it increases. Again, this Korean study also concludes that HbA 6.5 was more to detect, but their point was that optimum cutoff, they can take 6.15% for optimum cutoff as diagnosing a child with diabetes in Korean children. Again, in another study from Korea, they have concluded that when HbA increases, the specificity increases for diagnosing diabetes. Sometimes practically also we use this because this HbA gives you the long-term glycemic or dysglycemic parameter of a child. So often in our practice, we see in adolescent children who in their SMBG chart, they write, if you find the same handwriting is there in the chart, same ink is there. So there are two methods to see whether the child is taking properly insulin dose or not. You can see the log of that glucometer, or better you can check with HbA. So HbA gives you a long 2 to 3 months of, there's no bluff. It gives you the real picture of what was the this long-term glycemic control of a child. So it's a good for monitoring diabetes progression also. So it gives a cutoff that you should keep a child less than 7% of HbA. So the disease progression is slowed down. Also, especially in type 2, it helps you out in when you should start the insulin therapy. So the child who is on metformin, when you have to add metformin, when there is osmotic symptoms, when you have to add more metformin. So if a child who is having glycated hemoglobin 8.5%, you can add metformin. When this osmotic symptoms are persisting and it increases more than 8.5%, you can add basal insulin also. So it helps you out in initiating or reinitiating. When it goes up, you can add basal insulin, and especially in type 2 patients. Another support from SPAD is that it is a good monitoring, a good tool for the diabetes progression. This was also supported by Endocrine Society guideline that especially in a child who is having hypothalamic obesity, when you treat with octreotide, it is well with your fasting glucose, combined with fasting glucose, HbA can be very useful in monitoring these children for treatment response. In Prader-Willi children with obesity, if you are prescribing recombinant growth hormone, HbA can also help you out in the monitoring of disease progression in these sort of children. This retrospective study in 300 patients showed, this is adult study, which takes 40 to 70 years old patients. HbA was shown to predict the coronary heart disease and future risk of coronary diseases also. This study also shows that long-term complication HbA can better predict, especially coronary heart disease and stroke in older children. HbA variability, if you see and put a nomogram, so if there is great HbA variability, so it predicts the it's an additional marker of your disease progression and complexity, and you can change the your management plan also. This study was published in Lancet. Average age was 70 years old, and this study will gives us light on the HbA predicting mortality in these patients also. We don't have data in children, but in older patients, HbA can predict the mortality also. So the conclusion in support of my part is that it's a point of care test. No hi-fi thing is required. You can do it. No fasting is required. It predicts well the insulin resistance. There is high specificity in diagnosing diabetes. And it also give you, it helps you to initiate treatment, especially metformin or insulin or combined therapy. It also gives you, it helps you in monitoring diabetes progression in these children. There is good correlation between HbA and BMI. So as the BMI, HbA increases, the chances of going the child into overweight and obesity increases. And thus there is increase in risk of diabetes and other complications. HbA variability, if you monitor in long term, it gives you idea about the long-term complications also. So thank you very much.
Thank you very much. I think you are a very decent player. You have just credited your product. You have not discredited your opponent. So the role of HbA1c in obese children and adolescents in terms of diabetes diagnosis and follow-up, I think you have given a very strong case. The point in favor include a point of care testing, good utility in terms of cutoffs to make a diagnosis of pre-diabetes and diabetes, convenience, non-fasting, more acceptable, more reproducible, and good use in the long-term management and prediction of the long-term health of the given child. So I think it has its own place. And the negativities of your opponent would be questionable reproducibility of OGTT. That would be a point in your favor. The need for fasting to do an OGTT, there is no need for a fasting. And that would result in a lesser testing rate, probably if you're screening in a large population. And the glycemic load to probably a well-established diabetes, when you give 75 grams of glucose, are you going to push him one step further towards osmotic symptoms? So these points would be to discredit your opponent. So the ball is out. So I request the opponent to come and market her product of his product of OGTT.
So thank you very much for having a debate for this important topic. So now I'm going to talk about OGTT for the pediatric obesity. So at the initial point of the time, might be the slides is looking like this. We have a balance between the OGTT and the HbA1c. But I do have an entire 8 to 9 minutes to convey all of you that how OGTT is superior. So I will start with the things that has been told by Pradeep sir, that in the ISPED guideline, it is mentioned that the gold standard for the even for the type 1 diabetes prediction is a OGTT, not HbA1c. And second talk, that how many of you are using the affiliate machines in your point of care settings? Yes, I'm also using. I know. We have to wait for to become 28 degree for the machines, and many times there is a strip failure is there. So it is a very costly therapy, and sometimes patient have to wait, and there is a lot of glitches with the point of the care machines. So, and I want to repeat my title for the discussions, that we are talking about the obesity, not for the full-blown type 2 diabetes, where everything is elevated. Here we have to pick up the dysglycemia. Why we want to pick up the dysglycemia? Because as you all of you know that there is a drastically increased rise in the type 2 diabetes due to the obesity, and always it has a silent progression. But in the silent progression, we may delay the diagnosis. If we delay the diagnosis, according to yesterday's talk of Dr. Saurabh, that nicely convey that it brings with all the kind of the complications like the microalbuminuria and the elevated blood pressures and the metabolic syndrome. And what is the reason? Everybody's are aware that type obesity in the pediatric obesity is 30-fold increasing since the 2 decades. So here why we require the gold standard or most effective test that predict the dysglycemia. So let's see the history. What is the history? Always, according to the history, the criteria was set on the glucose-based criteria rather than the HbA1c. If you are using the HbA1c model, then you are going to lose 3 times more patients with the undiagnosed type 2 diabetes. But when you use the glucose-based criteria, you are picking up more high-risk patients that at the time you can do intervention, you can ask for them to lose the weight, and you can have a reduce the complication. And that is proven by the various studies like Nihan's study that has been revealed that glucose-based criteria is very, very important in terms of the HbA1c. Let's start with the historical context with the OGTT. This is very nice paper, might be you all can see, that has been talked about the non-biased title that impaired blood glucose tolerance, why it is not a disease. And here they have shown nice correlations that type 2 diabetes or diabetes has a direct correlations with the cardiovascular disease. And those patients who has an impaired glucose tolerance test, they do have more atherosclerosis and the cardiovascular event. Let's see the another patients, another case. Here, those patients with impaired OGTT had a more cardiovascular and the atherosclerosis event. So first point I want to put that in my point that it is looking a little bit plus point in terms of the OGTT. So now see this the answering my second questions. What is the gold standard for diagnosing early dysglycemia in the pediatric age group? Let's see the history. What would be the gold standard? It would be the HOMA-IR or it would be the hyperinsulinemic patch. But how many of we are using in the clinical practice? Because it is expensive, it is time consuming. So we have to have one test that looks like similar to gold standard. And OGTT fits in this setting. How? Because you are stressing your pancreas. And by stressing the pancreas, you are seeing how much pancreas will work when you are giving 75 gram of the glucose. In that term, it is a fitting into the similar of the gold standard, and you can have all kind of the curve like monophasic, triphasic, and the biphasic curve. Why it is a near to gold standard? That has been proven by the Chinese study. In this study, you can see they have done in the 1,000 patients OGTT, they have seen the three types of the curve. One is a monophasic, there persistent rise in the glucose level. Second is a biphasic, and third is a triphasic. And what is their conclusion? According to their conclusion, those patients who has a monophasic curve, that has a more chances of the type 2 diabetes according to this status. So OGTT is not just a screenshot, it is a movie, while the HbA1c is looking like a screenshot of the past chronic disease. So it is looking up again plus points in my favor that OGTT is looking superior in this setting. Let's see according to the biochemistry. What is the HbA1c? It is glucose is binded with the hemoglobin. That means it takes 8 to 12 weeks to bind. So suppose if you are doing the HbA1c in that window periods, then might be you going to undiagnose those high risk type 2 diabetes patient. And according to screening guideline, we have to call them after the 1 year or the 3 years. So for the 1 year or the 3 year, we are missing the diagnosis of the type 2 diabetes. So it is looking somehow not great in these terms of the pediatric obesity or the pediatric diabetes. So let's see the risk of the misclassification. It depends upon your HB. In the pediatric setting, we are very, very aware about the anemia and the hemoglobin variants. So whenever we have a hemoglobin variants, we miss this kind of the diagnosis. And it is well proven. Here is a case that 32-year-old male was undiagnosed with the type 2 diabetes because of the hemolytic anemia. And in the pediatric settings, as a physicians and the pediatricians, we are not aware about what are the factors that can easily affect the HbA1c, and we are doing the HbA1c and we miss the diagnosis of the type 2 and the type 1 diabetes. Let's see the another case. Even genetic variants also going to cause the false negative HbA1c reports according to this study. So we are already knocking the door of the missing diagnosis. This is the very nice case that even Dapsone and aspirin hydroxyurea also can faltering your HbA1c level. This is the very nice paper that when are the HbA1c values are misleading. This is the case that patient 29-year-old was getting the suboptimal therapy for the type 2 diabetes, and when they came to the endocrinologist has done the urine ACR, and that time it was a microalbuminuria. So that means at the time of the complication, we know that falsely elevated negative HbA1c was due to the hemolytic anemia. So we are knocking the doors of the lower HbA1c. Let's ask the questions that how many HB variants we see in the clinical practice. It is 7 to 10%. That means if we are using the HbA1c cutoff, then we are going to miss 10% of those cases for the early dysglycemia. So again, it seems some negative points for the HbA1c in the diagnosis of the early dysglycemia. And if we are talking about the pediatric age group, Dr. Pradeep also has mentioned that it has a lower sensitivity. So if we want to diagnose more tests, then we have a higher sensitivity rather than the specificity. So it seems it has a lower sensitivity and threshold is too high. According to the ISPED guideline that Pradeep Sir has been published, in that also the HbA1c cutoff was always in the questions. So some guideline was talking about the 7, some guideline was talking about 6.3. So here the cutoff is also the questionable. So it seems that it is not great again in comparison of the OGTT. So what about the cost? So HbA1c is costing around 600 to 700 rupees in the Indian setting. And what is the cost of the OGTT? The cost is around 100 to 200 rupees. So it seems a cost-effective therapy, but the only negative draw point that I see with the OGTT is time-consuming. The patient have to wait for the 2 hour, but the waiting for the 2 hour is looking more effective because we can pick up the more high risk group, and we can have a more diagnosis of type 2 diabetes, where even the lifestyle modification will be important. So here it is looking again not superior in terms of the OGTT. And these are the cutoffs that has been ISPED has been published, and you all are aware about the criteria for the HbA1c. But when the HbA1c for the dysglycemia, the cutoff is varying. And this is the study of the Thai patients where HbA1c looks inferior in terms of the OGTT. And according to this meta-analysis, OGTT has the highest sensitivity in the specificity and depends upon the type of assay. HPLC is the most effective method to do the HbA1c, but it should be the NGSP trial. In India,
10 minutes up.
many HbA1c is not standardized by this assay. And this is my real life case scenario that because we have a HPLC in our setting, so we are diagnosis weekly, twice or 3 cases, monthly, 1 or 2 cases with the HB variant. So it looks tricky. If you are going for the HbA1c, it is looking simple, but when you enter, then you are into the patchy disease. So it is again looking the inferior in terms of the HbA1c. And if you see the polycystic ovary disease, and then in this study, it is very correlated that a higher BMI is more correlated with the impaired OGTT in comparison to the HbA1c. So again, it is not for the pediatric age group. So, and novel therapies for the glucose-based criteria is we are now emerging as a 1 hour threshold. That seems very promising result. So it can be used as a novel diagnosis therapy. In the conclusion, might be HbA1c would be the good test for monitoring and for the full-blown type 2 diabetes, but it seems the OGTT is more effective for the diagnosis of the dysglycemia. Thank you very much.
Yeah, I think you have very beautifully credited your product and discredited the opponent very well. I request the opponent to come and fight for himself.
Thank you, Dr. Manoj. As you rightly said, that a patient who is already having type 2, HbA is a better tool which gives you the idea about dysglycemia the child is having for last couple of months. So that I find very good in terms of monitoring the children with diabetes. It sort of gives also, it is also included in ISPAD and other guidelines that it gives you idea about pre-diabetes and child going into diabetes. I'm talking about obese children and non-obese children also. It's a very simple test that is very important. No long-term waiting time. Cost 100 versus 500, 700. I think it doesn't matter much, I believe. Yes, it has to be NGSP accredited test. So at any test, if you get it done, it doesn't give you any value. So the lab has to be proper. So that is these are the points in my view.
I think he was telling that your articles you quoted are mainly based on adult studies and children with diabetes, not a child with
As
obesity.
we know, sir, that diabetes, just an analogous example. When we teach children, this postgraduate students, that why do you get massive spleen in juvenile CML or Calazar? Because this doesn't kill the child. So it takes time, months. So spleen goes and goes increasing. When you talk about enteric fever, malaria, it is deadly if you don't treat. So even soft spleen is there, the child present with fever and chills. So analogously, in diabetes, it's a long-term disease. So this year the child had diabetes will not have nephropathy next year. Or a person who has been diagnosed in adolescent, the long-term complication itself will take long-term. So most of those complication studies will be in adults, will be in older people. So that is what I showed.
Thank you. Thank you very much. I think both the debaters gave their flavor. I think to sum it all up, both the tests have their own places. It's like a jigsaw puzzle. It's like a joint family. Every member of the family is important. Every test in this glycemic parameters are important. In terms of GTT, the strengths of the test would be cost effectivity, cost efficiency. It is indeed the gold standard for the diagnosis of diabetes. In the Indian Academy of Pediatrics 2023 guidelines, clearly dissuade the use of HbA1c. So GTT is a very important test in the diagnosis, and it has a good role in prediction of progression of complication, progression from pre-diabetes to diabetes and diabetes to if through further. In terms of cons of A1C, the problems would be the standardization, the racial differences, the cost, and of course, the poor role in predicting the progress from pre-diabetes to diabetes. In terms of HbA1c, it's a point of care test, convenience, comfortable, acceptable, reproducible. In terms of GTT, the cons would be the difficulty in maintaining of reproducibility, the need for fasting, and the glycemic load. So the ball is out. I think to sum it all up, the role of GTT in the diagnosis is cannot be questioned, and the role of HbA1c in follow-up and progression of the disease cannot be questioned. So both the tests are important in their own might. Thank you both the debaters for bringing out the true flavor in this debate.
I think just to add regarding HbA1c, we get a lot of referrals of HbA1c of obese children 5.7 to 6. That is something I think which we want to highlight, that figure is not really correct. There are ethnic differences, as Dr. Hemchand mentioned. So below 6, don't get too much cautioned about with HbA1c, because that's now everybody gets a lot of profile tests and everything, and then they're referred to us. Now we'll move to the next debate.
So may I call upon the next debater? The topic will be aromatase inhibitor versus testosterone in constitutional delay in growth and puberty. And to support AI, to support testosterone, we have got Dr. Arpita. So let's start.
Thank you so much, sir. Okay, so thank you so much, sir, for the kind invitation. And I'll be talking about why testosterone therapy is still the cornerstone treatment in CDGP. As we all know that CDGP is a benign condition, self-limiting, and we are not treating any pathology in this, and it greatly impacts the psychosocial development of the child, and therefore treatment is essential in a subset of individuals suffering from this psychosocial impact of this disorder. A word about the normal male pubertal physiology. We should be respecting the normal male pubertal physiology, and the treatment in CDGP should not disrupt the HPG axis adversely. So that thing should be kept in mind while treating these patients. When to intervene in such individual presenting to us with delayed puberty, the guidelines are in place that boys with no pubertal onset by 14 years or no progression with puberty STS less than -2 standard deviation should be evaluated and intervened. Early induction is vital not only to facilitate secondary sexual development, bone mass accrual, muscle development, but also the psychosocial adaptation which the child is having in the very important social phase of his life. So the clinical and therapeutic objectives of the treatment in CDGP should be focusing on promoting normal pubertal progression in terms of development of secondary sexual characteristic. Androgenic signs should be apparent. There should be increase in testicular volume. It should aim at achieving expected adult height, ensuring the psychosocial well-being, which is of primary importance while treating these individuals. And because we are treating a physiology and not a pathology, it should not have any adverse event and should be easy to use and the child should be compliant. When we look up at the current consensus and the guidelines by various societies, CDGP is still wait and watch policy for spontaneous puberty to occur, and sex hormone replacement is only initiated when the child is suffering from severe psychosocial issues. So the guidelines are in place and testosterone is still the cornerstone of treatment, whether intramuscular, transdermal, oral, subcutaneous, or intranasal, depending on the choice of the individual. A brief about the mechanism of action of testosterone. So we all know that it has direct androgen receptor stimulation, which causes immediate onset of secondary sexual characteristics, which in turn increases the serum IGF levels and promoting linear growth and growth velocity, which promotes skeletal maturation and thus triggering the GnRH pulse and giving a push which this child actually needs. Whereas the aromatase inhibitors, on other hand, is blocking an enzyme which is there in an individual, preventing the conversion of adrenal and testicular androgens to estrogen, decreasing the estrogen levels and increasing the androgen level, in turn, indirectly stimulating the HPG axis and potentially delaying the bone maturation while promoting the androgenic effects. But what we need to keep in mind that we are interfering with the normal physiology and basically blocking an enzyme, which is not only expressed in the testes, but also in the bones, vertebrae, in the prostate, as well as in the brain. We know about the endocrinal effect of these drugs, but there are various paracrine and autocrine effect of this enzyme, which we are uncertain of as of now. We all are familiar with the pharmacological effects and the safety profile of testosterone. It promotes the secondary sexual characteristics in an individual, which we are aiming at. It also increases moderate erythropoiesis. It has anti-inflammatory as well as vasodilatory effect. The long-term cardiovascular safety effect, which is questionable in testosterone, is dose dependent as proven with various adult studies and is not a factor which we are considering in CDGP where we are giving a short course. It also improves the lipid metabolism, insulin sensitivity, as well as the muscle and the mass ratio which we are aiming in the puberty. When we are looking at the evidence comparing testosterone directly with the AI in CDGP, it was a landmark study which was published in Lancet in 2020, where they directly compared aromatase inhibitors with the testosterone. However, the sample size was limited with 15 individuals in each group, and they followed these individuals in Finland over a 6 months period of time. And as you can see with the letrozole group, which is shown in the red, there's a spike in LH, FSH, testosterone, and inhibin levels with the letrozole group compared with the testosterone. However, at 6 months data, these effects are nullified essentially. When we look at the serum IGF levels and estradiol, there was consistent increase with the testosterone in comparison. So the serum IGF level is increased in the testosterone group, whereas it was reduced in the letrozole group or the aromatase inhibitor, which is expected. So we can infer that letrozole leads to hormonal volatility with spikes in LH, FSH, and testosterone and causes significant estradiol suppression, raising concerns about the bone health and long-term safety, whereas testosterone, on the other hand, induces a stable physiological hormone profile with controlled LH, FSH, and estradiol levels. In the same study, they showed that there was a sharp increase in the testicular volume over a short period of time when compared to the testosterone group. There was increase in the growth velocity in the testosterone group. They also looked at the data on the bone mineral density. However, the study was not powered to look at this, and it was a short-term study over 6 months. So we have to infer this with a pinch of salt. The adverse events were also comparable in the two groups. So we can say that letrozole shows slight advantage in predicted adult height in the aromatase inhibitor group, and there was an increase in testicular volume, but we are not sure about the long-term benefit and the uncertain safety data with this study. Whereas testosterone ensures faster growth velocity, psychosocial improvement, and more predictable hormonal profile. When we are looking at the systematic review, I just came across one systematic review which was recently published, comparing seeing the efficacy and safety of letrozole in the management of CDGP. However, it included just a handful of 7 studies. They looked at the predictive adult height when they were comparing the predicted adult height in the letrozole group with the active control group. The effect was comparable. However, the predicted adult height was better when they compared with the placebo group. Testicular volume was seen increased in the letrozole group compared with both active and the placebo control group. Bone age progression was delayed in the letrozole group, both in these groups as expected. So aromatase inhibitors offers modest predictive adult height advantage, which was clinically insignificant according to this data. It enhances the testicular growth with delayed bone age maturation. However, the clinical difference versus the testosterone was small and long-term safety data is lacking. In the same systematic review, they also compared the endocrine fluctuations with the letrozole group, which shows that letrozole induces a transient surge in the LH, FSH, and testosterone. However, these hormonal fluctuations, when we look at the 12-month data, was lost. So no sustained endocrine advantage was seen with AI versus testosterone. They looked at the adverse events also, so they were comparable in the two groups. However, with the letrozole group, there was a statistically significant reduction in the HDL cholesterol, raising potentially long-term cardiovascular safety concerns when we are using this drug. Lessons from nature, we all know that aromatase deficiency in males have been reported in so many studies that it causes bone issues with recurrent bone fractures, osteopenia, and fertility issues. So basically what we are trying to do with AI is inducing aromatase deficiency in these individuals, which I believe should not be done. We should not be disturbing the normal physiology. Prolonged estrogen suppression may carry unintended systematic reviews risks, which we are not sure of at this moment. We have been using the testosterone for long, and we are sure with the long-term safety and efficacy of this drug. So to summarize, testosterone versus AI, the bone health, there is established safety profile with testosterone, whereas with AI, there is delayed epiphyseal closure. Psychosocial impact is positive with testosterone. Side effects are more with the AI in the form of spinal deformity, lipid abnormalities, effect on growth velocity. There is robust gain in pubertal onset and height velocity with testosterone. However, there was moderate gain in AI, which was statistically insignificant. Effect on predictive adult height was also comparable between the two groups. Fertility issues are there with AI. Endocrinal hormonal profile, there are sharp spikes, whereas it is predictable with testosterone. Lipid profile, there's a concern with the AI. So to summarize my presentation and to put forward testosterone as the gold standard for CDGP because it induces timely pubertal progression and growth acceleration. Predictable hormonal and skeletal maturation is done with it, and there are proven psychosocial and emotional benefits. Whereas AI is still experimental off-label tool. It is a new kid on the block, but we have to have some long-term safety data to start prescribing this drug in CDGP. So the clinical position as of now is that it is a normal physiology. We have to ensure safety, emotional well-being, and physiological mimicry, which is achieved by testosterone. So in my opinion, testosterone still seems rational, evidence-based, and ethically responsible choice for CDGP. Thank you.
Your last slide really summed it up so beautifully, the pros and cons of the testosterone. To credit your product, it's a old and gold, time tested, better efficacy in terms of the short-term well-being of the child, in terms of perceived symptoms, and improved growth in terms of IGF response. And of course, the array of side effects ranging from vertebral morphological changes, impact on spermatogenesis, impact on HDL in terms of, and the note about predicted adult height. If you see in the meta-analysis, you have a heterogeneous study group with varied bone age techniques and with varied height prediction equations, really not justifying that a quantum of increase of 2 to 4 centimeters in terms of, unless these people follow them up till they reach the adult height. You have made your opponent's job very difficult. I request.
It just underscored the importance of a conventional treatment. So whether treatment is needed in a physiologic condition, that is the first thing. And if you need, don't disturb the child. That is the importance of the testosterone therapy for a short period. So I think we can see what the opponent tells.
Dr. Manoj is a busy person today. Yeah, so this presentation is made by Dr. Sajili. So I think if there are much debate points, Manoj will be here to flip on.
Thank you very much, sir, for giving me presentation of the Dr. Sajili, madam. Because of her health issue, she couldn't join us. So it is well said point, and I would like to thanks to Arpita, madam, for setting a stage for me. What stage? That it in her last conclusion slide, it has been mentioned that according to that Lancet data, that in the CDGP, we have a height gain of the 2.1 centimeter, I think. So again, I want to repeat my title. We are talking about the constitutional delay in the delay in the growth and puberty. So that means by using the aromatase deficiency, we are in the gain of 2.1 centimeter in comparison of the testosterone. So let's start with the physiology. How physiology start? So puberty starts when the GnRH pulses is coming from the hypothalamus to the pituitary. It reaches to the testis and it produces the testosterone. That testosterone has to convert it into the estrogen for the ossifications. And the CDGP in the CDGP especially, there is a delay in this pulsatile manner of the FSH and LH. So ideally, the treatment would be the giving the FSH and LH in the pulsatile manner, but we are giving the testosterone for the short, because of the short durations of the of that pathology. So we are giving the testosterone outside. That testosterone will convert into the estrogen and it can cause the bone maturations. So if we are giving the testosterone, then might be we are delaying the growth velocity and might be the final height would be the questionable. So but estrogen is more important in the both sexes, but in the pubertal role is little bit the questionable for the 6 months of the time. So what is the expectations for the ideal treatment for the CDGP? We have to promote the androgenic signs of the puberty and the testicular growth. Let's talk about the testosterone, that it convert into the estrogen. So height will be delayed and many of the patients may have a side effect of the gynecomastia in the clinical setting. It should be increase the height and the lean mass gain. Testosterone and aromatase both do this kind of the effect, and it has to minimize the epiphyseal maturation because at the end of the day, height matters for the pediatric populations. So we have to look for the not only for the delay in the puberty, but always we have to look for the delay in the growth also. So since many years we are prescribing testosterone, and I also do in my clinical practice, it increase the IGF-1 level. It convert the testosterone into the estrogen, and it can cause the growth velocity. But the mainstay for the pediatric patients, what is the main stopping point for using testosterone injection? It is an injectable, long needle with the depot injections. With the pediatric patient, you have to hold and you have to give. And every month that patient has to come. So we have to explore the new modality of treatment. And that debate has been started widely after the Lancet paper that Arpita madam has been published. So I also quote that paper only. You can see in the comparison of the testosterone group, the serum LH was more high in letrozole group. That means it can mimic the natural LH and FSH surge. And if you see the serum testosterone level, it has been high in comparison to the letrozole group. And if you talk about the serum estradiol, then it would be low in comparison to the testosterone group. And at the end of the day, if you are treating with the testosterone, then your testicular volume will be high. How? Because we are blocking the estrogen. So estrogen will give the positive feedback to the LH and FSH, and FSH will increase the testicular volume. So anyhow, we are mimicking the natural kind of the puberty. So letrozole might be feasible, that can be given by the oral route in comparison of the injectable testosterone that is available in oily depot form. So, and we have a high testicular volume, and we will have a high growth velocity. This is the another paper that has been published by the comparison of the adult aromatase inhibitor in the CDGP in terms of the height gain. According to this paper, estrogen action is inhibited in the growing adolescent, and we will have a increased height gain if we are using the aromatase inhibitor. And this is the randomized trial that not from the puberty perspective, but from the height gain perspective, if in the delayed puberty or with the growth hormone deficiency, if we are using the aromatase inhibitor, then total height gain will be more in comparison to the only growth hormone therapy. So it is not like that it is not well studied, but in the growth hormone perspective, aromatase inhibitor is well studied for the more height gain. So this is the another paper, systemic analysis, that I think Dr. Arpita madam has been talked about. Here I want to highlight this two group, risk with the control and with the letrozole therapy. We have a 2.21 centimeter higher gain of the predicted adult height. And there is a larger testicular volume, 3.6 ml at the initial point, and the side effect is lower than in comparison to the testosterone therapy. I know it is a new kits in the market, but we always have to explore the newer options, which is available in the oral setting. Let's compare the two data. In the testosterone will be the gold standard, yes, because it is well studied. But if you are dealing with the very short height, and that perspective, aromatase inhibitor would be the good options, I must say. And risk and the side effect would be still questionable from the aromatase inhibitor perspective. But we have to treat not only delayed puberty, but we have to delay the delayed puberty and the growth issue as well as. Thank you very much.
Thank you so much. You brought out the story of the rabbit and the tortoise, testosterone being the story of the rabbit, but if you use aromatase inhibitors, you give a long-term well-being for the child. I think that is the key message, and you are probably the tortoise and your opponent is the rabbit. The pros of testosterone, pros of aromatase inhibitors include the benefit in terms of the testicular volume, in terms of the long-term height of the child and delaying of the epiphyseal fusion, and the impact on the HPG axis. And of course, the initial modifications of the HPG and the concerns around that were very beautifully summarized. Thank you very much. I request your opponent to bounce back.
So I want to ask the audience, when a CDGP child comes to us in the office, what's the primary concern? Is it the height or it's the development of secondary sexual characteristics? So height is not a very major concern in these children. It is the development of secondary sexual characteristics, which is achieved in testosterone group quite well. Aromatase inhibitors, it is a new therapy and it is looking promising, but unless long-term safety data and even the dose titration studies are also not in place. So we should be careful while using it and not prescribing it. Also, the rapid testicular volume development, is it physiological? Is it doing harm with the spermatogenesis, exposing the testis to such high level of testosterone? We don't know. So I rest my case in support of testosterone unless we have certain data, certain promising studies. I will be not prescribing AI in CDGP and still prescribing testosterone. Thank you.
But to audience, what is your opinion? Single answer.
And even
No
the
doubt.
height, even the height increment was like 2.1 centimeters, which is, I think it was non-significant in the paper also, and 2.1 centimeters insignificant in comparison.
Thank you so much. I think we are looking at manipulating the HPG axis in a normal child. I think sir very beautifully said CDGP is a normal child and we are manipulating the HPG axis by the two forms of treatment. So in ideal world, we need something that is safe, that improves the testicular volumes, that causes features of hyperandrogenism, improves the short-term growth, improves the long-term final height, and very importantly, looks into the psychological properties and the lean mass of these individuals when followed up to a long run, for which we don't have a clear answer. At this point of time, testosterone scores slightly over aromatase inhibitors. Probably the conclusion for this debate could change with more evidences and more points.
I think the biggest issue with aromatase inhibitors is the bone health. So the original people who started this work, Dunkel's group and all who started on that in CDGP, they always say that it has to be combined with the anabolic therapy. So either with growth hormone or even with testosterone. So this simple concept of giving just aromatase inhibitors is going to be very difficult to explain. I had done a preclinical study in a rat model earlier in the same age group, and we found that there was adverse effects on bone health in rats, which were treated in the peripubertal period with aromatase inhibitors. So, and that concern is there are vertebral anomalies, which you mentioned with aromatase inhibitor. So if you're thinking of giving growth hormone along with aromatase inhibitor, testosterone with aromatase inhibitor, that is the sort of a thing. And the issue of temporary increase in testicular volume is of no consequence from a long-term perspective. It is artificially increasing. So I would definitely, we have to wait for longer term, but a lot of people are in fact talking now about this. That's why we thought this debate becomes very important. Thanks to both of you. And I think it's been a wonderful session, morning session, and we've got great debate coming up and a lot of inputs from the chairpersons, Dr. Hemchand, Dr. Hari, and Dr. Vijay. Thanks all of you. And thanks a lot. And we'll now be moving to the next session.
Thank you, sir. Our next session is a ground round, and it's on bone and calcium disorders. I would like to invite Dr. Hemchand, sir, Dr. Vibha, ma'am, Dr. Vijay Jaswal, sir, as expert for this session.
And Dr. Manoj as well.
And Dr. Manoj as well. A speaker for this session will be Dr. Anurag, sir. I request sir to start with the presentation. Bone and calcium.
So thanks a lot, Dr. Sandeep. And And so this again is going to be a very interesting grand round in which we are trying to cover a lot in the next 45 minutes to 1 hour about bone and calcium. And we have kept Dr. Hemchand captive. He's here. And Manoj also is here because Dr. Sajali had a problem, so she couldn't make it for this session. So we'll talk about key aspects. We'll talk about 3 major aspects: impaired PTH effect, increased PTH effect, and low bone mass. We had a wonderful discussion yesterday. Dr. Hemchand talked about how to assess bone density, correct it for height, correct it for bone age and other parameters. So we'll try to talk those things forward. So impaired PTH effect, of course, is an important endocrine cause of hypocalcemia. It can be because of a problem in PTH, which may be genetic. Now, there are multiple disorders. We won't go into precisely those disorders. It can be syndromic. And one thing which you should remember is DiGeorge syndrome, which is extremely important from that perspective. So DiGeorge syndrome would be something which is there to be looked into, especially if you have a young child who presents to us with impaired PTH effect. In that regards, DiGeorge syndrome becomes an important differential from that perspective. Later onset in the childhood, the first possibility will be autoimmune, APES1, and we discussed about immune endocrinopathy a lot yesterday. Then there could be a problem in the sensing of calcium. The classical example is the calcium sensing receptor defect, in which you have hypocalcemia with hypercalciuria. Body thinks that there's a lot of calcium in the body. So that condition would be there. And then you can have a PTH resistance. Very rare is Bloom-Strand, a lethal disorder. More commonly, pseudo-hypoparathyroidism with multiple endocrine abnormalities and other rarer forms in that regards. Now, in impaired PTH effect, the hallmark is hypocalcemia with high phosphorus. So everybody who has hypocalcemia should have low phosphorus. If your phosphorus is high, that is an impaired PTH effect which is there. You should also have a normal creatinine, magnesium, and vitamin D. So before you label somebody as a PTH problem, look at vitamin D, creatinine, and magnesium before you make that diagnosis in that regards. They can present to you with coarse skin, problems in teeth, hair problems, intracranial calcification. Most neurologists that refer to us with hypocalcemia also actually do that when they find an intracranial calcification in that regards. Cataract, intracranial hypertension, and increased bone mass may be there. Very importantly, we expect that if the calcium level is low, PTH should be sky high, at least above 70. So if your calcium is low and PTH is high, this is a pseudo-hypoparathyroidism or a secondary hyperparathyroidism. But if PTH is less than 70, that is normal PTH, you have to think of hypoparathyroidism as a possibility. So we are talking about high phosphorus, normal creatinine. Then we are talking about a PTH problem. And there, if PTH is low and you exclude hypomagnesemia as an important cause, do a urinary calcium. If it is high, it is a calcium sensing receptor defect. If it's normal, it is hypoparathyroidism. While if the PTH levels are high, it is most likely pseudo-hypoparathyroidism. Always do vitamin D levels before diagnosing PHP, because vitamin D deficiency can induce secondary resistance to PTH. And in that regard, if the AHO phenotype is not there, this is probably 1B. If it is there, do a cyclic AMP response, which is a theoretical test to look at from that perspective. Now, management, we had a big discussion today about whether PTH is better or calcitriol is better. But generally speaking, we'll talk about calcium 30 to 50 milligram per kg per day and giving calcitriol around 15 to 30 nanogram per kg per day. And we have to worry about that there will be a risk of hypercalciuria in the setting of hypoparathyroidism. Pseudo-hypoparathyroidism, the PTH effect on the kidneys is preserved. So this hypercalciuria usually does not occur. And the options are clearly in the form of PTH from that perspective, which are there. And as I said, PHP, we are not that much worried about those scenarios from that perspective. So what are our targets? For hypoparathyroidism, we want the calcium on the low normal range. Don't want to keep it very high. So what we need to understand is that PHP, we are worried more of skeletal problems. Hypercalciuria is rare. So we can keep it at the higher level, 9.5 to 10. While hypoparathyroidism, we are worried about hypercalciuria. We don't want the calcium to go up 8.5 to 9. One unique condition is a calcium sensing receptor defect, which Dr. Manisha did mention about, that if you have that, you will have hypercalciuria at a very, very low level. So in that case, you want the calcium levels to be much low. and may be considered PTH right at the beginning in those cases because they will develop hypercalciuria, whatever you do. So in that perspective, we'll now start with the scenarios.
Thank you, sir. So we have the first case. It's a 4-year-old girl. She had tetany and the ionic calcium was 3.1 milligram per deciliter. The phosphorus was on the higher side, 8.4. PTH was 130 and she was labeled as pseudo hypoparathyroidism. So my question is to Dr. Vijay, what will be the approach, sir?
Yeah. So that is for sure that this child is having tetany with very low ionic calcium level. And you have mentioned that phosphate level is high and PTH is also high. So before labeling pseudo-hypoparathyroidism, I would like to see other parameters, what Dr. Anurag has already told you, that what is the status of kidney. So I would like to see the creatinine level, and now you have pointed out that it is a high creatinine condition along with hyperphosphatemia. So before labeling this will be probably a case of CKD which is turning like this type of thing. So that is really very important to understand.
Thank you, sir. As rightly brought out by you, we should always look for creatinine before labeling as pseudo-hypoparathyroidism. So renal failure is the important cause of creatinine with high phosphorus, and we should always do a serum creat before labeling for pseudo-hypoparathyroidism. So next case, 3-month-old girl, she had seizures. Ionic calcium was 3.2 milligram per deciliter. Phosphorus was 2.2, low. PTH was very low, 3.4. And she was labeled as hypoparathyroidism. So Dr. Hemchand, sir, what did you say?
I think serum phosphorus is an important game changer in the assessment of children who have hypocalcemia. Children who have parathyroid hormone deficiency usually have an elevated phosphorus level, and children who have vitamin D deficiency or vitamin D axis related disorders have a low phosphorus. In the setting of the laboratory assays, a low phosphorus puts the card more in favor of a vitamin D related axis related disorder rather than the PTH axis. I would take this PTH with a pinch of salt and look at pre-analytical and laboratory related issues to look at whether something is causing an artifact and influencing the PTH report. So this case highlights the importance of a close association with the lab, discussion with the lab technicians on the proper tube to collect a PTH sample, the importance of maintaining the temperature while transporting it, and the benefit of having an in-house laboratory to measure PTH to arrive at a proper diagnosis. In this child, this was probably related to an incorrect collection sample and transfer to the lab. So the PTH was probably repeated in another center and it was found to be elevated. So I think a low vitamin D matches well with a low phosphorus rather than a low PTH.
I think this is very common when we send the PTH to a collection center or people take it from home and then they don't even freeze it. They just send it right away. The PTH will invariably be low. So whenever you are sending a PTH, send to the hospital rather than taking the sample at home or at a collection center, because it should be done immediately. Very, very important point. Otherwise, the diagnosis will be really confusing as PTH is highly thermolabile.
So as correctly brought out, low phosphorus is against hypoparathyroidism, and being PTH being a thermolabile has to be collected in ice and has to be processed immediately. So next question, 7-year-old girl with tetany, calcium is low, 5.4, phosphorus is 7.7, creat is 0.8, PTH is low, which is 15, which is low normal.
So Dr. Manoj, the PTH is normal actually. So what do you think?
If you wish to diagnose PTH issue, then you don't have to see the calcium, you have to see the phosphorus, as Hemchand sir has told. Here, the phosphorus is very high with the hypocalcemia. So that means it is directing towards the PTH defect. And what is the PTH? It is in normal range, but here normal is abnormal. So here we have to see in the context. So here I would say the diagnosis would be most likely hypoparathyroidism, because the PTH is not elevated in comparison to the hypocalcemia and the hyperphosphatemia.
Thank you very much, sir. So it's a case of hypoparathyroidism, and we should always interpret PTH with the context of calcium levels. Normal PTH with normal calcium suggests hypoparathyroidism.
So PTH should at least be 70. So when we say if FT4 is low, TSH should be more than 20. If the cortisol is low, ACTH should be more than 200. If calcium is low, PTH should be above 70. Always interpret, if there is hypoglycemia, insulin should be indetectable. So endocrinology is all about contextual evaluation. That is important.
1 week old boy had seizures, ionic calcium is low 2.4, phosphorus is 9.1, creat is normal 0.3, PTH is very low. So Dr. Viva,
If we look the case scenario here, the phosphate is high and calcium is low, and PTH is also low. Creatinine. Biochemical picture goes in the favor of hypoparathyroidism, but this is very early presentation to we have to think some genetic causes those present very early because it couldn't be due to any like autoimmune or a vitamin E deficiency. So as you have mentioned that the in the this echo, it presented with the truncus arteriosus. So definitely it is a presentation of D-George. And it is said that if you have this defect in the calcium, that also go for the X-ray to look for the thymic shadow, to look for the echo, to look any cardiac abnormality, because it is we miss it and we look the calcium only, and we can miss this this major pathology.
And the TLC was also very, very low in this case. And this is a very, very difficult scenario. In fact, this child presented with sepsis and it was very difficult to salvage this child because of severe infection. So hypocalcemia may be the only suggestion that this could be a DiGeorge syndrome in this scenario.
so DiGeorge syndrome, it is an early onset hypoparathyroidism. A cardiac evaluation and immune assessment has to be done. 3-year-old boy had seizures. Ionic calcium is 3.1 milligram per deciliter. Phosphorus is high, 7.8. Creat is 0.5. And this is the clinical picture of oral cavity. PTH is low. So Dr. Hemchand sir, what is your diagnosis based on the clinical and lab parameters?
I think the writing is on the wall. You're looking at a symptomatic hypocalcemia and an inappropriate rise in the phosphorus, pinning the cause on PTH, which is matching with the low PTH, inappropriately normal PTH, I would say, for the degree of hypocalcemia. And hypoparathyroidism is a tip of the iceberg. The underlying cause for hypoparathyroidism has to be thought of in the interest of the long-term health of the child. And here the vital clue is the presence of mucocutaneous candidiasis, which the onset is early, and this hypoparathyroidism puts the diagnosis of a polyendocrine syndrome on the cards highly likely. So this thought process is very important to initiate, because you really have so many things to look forward in the future in terms of evolution of children to develop transaminitis, to develop adrenal insufficiency, to develop gut-related problems, etc. So I think the diagnosis which I would like to consider is an autoimmune polyendocrine syndrome, and I would like to look into this child further for any other associations which is described usually in this particular syndrome as depicted here.
I think the very important differences that are there in terms of hypoparathyroid management here compared to a classical case of idiopathic is that they require much higher doses of calcitriol because malabsorption is pretty common. And this candidiasis is not a benign thing. You have to keep on treating it. Otherwise, they will develop oral Haley leukoplakia, resulting in malignancy later on in that perspective. And of course, the one thing which we are always worried about, the elephant in the house, will be adrenal insufficiency, which will happen in most cases by around 5 to 10, according to me. But this mentions 10 to 20 years. This is based upon overall studies.
So on follow-up, the patient was labeled as APES 1. Patient had abdominal pain, polyuria, and high calcium. Calcium was gradually tapered and then stopped. Patient presently have normal calcium. So Dr. Vijay, he was managed with calcitriol. So what could have been the reason for his stopping of calcium?
Yeah, thank you. Because this was the patient who was presented with initially this hypocalcemia and other things, and we have started Apart from that, since we are talking about immune endocrinopathy, that is multiple APS, autoimmune polyglandular syndrome. So in this syndrome, what is going to happen that all the things what we know that they are not going to present at the same time. So it is very important we have to be very vigilant that evolving endocrinopathy. So I would like to see that whether the patient is now developing apart from candidiasis and hypoparathyroidism, whether Addison's disease, that is cortisol deficiency. So the first thing that we have to look for electrolytes and cortisol level, and correctly pointed out, so cortisol bit low. So what I am expecting that this patient is going to have has evolved now this cortisol deficiency too.
So cortisol is basically a hypocalcemic hormone. If you have cortisol deficiency, hypercalcemia will happen. So if you have hypoparathyroidism plus adrenal insufficiency, hypocalcemia plus hypercalcemia becomes 0. So this is a very nicely pointed out by Dr. Vijay in that regards.
On follow-up, this patient was on calcium 30 mg per kg, calcitriol 30 nanogram per kg per day. Calcium levels were 9.8 mg per deciliter. Urine calcium creatine ratio was 0.4 mg per mg. Ultrasound was suggestive of nephrocalcinosis.
So what will you do, Dr. Vijay, in this case?
So obviously the culprit that we have to now reduce the calcitriol, as well as probably for a short time we can stop calcium or we can reduce the dose of calcium. So and we have to follow up.
Yeah, so the target level, you think it's much higher than what we
Yes.
want in this case. Yeah.
And also thiazides were started due to hypercalciuria.
This may be a point at which PTH may be considered, that if you have fluctuating course nephrocalcinosis already there, renal dysfunction already there, we may consider PTH. The one case in which we started PTH was in adult who had a very fluctuating course that was not improving at all. So it has role in certain reserved situations.
So this was case of APS1 with hypoparathyroidism and cortisol deficiency. We should always consider APS1 as a case in which a child had hypoparathyroidism in childhood. Mucocutaneous candidiasis gives a clue. It's the early presentation. Hypercalcemia usually due to the simultaneous manifestation of adrenal insufficiency, and we should set a low calcium target to prevent hypercalciuria and nephrocalcinosis.
So just a message that if you have a clear-cut case of neonatal hypoparathyroidism, this is considered DiGeorge unless proven otherwise. If you have an acquired hypoparathyroidism, consider APS1 unless proven otherwise. Which diagnostic test will give you a clue for APS1?
So APS1, we have interferon antibodies, sir, which are diagnostic.
So these are the very highly sensitive specific for the diagnosis there.
Thank you, sir. Next case, 10-year-old boy had seizures, low ionic calcium 3.1 milligram per deciliter. This is the clinical picture of that child. He had cataract and there are subcutaneous lesions and MRI suggestive of multiple calcification. CT suggestive of multiple calcification in the brain parenchyma. So Dr. Manoj?
Yeah, so here a case is speaking by itself. Here we have a hypocalcemia with subcapsular cataract, subcutaneous calcification in the MRI in the basal ganglia. You are seeing the calcification. So this is the case of the hypoparathyroidism with the ectopic calcification. Now we have to see what kind of the hypoparathyroidism it is. Is it pseudo or is it true? So first of all, here the phosphorus is a mainstay that is guiding towards the hypoparathyroidism. We have to do the creatinine, but in this favor, pseudo hypoparathyroidism is looking more prominent here. So I would like to know the value of the PTH.
This patient also had brachymetacarpia.
Yeah.
The PTH level was 200.
Yeah, so it is guiding us towards our diagnosis of the hypoparathyroidism, and the brachymetacarpia is the main pathognomic features for the pseudo hypoparathyroidism and the Turner syndrome.
Very importantly for PHP, the features are milder because the PTH is acting through multiple pathways, not just the cyclic AMP pathway. In PHP, only that pathway is affected. So PHP is always milder, does not usually present very early. So if you have an early onset hypocalcemia with hyperphosphatemia, there are other causes, not PHP. This is the most common type of presentation, mildish hypercalcemia, hypocalcemia, but calcification will be very, very prominent here. What other endocrine investigations you will consider, Dr. Manoj, in this case?
So here they might associated with the TSH resistance. So we have to do the thyroid profile. In some case of the pseudohypothyroidism, they do have an abnormality in terms of the pituitary also. So we have to look for the obesity, TSH resistance, and the pituitary hormonal abnormality. And skeletal dysplasia also main the some present in some of the cases. So we have to rule out it.
So Dr. Hemchand, do you have experience of severe obesity with pseudohypoparathyroidism?
I think, no, sir.
Okay, so we have had, and that is a very interesting presentation. So sometimes they may present, so 1-year-old child presented with hyperphagia, rapid weight gain, mildly elevated TSH. So people thought it is hypothyroidism, but TSH was like 8. And then calcium, everything was normal, only PTH was elevated. So this could be a presentation because the MC4R also acts with the GNAS pathway. So they behave like that. And theoretically, they may respond to set melanocytes. So this is something which is known. And we always say short stature with obesity, hypothyroidism, pseudohypoparathyroidism becomes a differential Cushing. So that is there, but they may present with early onset. Calcium may be normal. So don't just rely that calcium is normal in the first year. Does not mean that this cannot be PHP.
So the calcium targets, we can set a normal calcium
So
target.
Dr. Manoj, what will be the calcium target?
Yeah, here PTH effect is preserved in the kidney perspective. So here if we want to target the calcium, then it would be little bit higher than the hypoparathyroidism because there will be no nephrocalcinosis unless and until we are giving with a very higher dose.
Thank you, sir. So this was a case of pseudohypoparathyroidism, hypocalcemia with high phosphorus. They have round faces and other clinical manifestations like brachymetacarpia. We can set a higher calcium targets than hypoparathyroidism because the PTH effect is preserved on the kidneys.
And in fact, sometimes they present to us with query refractory rickets like presentation also, because the PTH is increasing the calcium resorption. There, if you maintain calcium around 9.5, they will resolve very quickly. So again, PHP is a masquerader, which will be there. Hypocalcemia with high phosphorus, rickets with high phosphorus. Two things where PHP should be considered. Now we'll move forward quickly towards the increased PTH effect, which basically is most commonly because of hyperparathyroidism, which can be isolated. More importantly, because of the calcium sensing receptor defect, in which you have hypercalcemia with hypocalciuria, the opposite. So the body is not sensing calcium. Older children, men associations, typically men 1 in the second decade of life, very rare. And then you can have sporadic hyperparathyroidism. There could also be a sensing defect, which we discussed, and very rarely sensitization. So the major problem is in the parathyroid. Unlike pseudohypoparathyroidism, others are rare. McEwen-Albright syndrome can sometimes cause hypercalcemia. So when should you suspect hypercalcemia? Sick neonate with dehydration, anybody with polyuria, hypotonia, encephalopathy, calcium should be done. Abdominal pain in older children. So we all talk about moan, groan, and body pain. So these are the typical manifestation for adults with hyperparathyroidism. So abdominal pain, hypertension because of calcium effect, and ectopic calcification. Metabolic bone disease or bone resorption can also be there. So again, we are thinking of hypercalcemia with hypophosphatemia. So PTH is high. Very importantly, most patients who are referred to us with hyperparathyroidism are secondary. They are not primary, and sometimes it may cause confusion. You should have a normal creatinine, vitamin D, and rule out treated hypophosphatemic rickets. Again, I said that if the calcium levels are high, PTH should be undetectable. So if your PTH is more than 20 in somebody with hypercalcemia, that means it is hyperparathyroidism. While if the PTH is normal, this could be a calcium sensing receptor defect. So when we talk about hypercalcemia, PTH below 20, PTH above 20, we have to think of these things. PTH below 20, vitamin D related causes. So we are talking about this arm. Then you look at the fractional excretion of calcium. If it's more than 2%, this is classically hyperparathyroidism. If it is less than 1%, look at vitamin D, because vitamin D deficiency may mask your hypercalciuria. If vitamin D is normal and yet you are not excreting, this is familiar hypercalcemic hypocalciuria. While if it is in between, again, you give a course of vitamin D. Now, most cases that we see have a normal calcium, low phosphorus, high PTH, and a low level of urinary calcium. In that case, if vitamin D is low, you give a course, small dose of vitamin D for a month or two, and then see what happens to the calcium and PTH, and your diagnosis will be made. So this is something which is very, very important from that perspective. Now, what should be done? So, of course, if it is a adenoma, in most cases, you can do a resection. But remember, in young individuals below the age of 30 years, multifocality is common. So getting a scan and seeing one adenoma removing may not be the true. You have to consider for a larger surgery in that regard. Men one, clearly you have to remove. It's a very aggressive disease. Neonatal severe hyperparathyroidism, the most severe form, requires complete parathyroid removal and some autotransplantation. Men 2 is a milder form as far as the parathyroid is concerned. It is aggressive for adrenal, aggressive for thyroid, but then you just remove the part of it that becomes important. And carcinoma is a very, very rare thing. Think if the calcium levels are sky high, PTH is in hundreds, and there is a firm mass, then of course you have to manage that way in that perspective. So we'll start off with the cases, Dr.
So
Sandeep.
we have next case, 12 days old girl. She had irritability, dehydration. The serum calcium levels were very high, 18 milligram per deciliter. PTH was 300. Dr. Biba, what can be the possible diagnosis?
What is the phosphate value?
Phosphate is low.
Okay, so low phosphate, high calcium, and high PTH with a clinical feature of dehydration and irritability, giving us a clear diagnosis of hyperparathyroidism or increased PTH. Now, coming to the main important part is what is the fractional excretion to further confirm the diagnosis. So,
And if you consider it this age group, what do you think? A 12-day-old child?
so 12-year-old child.
12 day.
12 day. Then this more of a hyperparathyroidism because vitamin D deficiency won't cause this.
So this age group is extreme and the calcium is very high. So this is the most dreaded complication, most likely neonatal severe hyperparathyroidism. And urinary calcium to creatinine, Dr. Sandeep, was
It was
0.3.
0.3.
So in neonates, it may not be that high. So for that level of calcium, it's not high. So what are we thinking of?
Definitely, sir, neonatal severe hyperparathyroidism in this case. And in this case, we have to ask for the family, what is the calcium and the urine calcium. So as
Both parents had high calcium levels and low urinary calcium.
Definitely, this is homozygous
Yes.
neonatal severe hypophosphatemia. The important thing in this is the management part because this is they present with a hypercalcemic crisis, and here we start with the saline diuresis with the 5 to 10 milligram per kg of furosemide along with the this 0.9% of saline, that is 10 to 100 ml per kg. And the second option, we have a pimidone, or we can use zoledronic as well with a low dose like 0.01 to 5 milligram per kg along with the paracetamol dose. And other options we have like this salmon calcitonin, calcitonin, which is given in this nasal puff. This is 5 to 10 microgram per kg per 12 hourly, but due to tachyphylaxis, it is not being very much used. Another very interesting thing we have is the cinacalcet. It is basically, it allostically modified the calcium sensing receptor and increases the binding of calcium to the calcium sensing receptor. In this way, decreases the calcium. So, and the next is the prednisolone. It inhibits the conversion of this activated vitamin D. So it decreases the absorption of calcium from the intestine as well as from the kidney. So these are the various options, and this has to be this case has to be managed very aggressively because otherwise we can lose the.
So this is the most serious complication, probably endocrine emergency, I would say. We talk about DKA, we talk about hypoglycemia. They're much more easier to manage. This is the biggest challenge. You have to do everything. It's not just that you have given bisphosphonate, you have to give fluid, diuresis, steroids, everything is there in the armor. You may have to do dialysis also in that regards. Denosumab is a new agent. We haven't used it, but some people do mention that it may be a good agent, especially if the creatinine is high. But the neonatal age group, probably it's something which we have to worry. Ultimately, whatever you do, it's a temporary thing. You have to go for surgery in that regard. Dr. Hemchand, your experience in this condition?
I think it's a losing battle in most of the cases. Very, very aggressive tertiary care center management, and hit it like a nuclear war with all the armamentarium that is there, as it has been mentioned in this slide. And high risk consent must be taken, and the surgery is also a high risk procedure. We have to take a proper consent.
And I think I was discussing about breast milk hypernatremia, where sodium goes up to 180, 185. This is something like that. So it is like you have to do everything and still you may be losing the battle. So that is a problem. So surgery clearly is very, very important from there.
So neonatal severe hypoparathyroidism, it has a neonatal presentation. There is a family history of hypercalcemia, and
that was very important point raised by Dr. Vibha, that always check the parents. You may have hypercalcemia in the baby because of maternal hypoparathyroidism or maternal vitamin deficiency. Paradoxically, the calcium may go up. So that is absolutely important.
So we should check for the family history of hypercalcemia and hypocalciuria. Surgery is the mainstay treatment, and cinacalcet provides an interim relief. 21-day-old boy had irritability, mild dehydration, calcium was 14, PTH was 120. He was planned for surgery, but subsequently he was found to be improved.
So he was given those measures, but then he improved. So this is a very funny, the very interesting scenario, Dr. Hemchand. What
I think so. This is just a reflection of a continuum of the previous case, but with a milder phenotype. If you see the calcium levels compared to the previous case, they are slightly lower here. The PTH level compared to the previous case, they are slightly lower here, and the dehydration is also mildly lower here. So this may be the one picture of the same spectrum of disorder on a milder form. And the interesting point to note is the urine calcium creatinine ratio. So this, whenever you have hypercalcemia and hypocalciuria, you know the culprit is probably the calcium sensing receptor. And this is a milder variant, which is a heterozygous presentation of the same genetic mutation, resulting in probably a benign self-limiting course. Importance of parental testing, genetic testing of the parent, and looking at the whole picture holistically is very important, is highlighted in this case.
So this is a very interesting scenario that father and the child both have a calcium sensing receptor defect. So the child is sensing mother's normal calcium is low. And because of that, there is a secondary response which is happening. This will improve over time. So not everybody will require surgery. So 20, definitely. But calcium 14, be a bit wary. Give some fluid, dehydration, maybe give a course of zoledronic acid, these things, then they may improve. So don't rush for surgery in that scenario. So this is self-resolving with paternal inheritance in that situation.
8-year-old boy had abdominal pain, calcium of 12.2, phosphorus was low, 2.2, PTH was 60. He was planned for surgery. So Dr. Vijay sir?
So I have to see the other, what I can see that there is, of course, high calcium and low phosphorus. So we have to see, and then PTS is about, so a bit high. So before going surgery, we have to see that what other option that we have, whether we are dealing with spectrum disorder of say some familial hypercalcemia thing, or this is primary hyperparathyroidism. So two are the things, and to focus on approximately 2-3 important things. One, what is the fractional excretion of calcium? What is the status of vitamin D? So these are the things what we have to see. So now coming again to PTH levels. So it is above 20 picogram per ml. And this fractional excretion of calcium is a bit low, that is in less than 1%. Then we have to see what is the status of vitamin D. So now this vitamin D is normal, then we have to think for calcium receptor defect.
I think the other very interesting thing which can be found is the magnesium level.
Yes.
Because in cases who have a calcium sensing receptor defect, it's not just the calcium which goes up, the magnesium will be on the higher side or normal, high normal side. While in hyperparathyroidism, your magnesium will go down. So that is another clue which was there in this case. So this was a calcium sensing receptor defect. If you do a surgery, if you remove the parathyroid, will you correct the hypercalcemia in this case?
No, sir, because the
No.
sensing is also defective. So there will
So
be no.
urine will not be losing. So anyway, your calcium is not going to improve and they don't require surgery. It's like a milder disorder.
So this was a case of benign.
And very importantly, they will not have renal calcification because you don't have hypercalciuria. Why are you worried about hyperparathyroidism? The first thing is kidneys. So this is not going to be affected in this case.
So this was the case of benign, familial benign hypercalcemia. It is a milder variant with no renal calcification, low urinary calcium, and high magnesium levels. So there is no role of surgery as such. Symptomatic treatment has to be given.
So we'll now move towards the last part, which is the low bone mass, which basically is a big topic in itself. But most cases that we're dealing with is either osteogenesis imperfecta, which is a problem in the collagen, its post-translational modification structure. So that is one group of disorder. The second most common will be drug-induced like steroids. So these are the most common ones, along with inflammatory disorders like arthritis. Many of these hypogonadism and all those things do have an issue, but they will improve once you correct the underlying cause, like anorexia nervosa, hyperthyroidism, hypogonadism, they will improve. So most commonly, we're talking about OI and the steroid-induced / immune disorders in which there are problems in that perspective. So we have discussed this in detail yesterday also. So it's not that osteoporosis is defined just based upon the BMD score. We are using the fracture, which is actually more important. So if now we should think of when to treat. Now, these were the expert recommendations that suggested that if your bone density is more than -2, but there are spinal fracture, forget about the bone density. You would need treatment. If a child has clinically significant fracture with a Z-score less than -2, treatment is definitely indicated. But there are now other indications coming that if it is less than -2.5, even without fracture, you may consider treatment. So there has been some change in terms of the guidelines. And of course, if it's less than -2 and the pubertal decline in BMD Z-score is there, you may have to consider treatment. So you have to combine both Z-score, and Dr. Hemchand yesterday taught us very well as to how do we interpret the Z-score in terms of height, in terms of size, and other parameters. So you should do that exercise and look at the fractures are there or not. So most common option that we use is zoledronic acid. Pamidronate we are not using anymore. So zoledronic acid is highly potent. It basically has got predominant effect in the osteoclast. It's an anti-resorptive, long duration therapy. Remember to start at a very low dose, because if you give an anti-resorptive agent, you are depriving the body of calcium, and that may cause hypocalcemia in the initial phase. So start at a low dose and give it as an infusion. As Dr. Vibha was saying, fever is common, so maybe give some antipyretics as well. And acute phase reactions are common. So any infant, definitely OI, everybody who comes to us will require treatment. We remember the case we saw in the on-site also. This child has so much fractures and they will improve symptomatically. Now somebody presents to us later on with recurrent fracture or vertebral collapse. This is required. So indications are there. Very importantly, we also don't want to overdo. So now the guidelines are coming that you should monitor them on treatment as well. And if the Z-score is going between -2 to 0, you'd make the dose half. So like hyperthyroidism, we talked about, you make the dose half when the thyroid is normal. If BMD is in the normal range, make it half. If the Z-score is above the average, then make it even lower. So it is more likely to be 1/4 or even much lower dose from that perspective.
We had this 4-week-old girl. She had pain while handling and history of multiple and recurrent fractures. There was reduced bone density on X-ray. This is the X-ray suggestive of multiple fractures and low bone density. There was no family history of similar illness. So, Dr. Manoj.
Yeah, thank you very much. So here we are dealing with a 4-week-old girl who has a recurrent fracture. So first thing in the mind is coming like a pathological fractures. So there was no family history, but as seeing the picture and seeing the age specifically, I would like to have a thought about the OI in this perspective. And here the calcium and the phosphorus, calcium was normal, phosphorus was little bit high, alkaline phosphatase was high. So this is the diagnosis of the OI.
And how would you manage, Dr. Manoj?
Yeah, so here, as discussed, we can give the pramindronate or zoledronic acid. And here, while giving the pramindronate and zoledronic acid, we have to be worried about the pyrexia. And the dose, the initial loading dose will be milder than the thereafter dose. And here, we have to be worried about the acute phase reaction. And most importantly, before giving the any bisphosphonate, we have to supplement with the calciums and the vitamin D.
On follow-up, this patient was on zoledronic acid, 0.025 mg per kg per dose. Fever, she had fever initially, which was subsided with paracetamol, but subsequently she had seizures. So, Dr. Viva, what could have been the reason?
Might be this seizures is due to hypercalcemia because we have given the zoledronic acid and it has stopped the osteoclastic action, and the main calcium was coming from the bone. So that source has been stopped. So
And the dose which was given was actually higher.
high.
We have mentioned much lower dose, 0.0125. So
Yes.
how is zoledronic acid available?
Sir, it is available as a vial, sir. It contains
How many milligrams?
4 milligrams.
4 milligrams. So when you say 0.0125 milligram per kg, that is infinitesimally small dose. So sometimes erroneously, whether the dose has been given wrongly, and even 0.025 is very, very high. So if you talk about 0.0125, how much dose would that be?
For this patient, it will be, I think, around
3 kg, 4 kg child. So it will be like a very, very
0.1
small dose.
0.1.
So we have to be very cautious. 0.3, 0.4, that sort of a dose will be there. So this has to be very, very careful that they are not giving excessive dose, because then the hypocalcemia is universal then in that case. So Dr. Hemchand, you've got a lot of experience with OI. So what will be your take on this suggestion?
I think it's very important that the calcium supplementation is maintained and the calcium levels are monitored during treatment. And it's always better to have one person cross-verify the preparation by another person, and it should always be supervised by the physician and not just left to the staff nurse to administer zoledronic acid.
And even in this child, they are saying that they are much better. The child is able to sleep well. Otherwise, he was crying. So even though there is severe fracture, they will have symptomatic improvement early. So best is to start early, but even otherwise also, because they did not come for a long time, I
Yes,
think.
there was a loss of follow-up, sir. So on follow-up, 12 years, there was functional improvement. There was reduced fracture rate. BMD Z-score has improved, and presently it is -1.6. So Dr. Hemchand, sir, how will you further manage this case?
I think the improvement in the BMD Z-score to a level that we need not label this child as osteoporosis just on the low bone mass based on the Z-score value indicates that we'll have to do some amount of dose adjustments. So the dose adjustment can be in terms of the frequency, number one, or number two, it can be in terms of the quantum of the drug obtained. So a practical decision has to be made. These are the dosage adjustments that are recommended in the newer guidelines, where you reduce the dose by 25 or 50% based on the bone mineral density Z-scores. And but same would be applicable to worsening of BMD also. You might have to escalate the doses in terms of, I think, the frequency. The escalation cannot exceed a ceiling limit. Irrespective of the fracture frequency, you cannot exceed 0.1 mg per kg per year. I think that is something we have to keep in mind. And if the fractures are fulminant despite such a high dose, then probably second line drugs, etc., may have to be considered, like denosumab, etc.
Do you have experience of denosumab yet?
Not in pediatric age group.
So there are a couple of studies in OI, but they are too early stages, I would say. And I think, Dr. Anshul, you have experience in denosumab in older individuals, in adults? Osteoporosis. So it's the best part of denosumab. It's a subcutaneous injection once in 6 months. It's easy. But the biggest problem with denosumab is that while zoledronic acid goes in the bone, stays there for a long time, denosumab is just a rank ligand inhibitor. The moment you stop it, its action goes off, and the osteoclasts are waiting. So they will start eating up the bone. So you may develop very quickly, other problems will happen, and hypercalcemia, all those problems may develop suddenly. So this is something, so always you should have a plan B after you stop denosumab, with what to shift on to, or you continue denosumab. That is the thing in that regards.
So
Yeah, and when we stop the denosumab, that time the actually bone density declines.
Yes, yes.
So it
So
would be
because now they were sleeping, they were not dead. While zoledronic may kill them also. So that's the best part of zoledronic acid, best or worse, whatever you can say. What is the biggest problem of zoledronic in terms of the fracture? The problem is that the fracture will happen in unusual sites sometimes because you have some areas which are very strong, some area which are weak. So you will have these bisphosphonate lines which are known. And even the shaft of femur, which is the strongest part of femur, you may have fracture. So everything you need to understand the problems in that.
So OI3 is a moderate to severe variant, presents with antenatal fractures. Multidisciplinary approach is important. Bisphosphonate long-term therapy is a key, and we should titrate the doses as per the BMD values. 10-year-old boy presented bone pain. There was a fracture on trivial trauma. It was a spinal fracture. Z-score was -2.2 and was labeled as idiopathic juvenile osteoporosis. So Dr. Vijay sir?
Yes. So this is a significant fracture because the patient is having a fracture with trivial fall, and sadly the spinal compression fracture is there. BMD jet score, if corrected, so I'm going to take that this is significant, and this is -2.2. So yes, so we can see here that blue sclera is visible. Again, so blue sclera is there. So this is OI, and that we have to, since there is significant fracture, so probably we have to think for zoledronic acid.
So I think the big other message is that just like CDGP,
Yes.
idiopathic, the term idiopathic should always raise your mind. What is idiopathic juvenile osteoporosis? Clinically examine to look for the various causes, and then only you will make a diagnosis. So it was there to be picked up. There was clear-cut blue sclera. So rather than just labeling idiopathic, we should try to make a diagnosis in that regard. We're not saying genetics in everybody, but otherwise you can make the diagnosis. This is OI1. And we will be treating, as Dr. Vijay said, that this is a clear-cut fracture. We should be treating in this regards.
So OI1 is a milder form. We should always differentiate it from the idiopathic form. We should always treat if there are significant fractures. 15-year-old boy, a case of juvenile chronic arthritis on long-term steroids. He had fragility fractures, and BMD Z score is -4.4. Testicular volume is prepubertal 2 mm, 2 cc, and bone age is 12 age. So Dr. Manoj?
Yeah, so here there would be different case than we have discussed previously, that this is the pubertal boy who doesn't gain the puberty and has the chronic inflammatory conditions and taking the steroid. So here my thought process would be is it really no, bone issue, primary bone issue, or is it a secondary issue? Here, according to the history, the boy is a prepubertal. So delayed puberty could be the reason, and patient was taking exogenous steroid that can weaken the bone more. So here the DEXA would be guiding us for not to think about the primary causes of the deficiency, rather than we have to think about the secondary causes. And this is the guideline that has been published by the American Society of the Rheumatologists. And here, with the fractures due to the glucocorticoid therapy, zoledronic acid or bisphosphonate would be very, very helpful. But along with that, we have to address the puberty and the growth deficiency issue here.
So very importantly, always be on calcium and vitamin D right at the beginning. And also consider measuring DEXA at baseline. That is something which is very important. If you're thinking of long-term steroids, a bone density should be considered at baseline. So
and
now
DEXA also we have to take as a pinch of salt in the pediatric age group, because it should be validated by the pediatric software. In the many center we don't have the pediatric software, so might be erroneously we are misdiagnosis the osteoporosis. So it should be corrected with the pediatric software, and here by the
we took the help of Dr. Hemchand, and who gave that -4.4 was actually -2.8 in this case. But clearly still there's a fracture. So this is very, very significant. Otherwise, then you have to give the bisphosphonate in this scenario. So again, we are moving towards not just wait and watch, but more towards treatment, because treatments are available. They are safe. When we can use it in an infant, what is the problem in a 15-year-old boy? We don't want them to develop spinal fractures. So be proactive. Do DEXA at baseline. Continue calcium, vitamin D, follow up DEXA, faltering, consider treating. And puberty, growth, all those things also become important.
So, glucocorticoids induce osteoporosis is important entity, and we should have a preventive approach. We should give calcium and vitamin to all, and we should monitor BMD at the initiation of treatment.
So I think this was a very interesting discussion, and we had a lot of inputs coming on from the experience of the panel. I'll thank all of you for joining, Dr. Hemchand, Dr. Vijay, Dr. Manoj, and Dr. Vibha. Dr. Manoj has come for the last minute replacement, and he's been working actually in an orthopedic hospital, so he's having a lot of experience in the management of osteoporosis and other things. Thanks, Dr. Sandeep. And I think we are well in time, so we'll have a break for. There's one question from Dr. Rahul. Yeah, please. Yeah. 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 Yes. Yes. Yeah, so I think that is a big message which was also discussed, and that's a very, very important point. So I think we will have a break, a small break for around 10 minutes, and then we'll start off with the next session. एक minute. So we'll be starting with the next session, and I'll hand over to Dr. Nimisha.
Good morning, everyone. We now move to our overview session. It is my pleasure to invite Dr. Vijay Jaiswal, Professor Pediatrics, LLRM Medical College, Meerut. Dr. Manisha Maurya, Professor, Department of Pediatrics, MLN Medical College, Prayagraj. Dr. Prasoon Rastogi, Endocrinologist, Krishna Hospital, Kanpur. And Dr. Alka Jha, Endocrinologist, Fortis Hospital, to chair this session.
So this session is going to be talking about the latest development, and we've got very wonderful talks which are lined up. There are 5 talks, and we'll start off with the first one, which is by Dr. Hari Mangtani. Dr. Hari is a senior endocrinologist in Nagpur, and he has been working in the field of pediatric endocrinology for so many years. I actually had the opportunity to be one of the examiners for Dr. Hari Mangtani, so that is quite a long time ago. And he is also conducting the Indian Society of Pediatric Endocrinology meeting. He's the organizing committee main person for Nagpur conference. So I'll encourage all of you to go for the ISPE Nagpur, which is being held from 14th to 16th of November. And that's going to be a very good academic feast. And I'm sure it's in good hands with Dr. Dari.
So a very good morning to everyone. And I would like to So this goes, how does it goes back? It goes back this way. This is forward, this is back. This is back. So a very good morning to everyone. And I would like to thank Dr. Anurag Bajpai for giving me this opportunity. And yes, sir was my examiner in 2011 when I completed my fellowship. And thanks to sir, that he passed me. Uh, so yes. So coming to a topic of dyslipidemia in childhood or dyslipidemia in children and adolescent, a topic which is very less talked about and very little discussion is there because we are so much engaged in complicated cases. We don't look too far that what if we diagnose a lipid disorder in a child, what is going to happen? The complications are going to arise in adulthood. By the time the patient will be no longer your patient, it will be someone else's patient. So because of this, perhaps it is a ignored or less looked topic. So I'll be talking about dyslipidemia in childhood with assuming that you know the the pathology or physiology of lipid metabolism. You know about the how the dietary fat gets absorbed and distributed, how liver plays a central role for both cholesterol transport and metabolism, how this HDL is helping the reverse cholesterol transport by bringing the peripherally deposited cholesterol back to the liver, and similarly, how are the receptors, how they work. So because it is very important to understand, because when we talk about the drug therapy, each drug is targeted towards a respective receptor or a particular pathway, and that's how it is the effectivity is decided. So what is dyslipidemia? It is a disorder of lipoprotein metabolism that may result in either single or multiple disorders, including high total cholesterol, high LDL cholesterol, high non-HDL cholesterol, high triglycerides, or a low HDL cholesterol. So the NCP report of the expert panel, they have shown that blood cholesterol levels in children and adolescents, they actually are precursor of atherosclerosis or ASCVD, atherosclerosis related cardiovascular disease. And this pathology or this uh, uh, development of a plaque, it starts very early at a younger age with some physiological, some pathophysiological changes in the blood vessel, including the intima media thickness, and then later on plaque develops, and subsequently the person may suffer from a cardiovascular event. So atherosclerosis or its precursor began at young people, and elevated cholesterol levels early in life, they play an important role in development of adult atherosclerosis. Uh, Eating patterns and genetic, both, they affect the blood cholesterol levels, and that's why it is the CHD. Now we cannot do much about the genetics, but eating pattern or lifestyle we can definitely modify, and then in subsequently we'll see how it increases the risk and what can we as a endocrinologist do for them. So lowering levels of cholesterol in children and adolescents is known to be beneficial. Now, with this background, when we see the agencies, the American Academy of Pediatrics, the American Heart Association, the cholesterol guidelines, everyone, they came up with this acceptable borderline abnormal plasma lipid protein and apolipoprotein concentration. So, if we see here, okay, so these are very important, the pointers. Okay, long press it. So we have to actually remember these. This is a very busy slide actually to remember, but we have to remember these because these then comes into definition of dyslipidemia. Okay, and timely intervention to address this condition in childhood may decelerate the development of atherosclerosis process and prevent development of early ASCVD. So coming to the definition and etiology of dyslipidemia, it is defined as presence of one or more abnormal lipid levels of total cholesterol more than 200, LDL cholesterol of more than 130, non-HDL cholesterol more than 145. So we have to remember only these figures, a 200 figure of total cholesterol, and we know HDL 40, we all remember this, and triglyceride more than 100 at different ages. So less than 10 years, it is more than 100. For elder children, it is more than 130. And what is the etiology? Mostly it is the dietary cause. So excessive intake of saturated fats and trans fat may elevate the LDL cholesterol, and excessive intake of refined carbohydrate and simple sugars, they increase the triglyceride levels. So if we talk about dyslipidemia, there are two main things we are talking about is hypercholesterolemia and hypertriglyceridemia. Okay, both are different and they have different consequences. Hypertriglyceridemia will more work on leading to pancreatitis as a complication. And if we are talking about hypercholesterolemia, we are talking about the ASCVD risk factors. So secondary causes definitely we have to look after because which are more common, like obesity, type 2 diabetes, hypothyroidism, nephrotic syndrome, and the list goes on. We'll discuss all the risk factors. And the genetic causes, these include polygenic causes, which and monogenic causes. The most common and most dreadful is the familial hypercholesterolemia, and then we have got a list of dyslipidemia and other rare disorders. So if we have to catch hold of them, or we have to find out who is at a higher risk, then these guidelines of lipid screening were there. So because it is known that early identification and control leads to reduced risk, and lipid disorders, they are clinically silent. So previously what used to happen, that if there is a family positive or family history, then only the screening was done for the other family members. But now all the agencies, they have found there is an ample of evidence that there is an ample of evidence that pediatric dyslipidemia, the atherosclerotic changes leads to like obesity, it tracks from childhood to adulthood. Similarly, dyslipidemia, it also tracks from childhood to adulthood. And that's why early identification, it facilitates early intervention. So these are the screening strategies. So there are two types of screening. One is targeted screening and one is screening all. So targeted is when we have a risk factor. When we have a risk factor for obesity, diabetes, hypertension, or family history of premature CVD, then it has to be targeted screening, and rest we have to do screening for others. So if we go with the algorithm, the child who has got more than one CVD risk factor, we have to perform lipid screening, and it typically begins at the age when the CVD risk factor is first identified. Okay, but generally not before the age of 2 years we do it. And the interval of testing is tailored based on the individual risk profile. If there are no risk factors identified, we have to perform screening based on the age of the child. And this is what, if it is less than 9 years, no lipid screening is indicated. 9 to 11 years, all children should get lipid screening done. If we miss this, then from 12 to 16, we do not do any screening because it is not recommended in this age range because of the pubertal hormones. And after the age of 16, then again, all adolescent and young adults should actually be screened for presence of lipid disorders. So coming to a simple case which we usually see in our OPD, this was a 12.5-year-old female child, came with excessive weight gain, poor lifestyle, consuming high glycemic index foods, lethargic, low activity, sedentary lifestyle, high screen time. Father is type 2 diabetic. No CVD risk in the family. Then height and weight, compared to that, the BMI comes to more than 95th percentile. The blood pressure is less than 90th percentile. Waist circumference definitely high, 84 centimeters. Acanthosis she has got, and she has got acne and regular menses. You have planned a few tests, and these are the test results. So this TFT is normal, SGPT is also in the normal range. The sugar, random blood sugar, is also normal, HbA1c 5.6. LH, FSH ratio is reversed, and DHA is slightly on the higher side. This is the first case which we are seeing, and a lipid profile suggests a LDL of 142, a total cholesterol of 210. Okay, this is a very typical case we see in our OPD. Similarly, this is a 14-year-old male, a case of type 1 diabetes for 6 years. He has started recently on pump therapy. That's why has started thinking that he can manage everything. And because of adolescent age group, he is falling less frequently, not following the food restrictions, and has experienced recent weight gain, which we, with improvement of glycemic control, we see. And there is no diabetes, hypertension, or CVD in the family. The height, weight correlates to BMI of 80 to 85th percentile. No acanthosis. The workup says that the thyroid function was normal. TTG is negative. HbA1c quite well controlled, 7.7%. And urinary albumin creatinine ratio of normal. The LDL of 90 and triglyceride of 140. So everything looks normal in this child. Coming to this case, this is a 19-year-old male. No diabetes or hypertension in the family, but father had an episode of MI when he was 51 years recently only. He is on mixed diet. He goes to gym. He lives an active life. He has just experimented smoking and recently started. He is otherwise 172 centimeter, decent weight, 60, and there is adult tenor, no acanthosis. TFT is normal, HbA1c 5.1, LDL of 210, which was done at a fasting, and creatinine was normal. So I've shown you 3 cases, and let us understand that how do we do a risk stratification? Who all are at risk out of these 3? We should be able to know. Because once we get obesity, type 1 diabetes, or a smoker, or a family history, then we should do a stratification. We should know who is at high risk, moderate risk, and at risk. Okay, so what are the criterias? I'm speaking mostly on hypercholesterolemia, hypertriglyceridemia. I'll just give you a slide in the end. So mostly this dyslipidemia, I'll be talking on hypercholesterolemia. So risk stratification for children and adolescent at risk of early cardiovascular disease. We have high risk conditions, moderate risk, and at risk. So high risk includes homozygous familial hypercholesterolemia diagnosed case, diabetes, both type 1 or type 2. How well it is controlled, we don't know, but it is already a high risk condition. Then end stage kidney disease, Kawasaki's disease, childhood cancer survivors, or there are multiple comorbidities. If we see any moderate risk condition plus any 2 additional moderate or at risk. Similarly, when we talk about moderate risk, it is severe obesity, obesity more than 99th percentile, confirmed hypertension, or a heterozygous familial hypercholesterolemia with predialysis CKD. And when we see about at-risk conditions, the most commonly observed is that obesity that is not severe insulin resistance like NAFLD and PCO, family history of premature CVD, parent with known dyslipidemia, and a current smoker or significant exposure to secondhand smoke. Rest are again rare causes, which just to complete the list, I have put it. So chronic inflammatory disease, HIV infection, Kawasaki's, cardiomyopathy, these are additional risk factors. So this is the step 2 which we are supposed to follow. We have to assess other CVD risk factors and comorbidities, which include. So we do ask for extra history and do extra investigation to know the CVD risk factor. So a diet, physical activity, exercise history, measuring height, weight, BMI, measuring blood pressure, obtaining a lipid profile, and obtaining fasting glucose and HbA1c if appropriate. Once we identify the risk patient, then we ask for all this. So if the patient classifies to be a high risk, we have to establish the treatment goals for a person. And the treatment goals are controlling the BMI to less than 85th percentile, blood pressure to less than 90th percentile, LDL cholesterol of less than 100. That is the most important thing, because rest of the things are same. A fasting glucose of less than 100 and HbA1c of less than 7. Similarly, there are goals for moderate risk patient. And if the children is there in moderate risk, plus there are more than 2 additional CV risk factors, then it will get classified automatically to the high risk. Otherwise, it remains in the moderate risk group. Similarly, at risk with more than 2 comorbidities, it gets classified into moderate risk. So there are different goals, and the main factor here is LDL cholesterol, 130 for moderate. For at risk, it is less than 160 and less than 100 for a high risk. So high risk conditions are uncommon in childhood, and the most pediatric patient with dyslipidemia will be categorized as moderate risk or at risk. So what are the management strategies? We discussed yesterday about the healthy lifestyle, the healthy eating habits, and the heart healthy lifestyle changes are to be promoted, which is like dietary modifications and physical activity. Weight loss for children of obesity, because invariably if a child comes to us with some height problems, some other issues, we do not check the BMI, or even if we know that the child is on the overweight category, we do not give an advice, because that is not a primary concern they are about. They have come. Suppose a child has come from micro penis or small size penis, and you know that's a buried penis, and child is a bit obese. We don't give advice. We are not giving advice for controlling weight, because we have got a busy OPD. So understanding and sensitizing the patients or parents about increased weight is a very important part of our practice. And weight loss for children with obesity maximize high quality sleep and avoidance of nicotine exposure. So behavioral modifications and improving including the family into behavior modification is very important. For high-risk patients, statin therapy is started simultaneously with lifestyle changes, and for moderate risk and at-risk categories, we can just go by doing a lifestyle modification for at least 3 to 6 months and subsequently follow them up. So what is healthy lifestyle or heart healthy lifestyle? Once we start intervening, it reduces the LDL cholesterol modestly only around 5 to 7%. And a diet high in like Saurabh yesterday mentioned the Mediterranean diet, a diet high in fiber, fruits, vegetables. So a vegetarian diet high in PUFA and MUFA, that is polyunsaturated monounsaturated fatty acids, and a fat intake which is less than 30% of total intake, and saturated fat intake of less than 10%. So activity, moderate to vigorous activity, and weight loss in obese patients. These are the heart healthy lifestyle. Pharmacotherapy, coming to statins, is the drug of choice. It is a HMG-CoA reductase inhibitor, which is the rate limiting step in cholesterol biosynthesis in the liver. So the liver pool reduces. Once we block this, the liver cholesterol pool reduces, and this increases the LDL receptor on the liver, on hepatocytes, and that the increased vascular clearance of LDL happens. So it reduces the LDL levels by almost as a big chunk of 25 to 40%. It has to be started the low dose, OD dose at the night time, and side effects include myopathy, hepatic enzyme elevation that has to be checked in every visit. The dose of statin may be increased further until we get a target or the maximum dose is reached, or whenever we note that the toxicity is happening, the liver enzymes are going high. Ezetimibe is another safe second-line drug for a lipid lowering agent that prevents absorption of lipids or cholesterol and as well as triglyceride and plant sterols from the gut, and bile acid sequestrant. The cholesterol pathway, the internal pathway, the cholesterol which gets secreted as bile acids and they are again reabsorbed in the enterohepatic circulation, that is prevented by this bile acid sequestrant. And they are less effective than statins and have some bothersome side effects in kids, particularly constipation, bloating, which leads to poor compliance. So these are important pharmacological agents which can be used in children at appropriate dose. So coming to the first case, what are the red flags which we see? Poor lifestyle, high glycemic foods, low activity, BMI is high, acanthosis is there. We have got evidence of hyperandrogenism and we have got a LDL cholesterol of 142. So what is the classification in this child? This is 2 at-risk factors plus 2 CV risk factors. So comes to moderate risk, and treatment goals are tell them to reduce weight and keep a LDL of less than 130. That is the treatment goal for this first case. This case is, although he is fine on pump therapy with all the targets achieved, still is type 1 diabetes for last 6 years. What is the risk stratification in this child? He is high risk. Okay, because he's suffering from type 1 diabetes, and treatment goals is to keep BMI at less than 85th percentile, blood pressure at normal, LDL less than 100, and a fasting glucose. So we are not giving or doing any intervention in this child, but we have at least stratified into a high risk and told them that this is what you have to maintain. You have to maintain HbA1c, you have to maintain a normal LDL cholesterol. But here, an HbA1c of less than 7, which is slightly difficult to achieve every time. We may succeed it initially when the kids or parents are motivated, then later on they lose track some way. This is a 19-year-old girl, boy. Father died, father had MI. So early cardiovascular event. What is early? Less than 65-year-old in male, or less than 55-year-old in male and 65-year-old in female. If we get some cardiovascular, it is called as early cardiovascular event. And he has started smoking. Okay. Rest, everything is fine. He's active. He runs around. He plays around. BMI is also normal, but still he gets categorized into a moderate risk. And we have to tell him the treatment goals. The LDL is 210. And here we have to ask him to reduce the smoking or cessation of smoking, and the LDL make the cholesterol less than 130. So these are important things we should do in our clinical practice. And Once we know that it's a primary genetic lipid disorder or there is a clinical suspicion of familial hypercholesterolemia, these require extra workup, perhaps help from the colleagues or a lipid specialist. Now, who is a lipid specialist? Because it's an endocrinologist or a gastroenterologist or a cardiologist. But we have to play our part. Okay, so patient at high risk of early ASCVD who, despite optimal management of the underlying condition, warrants pharmacotherapy, inadequate response to statin therapy, patient requiring second line agent, and extremely high triglyceride level of more than 1000. So this finishes hypercholesterolemia. Coming to hypertriglyceridemia, hyper TG is itself not a major risk factor for ACVD, but it is associated with conditions which are internal related to early ACVD like obesity, type 2 diabetes. So when we get high TG, then perhaps we should screen for other lipid disorders. Treatment is primarily focused on promoting healthy eating habits, physical activity and weight loss, reduce intake of simple carbohydrate, having cold drinks or juices, or reduce the saturated fat. This all will bring down the triglycerides. And drug treatment may be warranted if they are very elevated and just reduce the risk of pancreatitis. Fibric acid derivatives, they can be used if they do not get controlled by basic, and statins if it is associated only with hypercholesterolemia. So to summarize my talk, it is dyslipidemia is important yet ignored risk factor for ACVD. Screening is useful tool to detect dyslipidemia. Early identification as well as early intervention may prevent the mortality and morbidity of cardiovascular event. And intervention includes adopting healthy heart lifestyle, which includes diet, activity, avoidance of nicotine. Now, risk stratification helps in identifying individuals who require early pharmacological intervention, and an early referral to a specialist is warranted in high risk and difficult to treat cases. With this, I would like to thank you all for your patience.
Thanks a lot.
I was told that I should highlight about one drug. So I have come with this PCSK9. Uh, so this usually we are not using, only I think I don't know how much I haven't used it, or it elevated levels of circulating pro protein convertase or PCSK9. They are associated with LDL in low levels of high levels of LDL and a worse outcome. So there are antibodies available, monoclonal antibodies available, which have been approved to treat or reduce the LDL cholesterol levels, and they are able to reduce the cholesterol level up to a tune of 60%. That's highly effective antibodies, and what it does, it blocks the degradation of LDL receptors. Okay, it actually binds to LDL receptor and prevents its degradation, and subsequently more receptors are available to pick up or do the vascular clearance. These are to be given subcutaneous injection, and the name is evolocumab and rocumab.
So this is
So they
mainly
are-
for very severe form of familial hypercholesterolemia where you cannot get controlled, because statins are going to have an effect only around 10 or something from that perspective, 10-20%. So I think this was a wonderful discussion. The biggest message is we should treat the child, not the numbers. It's not just the cholesterol level, but Dr. Hari really talked about how precisely you look at the risk factors. Dr. Alka?
Yeah, sir, any experience on using of bempedoic acid in childhood dyslipidemia or the adulthood?
No, it's not
not-
proved. We don't use it. So most of us will be using statin as a primary agent in most scenarios. And the familial hypercholesterolemia is an extremely difficult scenario to treat, because even if you reduce by 20-30%, if the baseline cholesterol is 600, it will go down to maybe around 400. So ezetimibe I have used in one or two patients, and this I have not used it, but this is a good. Anybody who has used PCSK9 inhibitors, Dr. Hemchand? This is something which is emerging as a good therapy on that. Dr. Prasoon, your inputs?
Very lucid talk, Dr. Hari. Just like to summarize it, we are seeing lipid profiles report day in and out. Yet, we have to say that the reports are very near, but the treatment appears too far. We are afraid to use it in a pediatric group of patients, so we should be vigilant enough to use it properly. And just to add that lipemic primitive streak begins from day one of life. So we should not delay the treatment in this group of patients.
Yes, sir. So ASCVD is a pediatric disease which is manifesting in adults, like osteoporosis, those sort of scenarios. And type 1 diabetes, you made a very important point. Type 1 diabetes is a CV risk factor in itself. So if somebody has a type 1 diabetes, people think, okay, type 1 is less, but type 2, it is in fact worse than type 2 because they're having such a long period of follow-up. So any point in...
Thank you, Dr. Hari. Just I'm going to echo your voice that we are tracking now, we are sensitized that obesity to be tracked early. So like that only that dyslipidemia is also going hand together, and we should have a track, and stratification is a very good strategy, and according to that we have to act.
So if I have
Thank
to
you.
give an analogy, it is said that the bone accrual happens maximum at around before the age of 20 to 23, and all have started giving vitamin D to prevent a fracture in the postmenopausal age. Similarly, to prevent that adult disease, we have to start working now.
Yes, very right. Very right.
And I think one word of caution about statin, especially in young girls, because statin is something which is teratogenic. And so we have to be very cautious in that scenario, especially in younger individuals to start that. We'll move to the next talk. And PCOS, we know, is a very, very common disorder. Thanks, Dr. Hari. Thanks a lot. PCOS is a very, very common and important disorders, and there are a lot of changes which have happened. So we have had discussions earlier about how do we manage, how do we assess. Today, Dr. Yuthika is going to talk about the specificities of what's new in PCOS. So hopefully we'll get new insights onto that.
Thanks a lot for having me here. So I'm a gynecologist here amongst pediatricians, but I specialize in pediatric and adolescent gynecology. So we have some relationship. PCOS, I know it is one of the most commonest disorders that we as gynecologists encounter, and you as pediatricians also see in your adolescent population. And we've had multiple lectures and lot of talks on PCOS, so I don't want to bore on its things. I here really wanted among so many professors and associate professors and so many seniors in front of me, want to just stimulate you to start doing research in this topic. So we know so much about PCOS and we really don't know much. And a lot of things are happening worldwide about why this enigmatic disorder occurs. So we all know it is basically the triad of chronic anovulation, hyperandrogenism, and polycystic ovaries, which is the morphological aspect of it. And according to the criteria of definition, amongst teenage girls, about 3 to 11% can have PCOS. But there is a diagnostic dilemma because of the physiological hyperandrogenism, anovulation, and multicystic ovarian that we commonly see in young girls. And we've had challenges that I would like to touch base is what are the updated criteria for diagnosis of PCOS in adolescent? And what actually, so we know the whole pathophysiology of PCOS, but what actually is how our lifestyle is leading to that, and what actually is the cause, we really don't know. And how to differentiate these lean girls with obese PCOS in adolescents specifically, because they would sometimes present with partial PCOS phenotype, say maybe just hyperandrogenism or maybe just irregular periods and not the whole phenomena. And what are the newer treatment modalities? So Rotterdam criteria in 2003 came up with this triad, and they said any 2 out of the 3 after excluding all the other causes would be the definition. But this one was not very fit enough for adolescent, because a large population of adolescent would have irregular periods, would be because of the immaturity of the HPA axis soon after Minaki. And also the diagnosis of polycystic ovarian morphology in young girls is a bit difficult, because doing scans in these girls, especially if they are obese, transabdominally you're unable to pick up the PCOS, and transvaginally it is not possible for the young girls. So a difficult diagnosis, and that's why there was a lot of overdiagnosis or underdiagnosis of these girls. And then in 2018, ASHRAE, ASRM again came up with the new criteria for adolescent girls. They said not to take the phenotype D, where you have just the chronic anovulation and the morphological part, that is the polycystic ovarian morphology on ultrasound. This combination not to be used as PCOS in young girls, because as I said, about 25% of young girls can have polycystic ovarian pattern, which could be just normal. So they said 8 years till Minaki. Don't use ultrasound criteria for the diagnosis of PCOS. And use age-specific criteria for characterizing that these cycles are really anovulatory. So having irregular periods is quite common in basically young girls. So when to say this is really irregular? So you cannot have adult criteria put up on these girls. And they made hyperandrogenism as a mandatory diagnosis to have. So if you're labeling someone PCOS, it has to be hyperandrogenism, either clinical or biochemical. Biochemical, the cutoff was lowered from 80 nanograms to 55. And for having significant hirsutism, that is a Ferriman Galloway of more than 15, or severe recalcitrant acne. They also came up with a term to not label young girls with PCOS, and they started saying that you call them at risk for PCOS if somebody is not fitting into these diagnoses, and keep them on follow-up. And there are studies that show that about 50% of those girls who were labeled as PCOS in adolescent population turned out to be healthy adults, individuals. Now, 8 specific criteria for anovulatory cycles. Basically, if you look at coming from the Minaki point of view, if there is no menses after 3 years of breast development, no menses, that is primary amenorrhea, in the first 1 year, a cycle which is longer than 90 days, in first to 3 years after Minaki, a cycle which is longer than 45 or less than 21, and a cycle which is more than 35. So this is the adult diagnosis of oligomenorrhea. So cycle which is more than 35 or a shorter cycle, you would call them as, so sometimes you have people with a 40-day cycle in the first year of Minaki, that could be just normal. So use age-specific criteria for anovulatory cycles. Now in 2023, which we have now started calling it Rotterdam 2023, 20 years after the initial criteria, they have now added AMH levels in their armamentarium for diagnosis of adult PCOS. So if either do an ultrasound or an AMH level, if they are high or you have the polycystic ovarian morphology, then you can label it besides the chronic anovulation and hyperandrogenism, but specifically said that not to use it for adolescent girls, which is very commonly the gynecologists are doing, using AMH for diagnosis of PCOS in adolescent girls, which is not recommended by the Rotterdam 2023 because it is non-specific and highly sometimes very much elevated AMH levels are seen in young girls, which might not be correlating with their symptoms. So coming on to basically the prevalence, as I said, the prevalence of the disease depends mainly on how you are diagnosing it. And this is a very brilliant study done by AIMS, published just recently in 2024 by the Department of Endocrinology, Professor Ashraf Ghani and Professor Neena Malhotra from Department of Reproductive Medicine. And they did basically it was a nationwide cross-sectional study of 5 zones in India. They used the Asha Bahu nurses using the voter ID cards from 18 to 45 years old women, going to their home, using questionnaires, and then they came out with basically this data. And alarmingly, using Rotterdam 2023, about 1 in 5 women actually had PCOS. So about almost like 19.6%. So they did the screening and all the at-risks were called into the medical colleges, mainly the AIMS, and then they were worked up and they were found out to be, almost say about 56% were thin fat phenotype. So the lean PCOS. And almost 90%, almost 92% had dyslipidemias, which is alarming. About a third had any, non-alcoholic fatty liver, metabolic syndrome, and only about 3% had diabetes. So basically, they are coming up with a follow-up study by using other criteria But this is for adult women. We don't have any such large-scale studies for adolescent girls. So this is for adults, and which is really alarming with the prevalence of about 20% of PCOS in general population. So what are the recent advances in the pathophysiology? So there are 4 aspects where we know that it is a multifactorial disorder. It is a lot of heterogeneity. One cause may not be the cause for PCOS in another patient. So a lot of heterogeneity here. There are a lot of implications, newer studies coming about gut dysbiosis, environmental toxins, and what is the molecular basis of lifestyle leading to PCOS? We really don't know. So we know that people who have, a bad lifestyle, weight gain, they don't exercise, they eventually land up into PCOS. But why? We really don't know that. So basically, if we'll just, we all know about this pathophysiology. I'm not going into detail, but there is something that is leading to this triad of hormonal imbalance, and these 4 things that have been implicated, leading to all the clinical presentations that we see of hirsutism, acne, by basically increasing the testosterone level, lowering the SHBG, and hyperinsulinism. So for environmental toxins, actually BPA, which is a very common endocrine disruptors present in plastics, there are many studies coming up. There is a recent review collating all the studies that are showing direct relationship of BPA to PCOS. And then you have circular RNAs. These are epigenetic factors, which probably in the next 10 years either might be used as a biomarker for diagnosing PCOS. And gut dysbiosis, lot of studies coming, lot of, in India, one study comes and we get the drug available to treat it. So we have a lot of people coming on to you with dextrins in their dietary supplements to improve the gut dysbiosis. And in fact, there are correlations of having a bad gut and lower levels of GLP-1s in those patients. And diet and lifestyle is an interplay of lowered GLP-1 and the uncoupling protein factor, which I'll come to in a little bit detail. So these are some studies that I identified while doing my research, that these are some areas that we should also work in. So coming on to BPA, it is basically it is a xenoestrogen, very similar in structure to 17-beta estradiol, and it is present in almost everything, all the, especially the feeding bottles that are very common, and we are sitting with these mineral water bottles. They have to be ideally BPA free, but they're not regulated properly. And WHO recommends that the daily dose should be less than 1.5 microgram per kg body weight, which is much higher when you look at the studies that we are taking. Toxic levels are very high, but chronic toxicity by taking long-term levels of 1.5 microgram per kg body weight can lead to a lot of problems. Now, this very nice review article that collated all the studies was published in 2024. It is from India itself. And it has actually all the studies are not done in India. This is a review that the team did from Manipal. These are studies done, in vitro studies on, the granulocytes, rat models, and even a lot of studies done in assisted reproductive technologies related studies, like taking out follicular fluids, metabolic studies while you're doing IVF, to look at correlation, how much BPA we have in our system. And you'll be surprised that BPA studies have shown that they basically works via mitochondrial dysfunctions. Basically directly affects the granulosa cell, causes a PCO-like morphology. So a lot of studies, in vivo studies, by taking ovarian biopsies in PCOS patients, in vitro studies where they have done, and even in rat models. So they have created, using BPA, in all the cells that are implicated in the PCOS morphology. So there are some studies now coming up, mainly in IVF related, so reproductive medicine, where they found that implantation rates and oocyte immaturity in PCOS patient is directly correlated to blood levels of BPA being lower in good prognostic patients. Coming on to the second aspect, the genetic basis of PCOS. Again, this study was published in 2025, where they found out among patients of European ancestry, there are certain genetic variations in these specific gene loci for lean PCOS, which is different from obese PCOS. So lean PCOS probably is working from a different pathophysiological point of view compared to the DNDA, which is the final, basically, eventually it collates into both lean and the obese PCOS that leads to hyperinsulinism and dysfunction at the level of granulosa cell and oocyte maturity. So basically, both distinct and shared genetic factors are present here in overweight and obese PCOS, giving us an idea that there is some genetic basis to this disorder. Not everyone in PCOS have a genetic basis, but when you look at, there is always a historical data of metabolic clubbing, of metabolic disorders amongst the family, and you have, fathers with metabolic syndrome having daughters with PCOS. Those type of correlation studies were always there, but this specific gene identification where the loci was done by them. Again, the epigenetic two-hit hypothesis. Some people might be predisposing for PCOS, but they do not present unless they have the epigenetic modification, where the role of the circular RNAs are coming. Now, circular RNA is the messenger RNA, where the 5 and the 3 cap prime ends, they covalently bond to form a circular RNA structure, which will not be translated, but it actually goes back to the gene and causes the upregulation of the gene. So it's sort of a positive feedback loop. And in the cytoplasm, it mops up the microRNAs that have the inhibitory effect on the gene upregulation. So it's sort of acting at the genetic level where the gene was normal, but its expression was increased or decreased due to certain environmental factors. And why circular RNAs? Because they work at the level of, the gene transcription, translation, and even post-translation modification. And they're very stable. So you can actually, they're not like messenger RNA that can be very easily metabolized. Because of their circular nature, they can be very easily picked up from blood plasma. And that's why a lot of studies are now coming in identification, raised level of certain disease-specific circular RNAs that can be identified. So a circular RNA which is specific for PCOS has been identified, which basically they're doing studies at their initial levels, but they can be diagnostic molecular marker for identifying this disease. Again, GLP-1 and UCP1. These are two molecules. A lot of research is happening here. So basically, our diet actually is, if it is not a great diet, so not very rich in veggies, not, if it's a high-fat diet, GLP-1 production actually decreases. And that causes a lot of other pathophysiological things that happen and eventually leads to hyperandrogenism. GLP-1 actually acts centrally at the level of brain. It causes satiety and all, but it also works directly on the GnRH pulse, leading to the alteration of LH and FSH ratio. It acts on the pancreas and it also acts on the muscles, where it is basically leading to both hyperinsulinism and hyperandrogenism in a PCO phenotype. And the muscle myokine. So when you're exercising, muscle is releasing certain chemicals. Now, this is an uncoupling protein 1, which is released by the muscles. It acts on the adipocytes by making the adipocytes brown. So the adipocytes that produce a lot of thermogenesis. Normally, adipocyte is there to store the fat cells, but there are certain kinds of adipocytes that actually will not store it and cause the burning of the fat. So the better kind of good fat. And that's why when you're exercising, this is the basic correlation between why you're losing fat. So in basically, I'll come to some studies where they have proven that in Indian people, lean PCOS people, the GLP-1 is down-regulated. The UCP is also down-regulated. Coming on to management, we all know about, lifestyle. It affects all aspects, hormonal and metabolic aspects of PCOS. The combined oral contraceptive pills make your cycles better, correct testosterone, but have no effect on the metabolic aspects of it. The metformin has a milder effect on the hormones via indirect loop of improving the insulin resistance, but better effect on the metal. So combination of both these drugs is much better than using the COCPs in patients who are high risk for metabolic disorders. And then the GLP-1 and SGLT2. The anti-obesity drugs are now also coming in the injectable formats, but not approved for PCOS, not approved for adolescent age group up till now, only for obesity. Again, myoinositol is one of the drugs that is very commonly used in adolescent age group because we generally don't prefer to use hormones in that age group. In fact, many studies have shown that it is as good as placebo actually. So I'll come to those studies as well. So metformin, and this is a 2025 study, metformin combined with COCs, combined oral contraceptive pills, is a much better option, especially if the BMI is high. So it is superior to COCP alone for metabolic parameters. And if the BMI is high, it is even better. So if you've got a patient with hirsutism, not use just the COCPs and anti-androgens, add metformin, it has a better result. This is a good systemic. It's a 30 RCTs and 6 RCTs were adolescent girls. Again, inositol, a lot of them. This is a 2023 update, and this update was included in the international PCOS guidelines, and where they recommended that metformin was definitely significantly better. So when you're choosing not to use hormonal preparations, even in patients who have just the adiposity and not the BMI is not high, you can use metformin over myoinositol, which is much better. And when you compare it with placebo, myoinositol was not as, it was as good as placebo. So myoinositol use is very high in our country, especially in adolescent age group, to basically when the patient chooses not to take hormones when the doctor is recommending. Again, this study, this was a 2014 study, and the same group did a follow-up study on the use of oral contraceptive in patients with lean PCOS, and they found that GLP-1 levels, both at fasting and in response to meal, were lower in lean Asian women. So we generally are genetically probably, or maybe our diet is like that, or we have gut dysbiosis, we are producing less GLP-1 compared to other people. And even the lean Asian women are producing less GLP-1. So we have insulin resistance coming out from there, and maybe the diet is like that. So basically now this research paper, again, it is meta-analysis where they found that GLP-1 agonists along with or individually with SGLT2 inhibitors in PCOS patients who are non-diabetic or pre-diabetic, just obese PCOS individuals definitely showed promising results because GLP-1 analog is actually acting at all aspects of PCOS, right from central, causing satiety, improving the GnRH pulse frequency, to attacking the hyperinsulinism pathway, and also at the level of granulosa cells, where it is improving the intra-ovarian hyperandrogenism, improving anthropometric parameters via the hyperinsulinism route. SGLT2 inhibitors also basically were good in reducing the body weight adiposities and the free androgen index. So these are the new drugs that have come up. Again, the take-home messages would be the recent guidelines that the 2023 Rotterdam aims to avoid overdiagnosis, not to use AMH in the diagnosis of adolescent PCOS, not to use ultrasound, use hyperandrogenism and chronic anovulation as the criteria. The at-risk PCOS candidates for preventive therapy, research should be directed at this area, and how to identify the true PCOS from these at-risk PCOS individuals. And chronic BPA exposure, this is another area of research We don't have even our IV lines and the bags that we are using have been studied in IVF cases to increase the BPA level amongst the follicular fluid that is being aspirated. So we have high BPA exposure, and there are studies that are showing BPA causing PCOS. Those studies need to be done. Again, circular RNA as a potential biomarker. Look out for this one for diagnosis of adolescent PCOS. And finally, the newer drugs, the GLP-1 analogs and SGLT2 in obese and pre-diabetic PCOS to be done. Thank you.
Thank you very much, ma'am, for recent update. And we have to really very cautious regarding making diagnosis of PCOS, particularly in adolescent girl. Since they are coming to you with complaints, so individual complaint to be taken care of. So it doesn't, that not labeling PCOS doesn't stop you to treat or to help the person. Rather, you should label it at-risk PCOS. And ma'am has rightly pointed out that there is no role of diagnosis on the basis of radiological or single AMH level. So these things we have to take care. And thank you very much, ma'am.
Thanks a lot. And it was a wonderful talk with regards to the recent developments in that regard. So, yeah, Dr. Soon.
Yes, very extensively covered presentation. I'd just like to highlight few points.
Yeah.
Just like dyslipidemia, PCOS is also is not only a menstrual disorder, it is a metabolic disorder with far-reaching consequences like ASCVD also. And just to mention that AMH should not be loosely prescribed because only few labs have been accredited, given the license by FDA that correlate with the clinical thing, such that the Access lab by Beckman Coulter and the MinoCheck kit by the ANSH lab or the ARUP. These are the only 3 kits that have been approved with pre-approved cutoff levels. So only the standard lab the lab value should be taken in mind while making a diagnosis.
Absolutely. And when we talk about AMH in adolescence, it's mainly a surrogate of PCO appearance. So in a way, because that's not being considered as the primary thing, hyperandrogenism and anovulation is, so we should not be over excited by the AMH levels as you have pointed out. So now we'll move ahead with the next part, which I'm going to cover about the long-acting growth hormone. We all have been using growth hormone for a long time. The growth hormone the use was approximately 70 years ago. And since then, there were a lot of developments. And around 1984, recombinant growth hormone came in when the supply became unlimited. So there's a famous pediatric endocrinologist from US, Professor Rogol, who says that short stature became a disease when growth hormone became available. So it's not that the people were not short, but they were started pathologizing once we had the treatment, and then it expanded. So from there, it has been used a lot in kidney disease, Turner's, Prader-Willi, SG, and ISS. So this is something standard. Millions of children have been treated globally with good response and safety. But sometimes they can be problems. So this was a 12-year-old boy who had short stature. He had a height of 120, peak growth hormone was less. On growth hormone, he had a good initial response to growth hormone, but subsequently the growth velocity plummeted. Now we know there can be multiple causes like issues of other diagnosis, nutrition, hypothyroidism, sometimes antibody. But one of the big elephant in the house is adherence. Now, whether we have got a good adherence or not, which may be an issue, especially where it is being provided by the government or through some agency. Because if somebody is paying for themselves, this issue is not very important. But somebody is getting it for free, then the value becomes less. So this patient had low IGF-1 and adherence was considered. Now, if you look at adherence data, this was a wonderful study which was done in New Zealand, which clearly they really looked at how many vials of growth hormone was being returned and how many were taken. So it's not just the reported prevalence, they were actually measuring that. And what they found out when they rank low, medium, and high, you can see there is a linear correlation between the adherence and height velocity. So clearly adherence is important. And of course, if you give a daily injection versus a weekly injection, the chance of adherence will be much better in weekly. Dr. Rishi yesterday talked about weekly icodec. I talked about even monthly GLP-1 receptor agonists which have been there. So now we're talking about longer acting peptides, and why are we for growth hormone still using a daily injection is a question. So if you have a daily treatment, issues of adherence, you cannot change the time. If you miss a dose, what to do? Dropouts are more common, and then this may have a compromise effect from that perspective. So I'll talk about why, what, and how of long-acting growth hormone. So as I discussed, obviously less is always better. So we'll have less number of injection. It will be a safe therapy, efficacious therapy, but the question is whether it is accessible or not. So these are the questions we have to look at. We need something which is safe, effective, and we want also accessibility in that regard. So we have a lot of long-acting preparations. If you remember, GnRH analogs were initially given as daily injections. Then it came up as inhaled one. And then finally now we have got monthly, 3-monthly, yearly also have come up. So this is something which is there. Long-acting octreotide, we talk about hyperinsulinism. Now it's available, so it's much easier to give. GLP-1 receptor analog, earlier daily, then weekly. Now I'm talking about monthly also have come in. So these peptides are becoming there. And insulin, Dr. Rishi talked about this molecule, Icodec, which is to be given once a week. So definitely there is a move towards less frequent injections, which will going to be important from that regard to improve adherence, convenience, and quality of life. So there is a role of long-acting growth hormone. We need to understand how do we achieve that. So the options which are there to prolong the action is either to give us a depot. Like you give a Lupride depot, you give a concentrated one, and then you have a small amount of product which is released. It's not much change in terms of chemical structure. It's largely the preparation that is being changed. The other option is that if you bind this particular product to a product which has got a longer half-life, then it will stay there for a long time. Classical example would be something like Degludec, where you bind it with albumin, it will stay there for a longer time, the half-life will increase. The third mechanism is to add a moiety which has got a longer action. And when we talk about gonadotropins, we always say LH, FSH, and HCG. HCG has the longest duration of action. So if you link HCG part to the molecule, the action will become bigger and more longer in that perspective. And finally, there is the option of pegylation, which also increases that. So these are the 4 ways in which most peptides have been made into long-acting ones. Now, it's not that the long-acting growth hormone is new. We all know about eutropin depot, which was there, once a week preparation. I think it was there for 10-15 years. And basically, you give it, it's there, and it's slowly released in a controlled one. It's a depot preparation, weekly injection. But like Lupride depot, often we talk about sterile abscesses. This also had local complications. So currently, it's only available in Korea. It's no longer available in India. So this is something which was there. However, we do have data which has shown that this was a good drug, which had a good response, very similar to a daily growth hormone with a lot of safety data. So there is now evidence of over a decade which is there for long-acting growth hormone with the use of this particular molecule, which is eutropin. Another way of doing it, as I said, is to bind something else. So this is a CTP, the C-terminal peptide moiety of HCG, which is tagged to the growth hormone. So you have the same growth hormone on which the C-terminal peptide 3 amino acids are linked. It increases the half-life significantly. So this is a GH fusion protein, and this is the somatogron, which was developed by Opco Pharma, and now it is part of Pfizer. Half-life is 28 to 35 hours, and the dose you use is 0.66 milligram per kg per week. So it's a weekly preparation because you have bound CTP. There have been multiple studies which have been done with regards to long-acting growth hormone, and these studies have clearly shown to be as effective as the standard treatment, which is the daily growth hormone treatment. It's available in the form of 2 pens, 24 and 60 milligrams, and you can give it, and it's like any other insulin. You can keep it 2 to 8 degrees, use it for 28 days. The maximum dose that you can use is up to 30 milligrams. So this is how you can proceed from that perspective. Now, the studies which was done, this was the first study which actually had 224 individuals who were given somatogron versus somatropin, so both in equal arms. And this was screening randomization and a study which was done for a year. Now, what we see is that there is no difference at all in terms of the daily versus weekly. Now, these studies will, of course, focus on non-inferiority. They're not looking at superiority, but if you're as good, but the superiority is there, you're giving it once a week. That's good enough. So from all endpoints, across genders, across growth hormone levels, this was found to be effective. And based upon that, it was given a FDA approval, then the European approval, and it is the only long-acting growth hormone which is currently approved in India. So this is something which we have been using also with quite efficacy. And if you see all parameters, you have got a similar scenario in that perspective. The adverse effect profile is also pretty similar. So it's a safe, effective, as safe and effective as daily growth hormone in that perspective. Other way, as I said, is to tag a molecule. So you tag something which increases the albumin binding. So somapacitan is a molecule which is developed by Novo Nordisk, in which it is tagged to a moiety which allows binding to albumin, increasing its half-life significantly. It's a linker one. The half-life becomes around 34 hours. So most long-acting growth hormone are 30 to 35 hours of half-life. And when you have 35 hours multiplied into 4, you have somewhere around 7 days. The dose is 0.16 milligram per kg per week. Remember, unlike growth hormone, where we say 25 microgram per kg or 50 microgram per kg, that's same for all preparations. Yet preparations are different. So you cannot say that, okay, this is 0.16, this is 0.66. The dose, of course, molecules are different. So you cannot compare that in that regard. So it has to be for every indication separately, available as 5, 10 and 15 milligram pens which are there. The study which led to its approval in the US was a real 4 trial in which they had treated it for 52 weeks and then followed up with somapacitan to identify that. And what they found was that there was no significant difference between somapacitan and daily growth hormone in that perspective. So clearly, what we are observing is that both drugs are as effective as compared to the standard preparation of daily growth hormone. This is interesting of IGF-1, and I'll talk about that a bit later. There would be a bigger rise in IGF-1. So while daily growth hormone, it will remain more stable. For the long-acting, you may have a peak and trough. Peak and trough. So this is something when you're monitoring, you have to be bothered about that and concerned about that in that perspective. The pegylated compound, the lonapeg somatropin, is a long-acting one, which basically is a prodrug, which is bound by pegylation, and it is transiently pegylated and then removed. We know about erythropoietin and many other agents which are pegylated. So it's not a new technology. It's an old technology which is being used now. With this, half-life is around 25 hours. Dose is 0.24. So it's 0.16, 0.24, 0.66. But then these are different compounds. So don't compare the dose per milligram basis in that regards. This is the one which comes as an auto-injector. The other ones are like pens, which are there, which are available. Now this study again, and this is one study which actually shows a better response. So this actually is a small study, but it does show that it does better compared to the daily growth hormone. And this is something which has been shown from that perspective. And overall, if you can see, the forest plot is going more in favor of long-acting growth hormone. But yes, it's a small study, so you can say it's at least non-inferior for all 3 studies in that regards. So if we compare the 3 products, currently we only have somatogron, which is available. It is addition of HCG moiety, dose is 0.66, pen device, and then you will need 2 injections if the weight is above 45 kg. Now, this is important because if your weight is much higher, you cannot give anything beyond a 30 milligrams. So you will need a second injection here, and you can use basically within 28 days. Dosing window is 3 days. So if there is a gap, you can give within 3 days. So catch-up dose can be given. Somapacitan and lonapeg are not available, but they have similar profile. The upper limit is 50 and 60 kgs. And then again, you can use it for 42 hours. Lonapeg is, of course, a single injection. You have to use within 4 hours of that. So these are the 3 comparisons which are there in terms of that. And I'll recommend all of you to go ahead and look at this consensus statement on long-acting growth hormone, which is there. Importantly, Indian approval currently is only for somatogron at the moment. Now, if you compare the 3, you can see pretty much they are similar as far as height SDS and adverse effects. So pretty much at the moment, there's no head-to-head trial, but their cardinal studies are similar for both these agents in that perspective. So now to talk about a few practical aspects. Most of us do not have that much practical experience. So good that we have got a consensus guideline which will guide us about that. So what about this case? They want to shift to long-acting growth hormone. What should we do? So this has been published in JCEM just now, 2025. It talks about a lot of practical issues. There are issues which are unresolved, but they do talk about that. So they're saying which children should be given long-acting growth hormone. Of course, we would say at risk of poor adherence. So what they're saying is taking multiple medication, children living in 2 homes, children going for vacation. So these are all the indications, but pretty much they are more like a Western based recommendation. Our recommendation will of course be with regards to the cost. So the cost typically will be at least double what you're giving as a daily injection. So you have to be aware about that. So main in India would be the cost issue probably, which will be the consideration. Now, how do we start? So when they are switching, what they say is that you are giving daily growth hormone, you give it on the next day. So you don't have to worry, just start from the next day, long-acting growth hormone. You can start off that. There is no catch-up dose. If you are giving, replacing from one to the other, which is not going to happen in India, then wait for 7 days. This is what they have recommended. Now, what happens is that this child has been shifted to long-acting, but has missed a dose. Now, what can we do? That is the other question which will come on to that. So what they say is that don't worry. If you have missed it by 2 to 3 days, no problems. It won't affect the efficacy. You can give it on that perspective, but try not to do that. This window is plus minus 2 days for somapacitan, for Lonapeg, and plus minus 3 days for others. So roughly 2 to 3 days. So this will give you more flexibility. Suppose somebody is going somewhere for vacation for 3 days and the day is coming there. Don't worry, give it once you're back in the home. You don't need to carry that pen there. So this is something which is going to be another beneficial effect from that perspective. Very important issue is safety. Now, many people say that if you give a potent injection, levels will go up. And if the levels go up, whether there will be side effects or not. So on follow-up, the IGF-1 is plus 2.2 SDS. And we know we want to keep it below 2 SDS, preferably 0 SDS. This is what the aim is. Now, very important thing to remember is that when have you taken that IGF sample? We know that course is like that. So ideally it should be done on day 4. If you don't take it on day 4, you will say falsely high or falsely low. That is important. So this is something, if you do it, this is the profile, the levels will go up and come down. So if you take here, it will be low. If you take here, it will be low. So day 4 is when it is recommended to take the sample. And there are calculations which have been made. Okay, if you don't take on day 4, how do you correct it? Plus minus. So do the IGF-1 at day 4. So as you say, when you talk about 1000 milligrams of testosterone, you say take a trough sample. So you know when to assess the response. So therefore, day 4 IGF-1 is what is recommended. So now weight is 50 kgs. What do we do? I've already said that once the weight is above 45 kgs, the dose will be above 30 milligrams. You cannot use a single injection. So then you have to give 2 injections, and this can be a bit of a problem. Either, so it's not that you can make it like more frequent. Better is to give 2 injections. So this becomes a bit difficult to see how it happens, but then this is the issue to follow. 10-year-old girl with DHD, height is minus 2.4, but BMI is more. So obese children. Now we know in obesity, how do we calculate the dose of growth hormone? Whether we calculate per body weight or body surface area. European people were using body surface area because they were saying otherwise unnecessarily you are giving high dose. But here all the recommendations are based upon the body weight and not body surface area. So this is a controversial area. What to do? So what they have found that if you use dose which are very high, suppose somebody is 80 kg, then you are going to give a huge amount of growth hormone. So in that case, what they have said that consider in obese children, lower dose, or you can use ideal body weight to decide about the dose. So these are the 2 important considerations that they have given, and to avoid hyperglycemia, which has been reported on this scenario. Very importantly, if you give a high dose, of course, all the side effects, benign intracranial hypertension, slip capital femoral epiphysis may happen. So other conditions where you have severe GHD, start with a lower dose. Now, many of us do start with 0.48 milligram per kg of somatogram. And sometimes we get good response and then we build up to 0.66. It is one of the cost issue. And second is sometimes you may get good response in somebody who has got a severe deficiency from that perspective. Now, 1-year-old boy with multiple pituitary hormone deficiency diagnosed in the neonatal period because of hypoglycemia. Now, whether this child can be shifted to long-acting growth hormone is the question. He's on growth hormone, cortisol, thyroid. The problem with this is that LAGH may not be very, very effective in preventing this hypoglycemia. IGF-1 is high and low. So you may have trough period, you may develop hypoglycemia. So if a neonate has hypoglycemia because of GHD, do not use a long-acting growth hormone. 1 to 3 years, there's no study anyways. So most people won't use it, but avoid it, especially if there is a risk of hypoglycemia. So this is one indication. You should be careful about that. And if there is hypoglycemia, then you may increase the frequency. So you don't wait for 7 days, you make it 5 days. This is what is recommended. But I will say stick to the conventional daily growth hormone in that setting. Another question is a child with craniopharyngioma who is post-surgery, and in that scenario, the growth velocity is low, whether we can start growth hormone long-acting or not. Now, these children, we are worried about whether the malignancy can develop, whether IGF-1 goes high, it may be a problem. So at the moment, there is not much evidence to support the use of long-acting growth hormone clearly in this indication. 6-year-old girl with short stature, FSH was high, karyotype is XO. Turner syndrome, can we give long-acting growth hormone to this child? Now, studies, again, there are no data on non-GHD indications. So in India or even globally, there is no approval for long-acting growth hormone for non-GHD conditions. So I would summarize that we should use it beyond 3 years of age in GHD individuals who do not have a neoplastic pathology. So I think this will be the way to go forward. So I think to summarize, long-acting growth hormone has shown to be efficacious in terms of lesser injection, good safety, efficacy, but accessibility is a problem because cost is high. I'm sure with more products coming in, the cost will come down, as we have seen with other agents like GLP-1 receptor analog, GnRH agonist, and this would be a good way to go ahead in terms of therapy. And I'll conclude on that. Thank you.
Yes, thank you very much, sir, for updating us on growth hormone preparation. Yes, that is a need. If you really want a good result, compliance is going to be issue, and unless and until we are going to take care of compliance, we are not going to the expected results. But there are so many lacunas still we have to wait and watch, particularly for non-GHD other recommendations. So still we have to wait. And since there is only single brand which is approved and available in India, let us see how it is going to.
So definitely just to finalize, cancer subjects, early childhood, non-GHD and obesity. 4 areas we are still not very clear, even globally on that regards. So now I think we'll head towards the next talk. Dr. Hemchand, who will talk about, who's always fascinated us with his wonderful talks about futuristic treatments. So he's talking to talk about novel therapeutics.
I think newer therapeutics is a very exciting topic, and I think this audience, it's a very relevant topic as well. So the general theme would be, when, as a physician, when would we consider the newer therapeutic agent? What does the current literature tell about the dose and administration? What is the mechanism of action of this newer therapeutic agent? From a practical perspective, what would be the pros and cons and the way forward? So I have divided the newer therapeutic agents into 4 groups. Group 1, drugs which are available, approved, and they are eligible to be used in children, but there is a physician inertia in using these agents. How do we tackle that? Number 2, drugs which are approved, used routinely in adults, anecdotal reports of their use in children. How do we tackle that? Number 3, drugs which are known to be efficacious in children in specific situations, but procurement of these drugs is a challenge. How do we tackle that? How do we use them? And drugs that may be available for use in the future. So what are the drugs? Number 1 would be aromatase inhibitors in short-statured children. So today morning we had a good lively debate on the use of these agents in constitutional delay of growth and puberty. But these drugs have been used for quite a long period in children with idiopathic short stature and children with growth hormone deficiency who are diagnosed late. So aromatase is an inhibitor that is located in the bone, that is located in the testis, that is also located in the brain. So you can be having these agents in the first, second, and third generation. And the commonly available literature as far as this particular drugs is pertaining to the third generation drugs, that is the anastrozole and letrozole. So where, as a physician, can I consider use of these aromatase inhibitors? You can consider them in children with growth hormone deficiency who are coming in the verge of epiphyseal fusion. They present at 18 years with a bone age of, say, 15 years, etc. There should be a thought on use of these agents. Second is children with idiopathic short stature who present late, and the prediction equations are telling you that they are going to land up below the third percentile. So these are two situations where a strong consideration could be given. The recommended dose in many of the studies would be anastrozole and letrozole in the doses that are depicted in this particular slide. And the mechanism of action, as all of us are aware of, is it inhibits the enzyme and prevents the conversion of the testosterone to estrogen and delays the epiphyseal fusion. So what are the pros of use of these drugs? I think the improvement in terms of final height in various meta-analysis is somewhere to the tune of about 2.5 to 4 centimeters with varied duration of treatment, somewhere between 2 to 4 years of treatment. I think this is something which we have to look into very carefully, because the prediction equations which have been done in those meta-analysis are based on varied techniques of skeletal maturity assessment and varied equations that have been used to calculate the predicted adult height. A couple of studies have included data pertaining to the final height, but they are in single digits. So I think, yes, there is a lot of emerging and a thrush towards the use of these agents. But the cons that we would have to remember is the impact of these agents on the vertebral morphology, the impact of these agents in the spermatogenesis, and the third would be very limited use of these agents in prepubertal children and girls. I think girls, again, there is a lot of recent data on use of these agents in adolescent girls, which is described as the Gale study, but still, they're all very small sample sizes. And the last thing that we have to remember is consider the use of aromatase inhibitors in children who present growth hormone deficiencies who present late and idiopathic short stature after taking a proper consent, and preferably an ethics committee approval. And we'll have to see how the data emerges. Probably it may be a promising thing in the future. Transdermal estrogen. I think this is something where we are really lacking. These are transdermal preparations of estrogen that are available in the market that can be procured. They are affordable, and this is how the literature describe how these transdermal patches should be cut to deliver the accurate doses. And there is plethora of literature available on how these agents should be used, and most of the data tells us that they are comparable in terms of efficacy, in terms of the induction of secondary sexual characteristics, growth of the internal pelvic organs, and in terms of better metabolic side effects. So indication for use of these agents would be in Turner syndrome, girls with hypogonadism, especially in the presence of metabolic complications like dyslipidemia, like early onset type 2 diabetes. This builds a strong case for use of transdermal preparation. You start with these preparations in a dose of about 3 to 7 microgram per kg, and literature tells you how to cut these patches, and there is a lot of data to tell you the stability of the patches are maintained despite cutting as well. So, and you would also probably have to monitor the estrogen levels to ensure titration of these drugs. The estrogen is absorbed into the capillaries and delivered into the bloodstream. And the plasma estradiol levels are expected to remain stable. The advantage, the pros, the thrust for these agents comes with lesser cardiovascular risk, reduced risk of thrombosis, reduced metabolic complications, and you have robust levels that are available for titration and optimization of these doses so that you mimic physiology. And of course, the cons would be in a busy school-going adolescent, the practical aspects of application of these patches, the skin reactions that have been described in literature, and poor addition of these patches. So I think this is something which I think I would encourage the practitioners and all of us to use these in right settings and report them. Long-acting octreotide. I think sir gave a very nice talk yesterday. I think if you look up literature from Indian setting itself, there is data pertaining to nearly 30 to 40 children who have been given long-acting octreotide from South India, from West India, and from North India. And there has been clear indication that it is efficacious, not only in diffuse, but also in some cases of focal. And there is a good group of children where the daily injections are stopped, and it is helpful not only in the diazoxide responsive group of children, even in the diazoxide unresponsive group of children. I think so there is a strong case for use of these agents at least above the age of 3 months. So once you tide over the newborn period with octreotide, there is a push for you, and of course improvement in quality of life. There are only anecdotal reports of not responding to this, going in for more advanced forms of therapy. So the indication would be children with PHHI requiring multiple octreotide injections to maintain sugar levels. You would have to calculate a monthly dose based on the daily dose and give a cumulative dose once in a month. And probably because the preparations are available in higher strength, they may have to be pulled together and administered. It suppresses endogenous insulin production, lesser pricks, as efficacious. The cons would be long-term safety, how follow-up period after use of these agents, what is the long-term results is not known. And of course, they need to have their growth and thyroid functions monitored, and liver function test, which was very beautifully highlighted in the previous case yesterday, has to be thought of. Lot of Indian data, as I said, is available. I think this builds a case for us to use them. The fourth drug I would say is sirolimus. There is, again, I have summed up the literature on the cases that have been used from our own country, somewhere to the tune of around 15 to 20 children. What is interesting is the drug is available, and there is an explosion in the use of this drug, not only in diffuse cases as per the original trial, but also in children with focal as well as residual disease after a surgery. So the dosing guidelines are available, and of course, it needs to be managed by a team with a good support from an ICU backup as well as a hematologist who can help you. The outcomes are varied. The dosings are different in different studies. I think you have to start on the lowest dose and slowly advance the doses. So children who are resistant to medicine and require high GIRs can probably be considered. You start off on a small dose, 0.5 mg per meter squared. You can go up to, literature says, 5 mg per meter squared. And of course, it is an mTOR inhibitors. It avoids the need for pancreatectomy. But the side effects have to be explained, and including the life-threatening risk of infections and the various systemic side effects. Always prefer to use it in a higher center with an ICU and a hematology backup. So now I come to the second group of drugs which are used in adults, emerging role in children. The first one is an extension of what was discussed today morning, recombinant parathyroid hormone for hypoparathyroidism. This is a very beautiful review where about 70 to 80 children have received parathyroid. So it's not that it's an experimental drug. From good centers, about 70 to 80 children have received parathyroid hormones, and follow-up of this is available till about 10 years. So it is indeed a safe drug. But the context of usage it has to be very clearly defined. So this is an Indian study who have used the use of, described the use of parathormone in an acute care setting, in the ICU, where they found the hypocalcemia to be really refractory. They proved the condition and they administered, and they brought the child out of ICU. At least short-term data is available. So etiologically confirmed cases of hypoparathyroidism with the development of renal complications or requirement of second-line drugs, phosphate binders or thiazides, there builds a strong case. The dosage would be 0.5 to 1 microgram. You can slowly advance it to around 5 to 10 microgram. It is a physiological replacement of the hormone. The benefits would be, as discussed, better renal function, better control, no need for second-line drugs, improved bone health, etc. But of course, the black box warning of osteosarcoma really tends to haunt us. Patient consent and appropriate monitoring would be the way forward. Monoclonal antibodies in genetic dyslipidemia. I think Dr. Hari gave a very nice emerging role of this novel therapeutic agent, especially in children with genetic dyslipidemias, where it's a losing battle in most of the situations. I think this is an Indian report of the use of this biological agent in a North Indian girl. And the authors have very beautifully from PGH Chandigarh, and where the authors have very beautifully described, you can see the decline in the LDL cholesterol after from the 3-digit numbers to 2-digit numbers. So I think it seems to be a wonder drug, at least in a short-term basis. And you can see beautifully the graphical representation of the decline in the lipid parameters after use of this biological agent. So I think this is a novel therapeutic agent that looks very promising. So not responding to conventional therapy. These are the dosing guidelines, subcutaneous and the intravenous dosing guidelines. It delays the clearance of the receptors and improves the receptor expression. About 80% reduction in LDL has been reported, and this author from PGA, who has, I think, Sir's student, who has reported it, and this seems to be a very promising drug. The side effects are very minor. The way forward would be taking a patient consent, ethical clearance, explaining the pros and cons, and of course, explaining the fact that we are in a desperate situation and something is better than nothing. And I think the short-term efficacy of this drug in anecdotal case reports is very promising. The third drug, I think this would be, I wouldn't really, this is a child with precocious puberty. Maximum doses of GnRH analog treatment have been given, but what next? So this is building a case for GnRH antagonist therapy, which is probably used in young ladies and women with endometriosis, which is available in market. And anecdotal reports of use of these agents as daily injections are available. So how frequently we encounter, maybe once a way, maximum doses of GnRH analogs you have gone to for the age and weight, and still you're not able to control the disease in terms of the growth, the biochemical parameters, and the skeletal maturity. So you can start off with these are the dosing guidelines. You go on with weekly and then go in for bi-weekly. This I've just taken from the case report that has been. So the rationale is these agents act not only on the brain but also on the gonads. So dual hit kind of a theory and acute suppression of the hormonal disease. And the advantage is there is no initial flare of this drug after initiation, which is usually encountered in GnRH analog treatment. Of course, more frequent injection, higher cost, and lack of data remains the challenge. You can consider it on an individual case based after probably a team discussion and taking the consent and ethical approval. And of course, this is the next promising drug, denosumab. Difficult OI. You have gone to the maximum permissible limit of bisphosphonate, zoledronic acid, and the fracture just doesn't seem to come down. I think there is a lot of studies. If I summed up the number of children, there are almost about 400 to 500 children who have been given this agent. But the dosing guidelines are very, very varied in terms of 1 mg per kg. In some studies, it's 60 mg extrapolated from adult. And they have given the rationality of description of these. So dosing is not very clear. They are monoclonal antibodies that target the rankle, and it is supposed to be efficacious and helpful in these children in terms of improvement in the bone mineral density, improvement in the fracture frequency. The big worry is rebound hypercalcemia. In fact, there is literature described of almost going to the range of hypercalcemic crisis warranting ICU care. So this is something which we have to keep in mind. But I think this is a promising drug in the days to come, denosumab, for refractory, difficult to treat OI. Probably in the days to come, we are going to see more children being treated with this. So coming to the third group of drugs that can be procured with efforts from out of country and used in the right situation. Burosumab. Burosumab, in genetically confirmed cases, it's a monoclonal antibody that directly addresses the pathology in terms of blocking the FGF23 activity. and it is known to improve the biochemical, clinical, and well-being of the child. So the consideration can be given in children who have a genetic confirmation beyond the age of 2 years with adverse reaction to conventional therapy. So that would be the case for giving this treatment. The dosing guidelines are 0.8 mg per kg, given as subcutaneous injection probably once in 2 to 4 weeks. It is a recombinant antibody that blocks the action of FGF23. The documented and well-established benefits include the increase in the serum phosphorus, improvement in the biochemical parameters, improvement in the radiological parameters, the improvement in terms of the side effects of the medication and quality of life. The cons would be unclear impact on the deformity, the primary deformity, what happens to that, long-term safety, and a very interesting condition of restless leg syndrome, which has been described in some children who have been treated with this. The way forward is probably making the drug available, more prospective studies after making it available in our country, and consider early burosumab treatment and see how these children do would be the way forward as far as this drug is concerned. This is recombinant IGF-1 in children who have genetically confirmed Laron syndrome, the use of recombinant IGF. As far as Indian data is concerned, there is one case report from APES who have described a growth velocity. They are desperate. They are extremely stunted. They have a therapeutic agent, but they're the practical difficulty in filling the fuel of the car. This is the report from APES who have described about 6 centimeters with continuous treatment per year treated for growth hormone. Our own center, we have one child which we presented in the APES meeting with a genetically confirmed Laron syndrome, IGF deficiency, and we found that the height Z-score improved from -7.9 to -7.2. So it's probably marginal, but for that it is like seeing an oasis in a desert in terms of the growth. So it's a desperate. I would really like to highlight that a genetic confirmation is necessary. And some practical experience, hypoglycemia is a big problem. CGM has been reported to be helpful, which was helpful in our case as well. Insulin syringes, 100 IU syringes were used to administer drug in appropriate doses. There is a very beautiful BSPED guideline which describes how it should be used. And this is a prohibitive cost. When the child was started on a low dose, the cost was around 55,000 per month. And now it is escalated to nearly 1.5 lakhs per month, which they are paying from the pocket. And it really builds a case for advocacy. So recombinant IGF-1, you genetic testing is preferable, 80 to 120 microgram twice a day per dose. It improves the oxology, improves the final stature. Hypoglycemia, tonsillar enlargement, and raised ICT should be looked into. Hypophosphatasia is another important condition, genetically confirmed disease with low alkaline phosphatase. You have to always compare it with the norms, and probably you should also keep in mind a genetic confirmation is necessary. There are specific designed criteria on replacement of alkaline phosphatase in children with a genetic confirmation. So these are the guidelines. So with a genetic confirmation, you start off with this agent 2 mg per kg on alternate days and slowly escalate it. And the benefits cannot be overemphasized. Reduce pain, disability, increase in the ALP, reduction in the fracture, improvement in the growth, etc. The development of antibodies, local reactions, and vascular calcification is a con. I think the way forward would be the prohibitive cost, the import taxes, and reaching it to the right patient. An Indian case report from one center in South India, in Mysore, authors have given a dose of they have started the treatment of recombinant ALP in a child, and they have reported it in IJEM. And what they have observed is there's a good improvement in growth, radiological parameters, the motor milestones, and the developmental milestones. So I think this is a promising treatment, a novel therapeutic agent, which can be procured and offered in our setting. Vosoritide, I think there is a lot of data coming up in terms of use of this agent in children who have a genetic confirmation of achondroplasia. above the age of 2 years with a genetically confirmed disease, 15 mg per kg subcutaneous injection. It restores chondrogenesis, acts on the NPRB, resulting in down regulation of the signaling pathways. The benefit would be 1 to 2 centimeters addition per year of treatment given. So on a long-term basis, again, the quantum of response may not match the efforts and cost, but at least it's an oasis in a desert in terms of these children who are so desperate for improvement in stature. I think this is a very promising drug, and the availability of data. And of course, the worry would be the side effects in terms of obstructive sleep apnea and tonsillar enlargement. Teplizumab, another promising agent, which is approved, as all of us are aware, in children with type 1 diabetes in a pre-symptomatic phase with 2 positive antibody reports aged above 8 years. The drug can be procured as an imported drug from outside and probably given after ethics approval and patient consent. It is given as infusion over a period of 14 days in small escalated divided doses. The dosing guidelines are available. You start off with the cumulative doses 9 mg per meter squared. And what the data tells us is the onset of type 1 diabetes is delayed. So I think this is a very, very important, promising drug, novel therapeutic agent, which really can make a big difference in their future. The last group of drug is pertaining to children with congenital adrenal hyperplasia. We have a lot of work that is going on in terms of acting CRH receptor antagonists who work on the pituitary and bring down the ACTH pulses. Modified release hydrocortisone, Chronocort and Plenodron, which kind of sustain and reduce the dosing frequency and help to mimic physiology. Granular forms of hydrocortisone, which help to give infants with smaller doses, and adrenal biosynthesis inhibitors in children who have very high androgen level despite having good. This is a sum up slide describing the pros, cons, and dosing guidelines for all these agents, which is there in a lot of published articles. The con is the use of these agents in sick days is a big question. The long-term safety, availability, these are the 3 problems as far as the novel therapeutic agents are concerned. Probably in the days to come, we are going to have it more helpful in our children with CAH. So, of course, I think to sum up, the Indian Society of Pediatric Endocrinology has taken a lot of effort. I think in terms of setting up of advocacy groups, and this would be the way forward in terms of the prohibitive cost. It's like you have a battery of therapeutic agents and you have a whole lot of children who really would be benefited. I think connecting the two in fighting the prohibitive cost in terms of inclusion of these diseases in the rare diseases group, or finding some ways, reduction in the import taxes. I think the problem comes with when you procure these drugs, the parents tend to pay a whopping amount in terms of the taxes. So probably as a society, when you write to them and you try to get the import taxes waived off, regulatory clearance, right, writing from the society to the DGCI to include these drugs in their list, so that the regulatory hassles which clinicians, when they use them, go through can be subdued, and limited Indian data, and probably help in ethical clearance of use of these drugs. So advocacy is the way forward. I sum up with the 5 R's: a right indication, a responsible physician, a rational use, regulatory clearance, and reporting them in literature is probably the way forward to reach these children to the right children. Thank you. Thank you very much.
So inputs from the panel.
Thank you, Dr. Hemchand sir, for a nice presentation, and it is really mesmerizing. And we are looking forward that how the things can be applied. And once we are going to apply, and of course, that procurement from the government side and to be inclusion in the rare disease is going to be a way forward for this these things to be used. Thank you.
I think a lot of wonderful drugs you have talked about, and I'm sure there's going to be an evolving role of many of them in the near future, especially things like IGF-1, which are clearly proven, Borosumab. These are agents which are very good, and they're going to change things up in that perspective. Thanks a lot, Dr. Hemchand. We'll now move forward to the last talk of this session by Dr. Anshul Agarwal, who is a leading endocrinologist practicing in Jhansi. And his topic is also very interesting. So this is more of an advanced topic. We talked about lipid disorders. We talked about PCOS. We talked about novel therapeutics, long-acting growth hormone. So his task is to talk us through about new developments in thyroid disorders. Over to you, Dr. Anshul.
Hello. So first, I would like to thank Anurag Vajpayee sir to have invited me in this wonderful scientific conference, and it's very delightful that we see such a high level of discussion over here. So I have been today allotted the topic on thyroid treatment advances, and first of all, I would just like to highlight a new drug which has been approved for hypothyroidism, that is leothyronin. So in general, what we know about marker, this one, long press. Okay. So levothyroxine monotherapy we are generally using in hypothyroidism, and general dose is 1.6 microgram per kg per day adult. But mainstay for treatment for this is that generally it gets converted to LT3, and this T3 is not fully restored in LT4 treated patients. And we see that 10 to 15% of subset of patient might not be able to resolve with the symptoms in spite their TSH is normal. So if we see those patients biochemically their TSH is normal. However, T3 is either low or slightly on a low normal side, but T4 is on higher side. So those subset of patient will have persistent symptoms. They might be unhappy. And most common mechanism which has been postulated for that one is there can be a genetic polymorphism of deiodinase 2 enzyme where there's lesser conversion of T4 to T3. This is what, if you even normalize the TSH levels, the T3 might not be able to restore hypothyroidism in the cellular level, and that is called as tissue hypothyroidism. So tissue hypothyroidism, many patients might complain psychological symptoms. So even we might be seeing some hypothyroid patient, they are not satisfied with their treatment in spite their TSH being normal. So they might be having some symptoms like lack of energy, cognitive issues. So what does guidelines suggest? This has been come up in India in last 1 or 2 years, but it has been under usage in Europe since long. And we have now 15 years been used in Europe. And 2012, ET have come up with the guidelines that it could be used as an experimental approach, especially in those patients who are having persistent symptoms. Next, in 2021, there is a consensus statement also that even in refractory hypothyroidism, that is when they are requiring more than 2 microgram per kg per day of LT4 dosing, those patients again, you can consider using leothyronin. Even in perioperative use, you can still use, because we see many patients perioperatively, they are frank hypothyroid and they want to undergo emergency procedure. So what to do in this case? We can give T3 along with T4. And this is one data from Venkatesan et al. Where T3 was given along with T4 in 12 hypothyroid patients at a dose of 20 microgram 3 times a day, and they underwent successful surgery. Post-surgery, they were put on levothyroxine alone. Even DCGI is approved in some special scenarios, a usage of leothyronin. Dosage recommendation is you have to use the dose by 20:1 of the ratio of leothyronin by levothyroxine has to be used. So ideal dose should be, starting should be 5 microgram and you can increase to 20. But elderlies and children's, you should be cautious, start with the very low dose. So ideal dose of T3 is T4 dose by 20, and T4 dose should be corrected according to the T3 dose. So thrice of the T3 dose should be subtracted from the actual levothyroxine dose. So for example, if the patient is on TSH normal TSH on 100 microgram of thyroxine. His LT3 initial dose would be 100 by 20, that is 50 microgram, 5 microgram, and 3 times of that should be subtracted from that original dose of levothyroxine, that is around 88. So this patient will be put on 88 microgram of levothyroxine along with 2.5 mg BD of leothyronine. So this trial should be done for 3 months, and if it works, so this mind it, this is an experimental approach, and if it works, you can continue with the leothyronine or increase the dose of leothyronine and accordingly subtract the levothyroxine dosing. Some contraindication that there could be hypersensitivity, cardiovascular diseases you should be avoiding, and in pregnant patient again, you should be avoiding. So euthyroidism should not be taken into granted that we have achieved biochemical euthyroidism, but also look whether patient has achieved clinical euthyroidism also along with biochemical, in which LT3 role might be useful. Next, I would just like to highlight congenital hypothyroidism. Dr. Anurag sir has told me to consider that also. So generally, there could be the cases like dysgenesis, agenesis, dysharmonogenesis, rarely resistant to TSH or congenital hypothyroidism. ISPE guidelines only generally we follow, and this is when if the TSH is more than 20 in the initial first screen, and you find that TSH is very high, more than 80, you just directly start with treatment. Just take the FT4 sample also. If TSH is more than 40, look for again FT4 level. If FT4 is very low, that is less than 1.1 microgram per deciliter, you start treatment. And if it is slightly low, that is less than 1.17, and you find that TSH is still more than 20, you consider treatment. So if these criteria are not met and TSH is greater than 20 till 2 weeks or TSH is more than 10 till 3 weeks, you consider treating those patients. So treatment is with 10 to 15 microgram per kg. Initially, goal is to normalize free T4, and next you have to normalize the TSH. Follow up initially in the 15 days, then 1 month, 2 month, and then 3 monthly. Next is the part of diagnosis, that is about the imaging. What ISPE recommend, USG and technetium scan both are complementary to each other. If there is an absent gland, that suggests agenesis, small gland might suggest dysgenesis. Enlarged gland causes could be either iodine deficiency or even dysharmonogenesis. Cases transient congenital hypothyroidism should also be looked for, especially those who have intact thyroid gland or dysharmonogenesis patients. There could be a reversibility, but ideally you should continue till 3 years of age and then discontinue levothyroxine. So after 3 years, what we can do is we can discontinue for 30 days. And after this withdrawal, thyroid is rechecked. And if patient is euthyroid, patient levothyroxine dose can be discontinued. Next, which is a newer thing which has come up, is about the thyroid eye disease. Graves' disease, we do see that patients will develop ophthalmopathy, and some patient, 30% of patient in fact, will come up directly with the eye disease and then land up in, you see that they are hyperthyroid. So basic physiology is that there is an orbital fibroblast where you can find that receptors, there is a co-localization of receptor, thyroid receptor and IGF-1 receptor. On these receptor, TSH stimulating antibodies bind and they causes multiple inflammatory cascade, plus which causes pain, swelling in the eyes. Plus there is an increase in the adipocytes and myofibroblast. Myofibroblast causes increase in the extraocular muscle size, which restrict our movement, and adipocyte and increase lead to proptosis. So these are quite troublesome to some patients with Graves' disease. And there is a new therapy which is directly acting on IGF-1 receptor, that is teprotumumab, which is the main thing which I want to highlight. So first of all, we'll just have a short discussion that how we generally treat ophthalmopathy. Clinical activity score is taken into consideration. If it is more than 3, that suggests it is an active disease. And those patients will be treated with high dose of IV steroid. UGOGO guideline also recommend that mycophenolate can also be added. Now, glucocorticoid, normal dose is you have to give 500 mg of IV steroid for 6 weeks, followed by 250 mg IV steroids for next 6 weeks. That is total 4.5 grams. In some cases, you might have to extend the dose to 7.5. However, if you go beyond 8 gram, there is a serious risk. That is, it could cause liver damage, electrolyte imbalance, arrhythmias, and hence we generally avoid high dose steroids. So next line would be considering non-steroidal immunosuppressive therapies. In general, these are some therapies like azathioprine, which has a possible benefit, not as a monotherapy, but as an add-on to steroids. Next, cyclosporin again has been studied as a complementary add-on to steroids. Mycophenolate and even orbital radiotherapy have some mixed role which has come up. Methotrexate has a limited evidence. Some adjunct therapy which are generally considered, that is, one is statin, which has been useful in especially in hypercholesterolemic patient, and next is selenium, which has shown some effects as an antioxidant effects and thyroid protective effects, especially in the dose of 200 microgram per day for 6 months. Next, other than steroid and non-steroidal sparing agents, there are agents like biologics which have come up with a good role. One, tocilizumab, is an IL-6 receptor blocker, which have shown that clinical activity score has been reduced by almost 92%. Rituximab, we are all been using if the steroid fails. Initially, 1000 mg rituximab was used. Now, it has been found that even the low dose, 100 to 500 mg, has been found to be quite effective because higher dose led to cytokine release syndrome and there are a lot of side effects. Now, newer drug which has come up is teprotumumab, which is actually a IGF-1 receptor inhibitor. So this drug has got great role in terms of thyroid eye disease. So it directly blocks the TSH receptor antibody binding to IGF-1 receptor and led to decreased adipogenesis, decrease in the extramuscular muscle growth, as well as inflammatory cascade. So this is the first drug which was done in the OPTIC trial, first drug which has shown that or not only improve the active disease, but have also role in the proptosis. You can see one subset of patient where there's lot of proptosis, and after 24 weeks, his not only active disease resolved, but proptosis improved. So this is an IV infusion which has to be given every 3 weeks into 8 doses. So this has been now FDA approved very recently in January 2025. And other drugs like rituximab are still off label other than steroid. So there are again future therapies which are being considered in thyroid eye disease like IGF-1 receptor targeting agents, TSH receptor blockers, and combination of both. Thank you.
Thanks a lot, Dr. Anshul. And there have been so much development which have been taking because we have always been saying only T4, but T3 definitely is something which is coming up. And especially for congenital hypothyroidism, many times children are very, very poor in terms of thyroid function. It takes time. So that is the best time to use probably in that regards. And then, of course, hemangiomas and other situations also which are there. Dr.
Regarding the use of T3, actually it's a very rapid onset. So whenever you're using this drug in patient with the cardiovascular diseases, you need to be very careful about that.
Yes. That is something which is very, very important. And T3, so don't use it very loosely. Clearly, if somebody is having clear-cut indication, it's okay. But sometimes they use it like a stopgap. You use it for some time, and then once the compliance becomes better, they can use it from that.
So we have tried this drug in patients who have a very high dose of requirement of LT4, like 200, 225, not responding. We have used that drug.
Yes. The other use sometimes is that somebody who has a thyroid cancer and they cannot afford a recombinant
Yes.
TSH stimulation, then what you can do is that you can
So
stop
the-
T4, give T3, and T3 has a shorter half-life. So you can give a quicker gap on
Yeah,
that.
that's true. Thank you.
Dr. Prasoon?
To add on, we have also used T3 in myxedema coma, for example.
Right.
It has very good results.
Yes. So it's like when we say you have hypocalcemia because of vitamin D deficiency, you give calcitriol. That is the time, because calcitriol will build up your levels quickly. And then you can use your 25 vitamin D, which will go slowly. Same is here. T3 is to bridge the gap, and then you can take over the long acting one. But the preferred treatment is T4 very clearly. Dr. Manisha?
It was, I think you have said everything.
And Dr. Final words, I think this is the last talk of the session.
Yes, this is really good. And now we are going to have that, we have to take a pinch of salt, that we have to make a bridge. So to build up the level, probably we have definitive role of T3.
Thank you, sir.
So I think this was a very wonderful session. We discussed a lot. I'll request Dr. Nimisha to hand over a moment of appreciation to Dr. Anshul. I'd like to thank the chairperson. I'll request Dr. Alappan to give a moment of appreciation to Dr. Prasoon. And Dr. Alka has been associated with us for a long time. I think we'll give a certificate of appreciation to Dr. Alka. And Dr. Alka did the fellowship with us, and she's, despite being a leading endocrinologist from Delhi, she specifically made a point to come again. And we love to have you in future events as well, with scientific contributions as well. Thank you. So I think we are reaching towards the end of this mammoth marathon program. There's only one session which is there, which is separating us from the conclusion and the lunch. So hopefully all of you can hold tight for another. It's supposed to be 1 hour. I'll try to finish off in 45 minutes. It's again an interesting session which is there. Over to Dr. Nimisha to carry forward.
Now coming on to the last session of this afternoon, I would like to welcome Dr. Vibha ma'am, Dr. Anshuls, Dr. Rajat, and Dr. Manoj to chair this session.
So Dr. Rajat somehow is busy with the surgery, so he'll not be there. Dr. Alappan, you can come. So we will redistribute the questions. There have been a couple of people who have dropped out. Dr. Vijay had to go. So Dr. Vibha is pitching in. Dr. Manoj is there. Dr. Anshul is there. So Dr. Rajat's question we will be putting up to one of you. So testicular disorders are very, very important, and they have huge implications. We'll be trying to focus on hypogonadism, undescended testis, micropenis, and gynecomastia, 4 conditions. And again, case-based approach with a bit of theory. So when we talk about the HPG axis, we know that the GnRH regulates the secretion of FSH, LH, and which then works on the testicular problem. So problems could be at the level of the hypothalamus, which is hypogonadotropic hypogonadism, or at the level of gonads will be hypergonadotropic hypogonadism. So hypogonadotropic hypogonadism, characteristically LH is less than 0.3. And you can most common causes constitutional. You can get other clues like anosmia, synkinesis, other abnormalities which will suggest the possibility of Turner syndrome. While if it's hypergonadotropic hypogonadism, you will have high levels of LH and FSH. Remember, LH is a better marker of pubertal onset. FSH is a better marker of gonadal failure. So when you're looking at hypergonadotropic hypogonadism, look at FSH. When you're looking at hypogonadotropic hypogonadism, look at LH levels from that perspective. And of course, Klinefelter is a very important cause there. Remember that the adrenals also produce androgens in that perspective, and which is responsible for pubic hair growth. So if you have somebody who has a problem of both adrenal and the pituitary, there will be no pubic hair growth. If you have problem only of the pituitary, you will have pubic hair growth. So if absence of pubarchy in a boy with delayed puberty suggests constitutional delay, functional illness, a steroidogenic defect, or a multiple pituitary hormone deficiency. A child who has got a pubarchy but who has got no other development, you think of a hypogonadotropic hypogonadism, or a stalled puberty because of Klinefelter syndrome. So these subtle clues become very, very important from that regards. And very important thing to remember is that the Sertoli cells also secrete inhibin B, and inhibin B precedes the rise of testosterone. So it is the best predictor of pubertal onset. And if you want to differentiate CDGP from HH, the best marker is basal or stimulated inhibin B, which is something which is already there. So hypogonadism usually in boys is physiological, self-limited puberty, or pathological, where it could be hypergonadotropic hypogonadism. Most common cause will be Klinefelter syndrome. Hypogonadotropic hypogonadism, in which you can have functional illnesses, less common in boys. Permanent causes, either multiple pituitary or most common isolated, lot of genetic causes. Yesterday we had the case in which Dr. Shweta presented of FGF receptor. There are a lot of genetic causes which can cause this scenario as well. For the individuals who have physiological, functional, or MPHD, pubarchy will be absent. So the most important thing to look at in a child with delayed puberty is the testicular volume and pubic hair. That will give you the classification, while all other cases pubarchy is usually present. Of course, FSH will be low and high depending upon hypo versus hypergonadotropic hypogonadism. So as I said, testicular volume is very important. If the testis is large and still there is no pubertal development, only one cause, this is hypothyroidism, because FSH is acting on the TSH receptor, stimulating the Sertoli cells, but Leydig cells are sleeping. So you will have large testis, no pubarchy, that will be the scenario. If you have small testis which are soft, that is GnRH deficiency. Tall child with the sparse pubic hair, with soft testis, hypogonadotropic hypogonadism. If you have intermediate size 1 to 3 ml testis, think of CDGP, while if it is a firm and shorty testis in a tall child with gynecomastia, consider the possibility of Klinefelter syndrome. So combination of testis and other pubic hairs will give you the clue from that perspective. Very importantly, since most boys, 70% have CDGP, you should know when not to think of CDGP. If there is pubarchy, stalled puberty, normal growth, or micropenis, these are pointers against a self-limited form of delayed puberty in that regards. And if the inhibin B is low, GnRH stimulated LH is low, and SCD stimulated testo is low, this is more likely to be a case of hypo versus a CDGP in that regards. So just to summarize the approach, always think of systemic causes to CBC, SGPT, creatinine, thyroid, celiac. If it's normal and testo is low, then you are thinking of high gonadotropin with low testo, Klinefelter, 99% of cases will be the case. If it is high, you're dealing more with a DSD scenario. That will be like partial AIS versus a scenario of 5-alpha reductase. Usually they will have hypospadia. So this will not present to you with typical delayed puberty. On the other hand, if the gonadotropins are low and you have pointers of HH like micropenis, undescended testis, anosmia, synkinesia, CNS features, you know this is a permanent cause, get an MRI done. If not, TV is less than 1 ml and inhibin B is less than 50. This is most cases a permanent HH. TV is above 1 ml and inhibin B is more than 100. It is clearly CDGP. So combine TV with inhibin B and you will know where you are heading on. On the other hand, if you have an intermediary value, you can do a GnRH test to distinguish between the two conditions. Now, androgen therapy, always remember, start with a low dose and gradually build it up. Start with around 50 milligrams, go up to 300. Use 12 weekly preparation only after 2 to 3 years of treatment when things have stabilized. Testosterone gel is there, but not for induction. And oral preparations are also not recommended. So for CDGP, we generally recommend 100 milligram monthly for 3 to 6 doses and see whether they are reversing or not. For permanent, we use testosterone from 50, go up to 6 monthly. There is also a possible role of using HCG and HMG to induce puberty in the setting of hypo. Even mini puberty people have used in that scenario, and hypergonadotropic only treatment is donor insemination. So with that background, we'll start with the case.
Thank you, sir. Good afternoon, everyone. So the first case, 14-year-old boy presented with delayed puberty. Family history was present in the father in terms of delayed saving in father. His height was on the shorter side, 152 centimeter, weight of 45 kg, and testicular volume of around 3 ml with a PBK stage 1. So
Dr. Vibha? Yeah, on. It's on.
So this is a 13-year boy. We cannot label at 13-year delayed puberty. And he is shorter. He has a height like shorter than his father, and definitely testis is prepubertal. And so at this stage, we cannot label him as a delayed puberty. First, we have to see what is the cause of like this shorter height, and there are no pointers of hypogonadotropic hypogonadism like micropenis, undescended testis. So definitely it is he is not delayed or the permanent hypo. So we have to look for the inhibin B, whether it is more than 100 or less than 50. So in this case, it is more than 125, so which is going more in the favor of CDGPs.
And we could have also waited in this case, but the parents were very concerned and they got a LH, FSH and testo which was 0. So then they got too concerned. We had to show them that inhibin B is there, but we can have waited, as you said, also for a year in this scenario. And this is classically CDGP. Now, how will you manage in this scenario, Dr. Vibha?
So in this case, as you have mentioned, that we can start with 100 milligram of testosterone. We'll give 3 doses, then we'll see what is the response. If it is CDGP, definitely the puberty will come. But if it is the case of permanent HS, then we have to increase the.
So 3 to 6 months reversal is what we are looking at. So self-limited form, Dr. Alappan.
So CDGP usually presented like testicular volume of around 1 to 3 ml with no puberty, a short child. Usually the family history could be present. Autosomal dominant variant is usually seen in these cases. And when we do inhibin level, we can see a higher inhibin level in comparison to the permanent hypogonadotropic hypogonadism. So a short, and Dr. Bibha has mentioned about the short course of androgen therapy, and also we can also wait and watch to see the spontaneous pubertal progression is there or not. Moving on to the next case, a 15-year-old boy, same delayed puberty presented with, and now he has a small phallic length since birth. He has a height of 162 centimeter with a weight of 60 kg, and testicular volume is this time 1 ml around, and it is soft, and pubic hair stage was 3. So, Dr. Manoj sir, I would like to know your opinion regarding this case.
Yeah, thank you, Alappan. So here is a different case than Vibha has told. Vibha was talking about 13-year-old case. Here the patient's age is 15 years. That is fitting into the criteria of the delayed puberty. And first, if we see the height is great. So that means it is not fitting into the CDGP. Third, the testicular volume. It is very small. It is 1 ml only. So here we have to pick up all the pointers, and we have to think about something permanent is going on. What permanent? Hyper, hypo, or hypo. So here testicular volume is guiding us that we have to think about the hypogonadotropic hypogonadism in this setting. So we have done LH FSH that was yeah, it was low. There was no pointer of the HH, and there was even though if there is no pointer, then also it could be the isolated hypogonadotropic hypogonadism, and inhibin has been done, and in front of you picture is there. It is permanent hypo.
So very, very clearly that if you have testicular volume less than 1, if you remember this is good enough, testicular volume less than 1, inhibin less than 50, likely permanent. There's nothing 100%, but you have to follow, but most likely this is permanent HH. So will you do an anti-purity test here, Dr. Manoj?
As there was a no pointer, but in the every hypogonadotropic hypogonadism, we have to do other hormonal assessment to rule out the multiple pituitary hormonal deficiency. So yes, I would like to do, yeah.
So there's no problem in getting an MRI head because you may get some clues like absent olfactory bulbs and other things may also be there.
So on follow-up, this patient, he was given injection of testosterone 50 milligram monthly, which was increased 50 milligram every 6 months. Now he is having a normal penile development with a testicular volume is not increasing. It is still 1 ml. So after 26 years of follow-up, he was given testosterone continuously. He was married and again planned for the fertility. So Dr. Anshul sir, I would like to know from you that how would you like to plan from this scenario?
So if we talk about this patient was on testosterone since 26 years, and now if he's planning fertility, we might have to add SCG or an FSH injections. So SCG can be started from 1,000 twice weekly to increase to 2,000, 2 to 3 times a week, along with FSH, which is 75 starting dose twice a week to 150 thrice a week also. So once this has been given, within 1 year, it has been seen that spermachy might achieved and patient might have a high risk of increased risk of fertility.
So I think that's very, very important. And now people say that if you give testosterone for pubertal induction, it may have adverse effects, although there are no clear-cut studies. So there is group, Dr. Margaret from Australia and many other groups are advocating that rather than giving a testosterone, you start them with FSH for some time. Then you give FSH plus HCG during puberty. Once the TB becomes 8 to 10 ml, then give testosterone. The Japanese guidelines say continuously, they talk about right away. They don't even talk about testosterone because, of course, when you are saying this is hypo, the treatment should be LH-FSH rather than testo. It's the cost, number of injection and all those things. So what's the approximate cost of 1 month, let's say, if somebody has to get HCG and HMG?
Around 17 to 20,000 more than that.
At least 12, 13,000 is minimum is there. And the other thing to remember is that HCG and HMG are reasonably good enough. If you go for pure LH and FSH, the cost becomes very, very high. So these are the options which are available. So what happened on follow-up, Dr.
So
Alapan?
on follow-up, his testicular volume was still 1 ml with testosterone therapy. And now for the fertility planning, we have started injection HCG 2000 international unit biweekly along with FSH 150 international unit biweekly. On follow-up for 6 months, his testicular volume increases to 3 ml. And at 9 months, we found spermachy present in the sperm analysis. But initially, when patient presented to us, there was azoospermia completely. And at 12 months, the patient had conceived naturally in that scenario.
So this was a good outcome in that regards. And this is something like there was a big discussion in the ACS meeting recently in ISPE. And I have seen many patients who become fertile. Of course, somebody who is very severe like Calaman, they will be most difficult. But otherwise, we have seen many fertilities which have happened. What about acquired, Dr. Anshul? If it's acquired cause like a craniopharyngioma and other acquired hypogonadotropic hypogonadism, what's your experience? Is it easier or more difficult?
In terms of fertility,
fertility induction.
For acquired, it will be much easier because already that testicular volume will be higher and they might have a better function. So it is much better.
So that's their argument that if you sensitize the testis in the pubertal age group, maybe it is easier later on. So they have got mini puberty also. They've got puberty also. So now it becomes very easy. There you can only give HCG only, which may be good enough to get the outcome.
So moving on to the next case, a 16-year-old boy presented with pubertal concern. Onset was around 13 years, but then it stopped for 2 years. So now the testicular volume is around 3 ml with PBK stage of 3, height of 170 centimeter, quite tall boy. And he was diagnosed as a case of CDGP. So Bibha ma'am, I would like to know your opinion. How would you like to proceed from here?
So as we see in this case, the puberty has started, but now after 3 years it has stopped. So definitely it is not CDGP. In CDGP it has not started at all. So there are some causes that has stopped the puberty. That could be any lesion in the CNS that has stopped the puberty. It could be due to hypogonadotropic hypogonadism, that is this Klinefelter syndrome. So we should think about all the causes that has caused the stalled puberty. So in this case, we can see in the MRI there is a big lesion. This is looking like more of a prolactinoma. So it is the patient also has some neurological features as well. So this is a clear-cut picture of the stalled puberty due to the macroprolactinoma. And
So, and the other big message, as I was discussing with you, Dr. Mano, that we have seen patients who just presented with delayed puberty. And then they were found to have macroprolactinoma, they were found to have craniopharyngioma. So we should definitely evaluate MPHD, of course, but even isolated, it may be isolated now, it may progress further on. So very important point with Dr. Vibha said that normal height and pubarchy are against CDGP. Neuroimaging is absolutely essential in this scenario.
Moving on to the next case, a 15-year-old boy presented with delayed puberty, testicular volume of around 1 ml with no anosmia present. The gonadotropin levels were undetectable with normal screening test and MRI. So he was started with injection testosterone 100 milligram per month. And with starting the testosterone therapy, there is a increase in the testicular volume. So Dr. Ansul sir, I would like to know how it works, testosterone.
Yeah, so generally after starting testosterone in isolated hypogonadotropic hypogonadism, there will be no increase in the testicular volume. But this might be a case of reversible IHH also, which is showing increase in the testicular volume. So this could be one case. However, I would like to highlight what was the inhibin B level if it was done.
So initially the inhibin B level was low. So
Right.
it was, we had diagnosed him as hypo and
Right,
then we
sir.
were managing. But this is something which we are seeing not infrequently, that many patients who were labeled as HH become reversed. On the other hand, some people we say this is CDGP, they then go into the permanent HH as well. So this is something this probably would mean is that the GnRH neurons are coming from the olfactory placoid to the pituitary. You need maybe not 100%, even if they are 20-30%, they will start the puberty, but it may be not sustained. So in a way, CDGP and HH are just ends of the same spectrum, and there will be an overlap. So this case is an overlap probably. So always look for testicular volume every time. If it's increasing, good, wait for some time, stop testosterone and see if spontaneous puberty happens or not. So reversible HH.
So this is a case of reversible HH with increasing testicular volume with testosterone, and there could be sometimes curling of hair also present. And as Sarah has mentioned, this is a spectrum of thing. So moving on to the next case, a 17-year-old boy presented with pubertal concern. Onset was around 12 years and now it has become stopped for last 3 years. So a case of stalled puberty. Testis was 2 ml this time. It was firm and there was presence of gynecomastia present in this case. He is reasonably tall for his age. 182 centimeter was his height. So Manoj sir, I would like to know your diagnosis in this case and how would you like to proceed?
Yeah, here is the case that is 17-year-old child and who has a stalled puberty. So when something is going normal and it is stopping, that time we have to open our door and we have to see something pathological is going on. In the Vibha's case, it was a tumor. Here it would be the difference pathology. And Alappan, can you go back through the slides, previous slide? Yeah, and here the testicular volume was 2 ml, that is pump. And plus, if we combine this clinical history with the association of the gynecomastia, then hypo and hyper would be the two possibilities. But the chances of having gynecomastia will be much more in the hypo. So I will be thinking about the hypergonadotropic hypogonadism in this tall child.
So as Sarah has mentioned, we have done the gonadotropin levels and these are the gonadotropin levels with karyotype of.
Yeah, it is a client filter syndrome.
So what will you do for gynecomastia, Dr. Manoj?
So gynecomastia is due to the testosterone deficiency here. So once we start with the testosterone, it will progress for some time, but after replacing the testosterone for the 6 to 8 months, it will resolve. So here anyway, treatment would be the testosterone therapy with the counseling with the parents.
And surgery may be considered if you have persistent gynecomastia after 2 to 3 years, once you have reached the full adult dose. Similarly for bone also, a lot of people get concerned, get a DEXA done right away. They will find that the bone density is low. But if you have corrected the compare for 2 to 3 years for both Turner and Klinefelter, then do the DEXA. Then you will get a better picture in that regard. So tall stature, stalled puberty,
and shorty testis with gynecomastia probably indicates towards Klinefelter syndrome. We have to look for the gonadotropin levels before any diagnosis. And in these cases, fertility prospects are very poor as rightly described by Manoj sir.
So we had 3 phenotypes which were classically described. One was a short child, no pubic hair, 3 ml testis. This is CDGP. One was a normal height child with pubic hair development, soft testis, HH. Third is a tall child with gynecomastia with stalled puberty, pubic hair, shorty testis. This is Klinefelter. So if you just remember, you will be able to make right away the diagnosis at the time the child comes without doing any investigation. Of course, investigations will confirm those things.
So moving on to the next case, a 18-year-old boy presented with delayed puberty. She has undergone a penoscrotal hypospadia surgery with penile length of around 3.2 centimeter with PBK stage 4. There was a presence of inguinal testis along with gynecomastia on examination. His gonadotropin levels were quite high for his age. LH was 35 and FSH was 56. So, Dr. Ansul sir, I would like to proceed in this case.
So there was already there was a hypospadias surgery which was being done, and this patient has smaller penile length as well as testes are in the inguinal region. So this could be the case. We need to know the testosterone also. So testosterone is showing quite high. So it is more suggestive, not suggestive of hypo, but it is more suggestive of some androgen insensitivity defect. So DHT is also done, which is also on higher side. Suggestive of partial AIS. So partial AIS will see lesser ambiguity as compared to complete AIS.
This is very important point to remember, that you do not develop hypospadia in a child who has hypogonadotropic hypogonadism, because their HCG is taking over the LH work between 8 to 12 weeks. But if somebody has a problem in testosterone biosynthesis or action, they will develop hypospadia. So the presence of hypospadia means that you have ruled out hypogonadotropic hypogonadism, and clearly this will be a case of high testo, high LH. If testo is high, LH should be low. So this means that the testo is not working. This is a partial AIS classical presentation. Treatment, Dr. Vibha, I think you had managed this case.
In the partial AIS, we go for the high dose of testosterone here.
Yeah, so we had to give a very large dose of testosterone. Definitely gynecomastia surgery is required. Now the big question is, his testes are actually big. I think did we mention that? His testes are not small, his testes are big. So fertility plus minus, we are not clear, but theoretically there may be a chance of fertility also in this case. So partial AIS.
So it actually feminizes during puberty. There is high testosterone and DHT level with requirement of high testosterone during treatment.
So we'll now move forward to the second scenario of undescended testis, which is common at birth. 2 to 5% have undescended testis. 70% will descend by around 6 months to 12 months, while 30% will be permanent. So you can wait till 6 to 12 month period basically. Preterm babies, it is more common. It can be bilateral, and there are a lot of issues which are there. So if you look at testicular descent, the chances of descent will basically be happening throughout the gestation. So if you have a preterm child who is born early, they may have more likelihood of undescended testis. Then it will descend by around 4 to 6 months. Beyond that, if it is not descended, it will be permanent. So 6 to 12 months is the time when you are not going to lose the testicular function, and still it may descend. So wait in that period. Later on, you may consider treatment, and do not delay beyond 1 year. That will be a big message from that perspective. Very importantly, for preterm babies, don't rush. You correct the age and they will improve over time as well. So what is undescended testis? Diagnosed at 4 months of age with no scrotal testis. On inspection, you get poor scrotal growth. Sometimes the testes are there and you're not able to identify them. So ask them to go into a squatting position or a tailor position. Ask them to cough and you will be able to identify. Because if you say undescended testis, you have to do a lot of things. But if you're able to identify, things are over. There's nothing to worry in that scenario. Palpation should be a two-hand approach, starting from the superficial inguinal ring and going towards the scrotum. You will be able to milk the testis. So always be very careful before labeling somebody as a true undescended testis on that perspective. So first of all, exclude prematurity, ectopic testis, as for palpable gonads present. Look for hypospadias. Hypospadias with palpable gonad, that is atypical genitalia. XY-DST, go for Dr. Pradeep's talk, which will be uploaded soon. He discussed that very well. If it is not there, do surgery for 4 months. Don't waste beyond that. If you do not find the palpable gonad, if it's unilateral, then there is the only option is surgery. If it is bilateral, the question is it a abdominal testis? Is it a DSD? Or this is a anorchia? So in this scenario, you can look for Mullerian structures. If they are present, that will be XX-DSD. Go for workup there. If they are Mullerian structures are absent, then look at AMH, low in anorchia. And if it's male range, you have to do exploration. So bilateral undescended testis without Mullerian structure, go for AMH and inhibin B, and that will give you a clue. So this is the algorithm we are talking about. You should refer Every neonate with bilateral undescended testes, this could be CAH. Immediate evaluation is required. Bilateral non-palpable testis, immediate if AMH is undetectable. Unilateral, as I said, 4 months to 1 year. This is the time we are talking about. And acquired, sometimes you may have secondary ascent of testis. That also requires immediate surgery. Don't wait for any further time. And if you have a palpable atrophic testis, it's not doing anything, remove it. That is the key message which is there.
So moving on to the cases, neonate with bilateral cryptorchidism with a normal penile size present. He was reassured that it will not happen, it will not be any harm to your child. And Dr. Manoj sir, I would like to know whether this parental reassurance was correct or not.
So as we seen in the previous slide, this is the neonatal child with present with the bilateral cryptorchidism. So here it is looking like something going bad with the testosterone. So here we have to see for the Mullerian structures if it is present or not, and then if it is negative, then we in any case we have to do a 17 OHP. It could be the congenital adrenal hyperplasia that may be presented with a disorder of sexual development.
So in this case, Mullerian structure was present and 17 OHP level was high, 120.
So always consider very carefully somebody who had a bilateral cryptorchidism. I have seen patients with 21 hydroxylase presenting just like that, and they will die if we do not identify that.
So this is a case of 21 hydroxylase deficiency. We should rule out bilateral DSD in with bilateral cryptorchidism in cases of 21 hydroxylase. The modalities are like ultrasound and 17 OHP. Moving on to the next case, a 8-year-old boy presented with left undescended testis. And this is a picture of the child.
So Dr. Vibha, you can see this child, he is quite obese. He has a lot of suprapubic fat, and they were very concerned that scrotum is very not well formed and this testis is not there.
So, as the child is obese, so this is more like a buried penis, and the testis is present. We can ask the child to have a cough, or we can squat the child and palpate the testis by 2-hand methods.
Yeah.
So
this is again a situation of a normal physiological cryptorchidism. I said physiological, but it's not really cryptorchidism. So you should do a careful examination, ask them in squatting position. This really does a trick in most cases.
Moving on to the next case, a 6-year-old boy presented with left undescended testis, and he was gone for orchidopexy. Scrotal sac was well formed. Anshul sir, I would like to know your approach in this case.
So this is planned. This is not a bilateral. You can see that it is a unilateral undescended testis, and scrotal sac is well formed. Again, we have to palpate it properly and have to look for that it is coming up or not. So we have to look for whether it is a retractile testis or true undescended. This is important because retractile need no treatment. So retractile, you will see that scrotal sac is well formed. It will improve once the testis is brought till the scrotum, and you will find that cremasteric reflex is hyperactive. So this, of course, might need just observation.
So the best way is if you get the testis, try to bring it down in the scrotum, keep there for a minute and let it leave. If it goes up, it is basically a clear-cut undescended testis. Otherwise, it will be a retractile testis. So this is something which we often do as a test to identify that.
So retention test is the best we can do, and there is no need of intervention, as Sarah has already mentioned. So if we do an intervention in this case,
sometimes they do a suturing. Rare cases if it is persistent, but it is not routinely recommended. So this was more from a surgical perspective.
So moving on to the next case, a 13-month-old boy presented bilateral cryptorchidism.
Dr.
Vibha ma'am, I would like to know your opinion regarding this. How do you like to proceed?
13-month boy
So there is
by
no hypospadias.
cryptorchidism, and what is the Mullerian structure?
There is no Mullerian structure present in this case.
So definitely AMH is 12. It means that there were testes were there and they are producing some AMH, but they are not in the gonad. They must be in the abdomen somewhere. So it's the abdominal test.
So I think that's a very, very important point that you asked of, that you should do an ultrasound here again. CAH is less likely because he has survived so much time, but still getting abdominal ultrasound is important, and AMH is the best marker. We talked about inhibin B. So if you look at AMH, inhibin B, both coming from Sertoli cells and testo coming from the Leydig cell. AMH is highest in early childhood, it comes down. Inhibin B starts in late childhood and starts to go up in before puberty, and testo later on. So if you want to assess in early childhood, AMH is the best testicular marker, late childhood inhibin B, pubertal testosterone. So here AMH is a very good marker, and generally the level will be about 20, but 10 and above is considered to be quite good, which means this testis is probably now failing a bit. If it was inguinal or scrotal, it will be usually much more than 20 in this regards. So in this case, what should be done? So of course, we need to go for procedure very quickly. We have to refer to the surgeon. It's already 13 months and they should do it right away. So as I said, bilateral abdominal exploration is what is required.
So this is a case of abdominal testis. AIM is the sir has already mentioned about that it is the best marker for any testicular tissue, especially during early childhood, and it requires early intervention in terms of exploration. Moving on to the next case, a 14-year-old boy presented with right undescended testis. Orchidopexy was done 4 years of age. Now the child has presented to us with testicular swelling with loss of testicular sensation. Dr. Manoj sir, I would like to know, how do you like to interpret this?
So as we
clinical
previously
findings?
discussed, if a child is there with undescended testis, then ideal surgery should be done before the 1 year of age. Otherwise, we will have a less chances of the fertility, and we are knocking the doors of the tumor. So here there would be the testicular tumor, and loss of this testicular sensation is favoring that type of the diagnosis. So I would like to know, Leah. So even though if the surgery has been done, it doesn't remove the total risk of having the tumor development. So we have to keep our eye open here, and we have to look for the tumor in this kind of the cases.
That's a very, very important message. The testicular tumor is not prevented by just bringing down the testis. You may improve the function, but not the chance of malignancy. So always tell them that self-palpate, change in size, change in texture, sensitivity, right away come to you. We have seen, unfortunately, patients who come to us with abdominal germinoma. So late the testicular volume actually developed on that. And we had a couple, both testes had to be removed, and then they basically are without anorchia, in that sense, acquired anorchia. So this is important.
So moving on to the next case, 14-year-old boy presented with left undescended testis. Right testis is 8 ml, left one is 1 ml.
So this is a scenario. Often people think that if you have contralateral hypertrophy, so one testis is big, this is always happening, then the left is undescended, right is scrotal. So they will say, okay, this means the left testis is gone, don't do anything, leave it. But don't leave it. This is a very, very high chance that this may develop into malignancy. So this case, you have to go, definitely what they're saying is that you have to remove this testis. Don't even try to bring it down. Remove the testis from the European Society guidelines from that regards. So orchidectomy will be recommended because one testis is there, it is good enough in that regard. So unilateral, no role of medical treatment. Another big message, earlier when we were studying, HCG was in vogue. People used to give HCG for testicular descent. Now it has been shown that if you give HCG, it causes high level of intratesticular testosterone, which may be deleterious in an immature child where there are no Sertoli cells. So HCG has no role. If you're using HCG for hypo, give FSH before and then HCG. So don't do anything. Surgery is the main treatment which is recommended. So now we'll move forward to the micropenis, which we all know is a very common condition. For definition of micropenis, it's below 2.5 standard deviation score for age in a phenotypic male with a normal median raphe. So if you have hypospadia, that is not micropenis. This is something which we always talk about, and urethral opening should be normal. The penile development happens a lot between 9 to 12 weeks, and that is a critical window for fusion of the labioscrotal fold. If you have a problem in androgen synthesis or action, you will have hypospadias, while for HH, you will not have hypospadia, they will only have micropenis. After that, there will be growth till around 2.9 centimeters in term. Mini puberty, you will gain another 1.2 centimeters. What's very important to remember that from mini puberty till the time somebody enters puberty, there is only 1 centimeter increase in size, and parents are very, very concerned that there is no increase in size in this period. This is a static period. And after puberty, you have got a fixed growth. So if somebody has a small penile size right at the onset of puberty, they will remain compromised. So it's better to correct it before puberty rather than waiting, that we will wait for a long time. So 8 to 13 is a critical window for fusion. They will present with hypospadias. After that, they will present to micropenis. In newborn, if they are presenting, evaluate for multiple pituitary hormone deficiency. If mini puberty, you can wait because now maybe the penile size is increasing. After that, you should treat it right away before the puberty. There are nomograms which are available for penile size. So 30 weeks, 1.5, 34, 1.8, at birth, 1.9. Some people say 1.82. So it's just here and there in that perspective. 1 year, anything below 3.1. And then 3.6 and 4 is significant. So you can just use this or the nomograms which are available on that regards.
Moving on to the cases, a 8-year-old boy presented with small phallic size and
So small phallic size. The main question would be whether it's really small or not. So Dr. Manoj, how will you measure the penile size probably?
We have to use the transparent scale here. We have to have the stretched penile length so we can have a erectile tissue, and it should be done at the dorsal surface. So these are the 3 steps is required for the assessment.
And then only you will be able to do that. And very importantly, press the pubic ramus so that you can get the actual length in that perspective and exclude sometimes some children have excess foreskin which should not be counted in that regards. So this was the child who presented to us with obesity we discussed earlier. So they had concern about both micropenis and undescended testis. SPL was normal, nothing to be done.
So 8-year-old boy with small phallic size, height of 130 centimeter and weight of 44 kg, obese child. Pransul sir, I would like to know that parents are concerned about his penile length. How do
So
you
again, we have to properly measure the size. We have to suppress the fat and just see whether it is or not a buried penile. This is very common, which we see in our OPD. So we have to properly measure the stretch penile length.
So in this case, it was 6 centimeters. So again, this
Right.
was the obese child. The one slide before probably was the one that we're talking about. So this is a false impression of micropenis. Don't do unnecessary workup in this regards.
So moving on to the next case, a 3-day-old boy presented to us with presence of micropenis in our OPD. His stretched penile length was 1.8 centimeter, testicular volume of 2 ml both side. He was reassured and discharged in the subsequent visit and asked for the follow-up, but at home he has developed seizures. So Dr. Manoj sir, I would like to know, is there any fault from our side?
Yeah, so in this picture, you can appreciate the micropenis. The spectrum of the micropenis is severe here. So, sir has mentioned, according to normograph, at the birth, the penile side should be more than 2.5 centimeter. Here, the 1.8 centimeter is making us to think about something something severe is going on. It is not just a buried penis, and we have done the sodium and sugar level. That was a hyponatremia and the hypoglycemia. So now clinical pictures and the diagnosis in front of you that it is not a small micropenis, micropenis, but it is a multiple pituitary hormonal deficiency. So by just looking at the micropenis, we can have a pathognomic diagnosis is there in our hand.
So this is very important. Any newborn with micropenis, don't just discharge, get their cortisol, other profile done, sugar monitoring, very, very important from that perspective.
Moving on to the next case, a 3-month-old boy presented with micropenis and inguinal hernia. There's a sodium level of 130 millimole per liter with potassium of 5.8 and a head circumference of 32 centimeter. A picture of the child was present. So I would like to know from Dr. Vibha.
So if we see, there is a micropenis along with hernia, and if we see clearly, the head circumference is 32 centimeters. That is definitely a microcephaly, along with the hyponatremia and hyperkalemia. So micropenis, and if we clearly look at the facies of the child, there is a upturned nose, and there is low set ears in this picture. So definitely, all these clues are giving us a diagnosis of limits of SLO, in which there is a cortisol deficiency and the cholesterol. Every steroidogenesis is defective.
And because there are alternate pathways, so it's a milder disorder compared to other salt wasting forms. You will have mild salt wasting, but cholesterol will give you a clue. Low cholesterol will give you a clue clearly for SL.
So, as ma'am has rightly said, the microcephaly, micropenis, upturned ears, and typical faces, lower set ears, points towards the Smith-Lemli Opis syndrome, mild adrenocortical insufficiency. DSD can be happen, but often we can present child as isolated micropenis. Moving on to the next case, 3-month-old boy presented with small phallic phallic size. SPL length was 1.6 centimeter, a testicular volume of 2 ml. He has low gonadotropin levels, almost undetectable. So, Dr. Ansul sir, I would like to know your plan regarding this case.
So we can see that this is a time where mini puberty comes and we should be having some detectable FSH LH, which is very quite low in this subset of. So we have to proceed further in this case.
So this looks like a hypo. This is unusual for this LH level. So often people say, okay, levels are low in children. No, not low till around 6 to 12 months. That is the time when the level may be very high. We have seen testo up to 100, 150, LH up to 3, 4. So this is mini puberty. Clearly, there's no increase in penile size. So definitely we should think of giving a treatment. And now, as we were discussing, that some people even say, right at this time, you may give FSH and HCG. But there's hardly any much study on that. But you should give testosterone. This is what we give in this scenario. Now, at 14 years of age, presented with delayed puberty and anosmia. So, Dr. Vibha, what do you think is there?
Basically, this child was hypo, where the mini puberty was absent, and later on, his puberty was also delayed, and he presented with anosmia. So, this is a case of permanent hypogonadotropic hypogonadism.
So this is already we have discussed in detail. So isolated micropenis, low LH FSH in mini puberty, and delayed puberty will be the characteristic features. We'll go to the final part of gynecomastia, which again is a more common problem which we see. Most cases are physiological, which can be there in the pubertal age group, neonatal age group, or older people. Pathological cause can be because of either deficiency of androgens. We talked about Klinefelter being more likely. So hypergonadotropic hypogonadism is more likely to have gynecomastia than hypo. Estrogen excess, rare cases, HCG tumor, and some systemic illnesses can have these scenarios. So gynecomastia basically means a benign swelling which is symmetrical, fibrous, and concentric. So if you have an eccentric swelling, if you have a hard swelling, then you should not think of gynecomastia. This is something else. It can even be carcinoma. Above 0.5 centimeter in diameter, you ask the patient to lie down, put the hands behind the neck, feel for the breast tissue and see how much is the diameter. This is how you do that. It may be unilateral to begin with, and it's usually a circumferential one in that regards. Very importantly, if there is tenderness present, it means there is an active estrogen present. So this could be suggestive of pubertal, and there may be discomfort. After around 12 months, fibrosis happens, which means there is not much estrogen, not much benefit also in terms of treatment from that perspective. So if it's a pubertal onset, good pubertal development, testicular volume, smaller size, this is physiological. If it is pre or post pubertal, large size, testis is small or more, this is more likely to be pathological. So this is how you can distinguish. So most cases do not require evaluation in that perspective. So if there are indications for evaluation, that is pre or post pubertal onset, above 4 centimeters and 17 years of age, you then evaluate. Very importantly, take history of drugs, liver, renal, thyroid disorders. Find the cause. Otherwise, testosterone, if it's low, this is hypo or hyper. This is already we've discussed. If the testosterone is high and LH is high, this could be partial AIS. The case you remember we discussed earlier. If it's low, this could be a tumor, HCG producing tumor, and these scenarios can be looked at. So gynecomastia, 80-90% will be physiological, and there are other rarer causes.
Moving on to the cases, 15-year-old boy presented with gynecomastia. It was noted 1 year before the age of presentation. It was non-tender and a testicular volume of 4 ml. So
Dr. Rajat is not there. What will you think, Dr. Vibha, here?
So this is a pubertal age group,
Yeah.
and this is 1 year ago it has presented. Its testicular volume is 4 ml pubertal. So we can think of this physiological gynecomastia.
And other thing always is to look for lipomastia. Most people will be obese and you will find that this is actually not a true tissue. So somebody referred to us with gynecomastia, always palpate, as I said. If there is no resistance, this is a lipomastia. So this is important to do from that regard.
So moving on to the next case, a 14-year-old boy with gynecomastia noted 6 months ago, similar, but this time it is tender. Testicular volume is around 4 ml. So Dr. Manoj sir, I would like to know whether it is a pathological one or a physiological one.
So this child has been noted with the 14-year of age with the 6 month ago, and it is looking like it is a peripubertal gynecomastia with the testicular volume of the 4 ml. So here I would like to wait for the puberty to happen, and then if it is persisted after the puberty, then and then it would be the things to be worried.
So again, this is clearly a case of physiological in that perspective, reassurance and not tamoxifen. There's no role of tamoxifen here. So physiological gynecomastia is.
It is peripubertal usually in onset. Diameter should be less than 3 meter and should be resolution should be by 17 years. And ideally there is no requirement of any treatment, as Manoj sir has rightly pointed out. Moving on to the next case, a 18-year-old boy presented with gynecomastia. It was noted 3 years ago, around the age of 15 years. It is non-tender. Testicular volume is around 20 ml. And Dr. Anshul sir, I would like to know how this case is different from the previous one.
Right. So this is patient is post-puberty, but this has crossed 17 years. So he need definitive treatment right now because it is not going to automatically resolve.
And again, it's non-tender, which means that there is no estrogen exposure currently. So all the drugs are not going to help out. This is clearly pathological. This is a candidate for definitive treatment. So pathological.
If it is a prepubertal or postpubertal, always think about a pathological cause, larger size, and no resolution by 17 or 18 years. We should go for the treatment. Moving on to the next case, a 17-year-old boy presented with breast enlargement, recent onset and rapid. Testosterone level is quite high for his age, 920 nanogram per ml. From Manoj sir, I would like to know your approach in this case.
Yeah, so in the first case, Dr. Anshul has been talked about the androgen insensitivity syndrome. So here it is looking like a very high testosterone, but there was a normal pubertal boy is there. So, and if you see the history, then particular 2 point is noted that it is a recent onset. So recent onset is making us thinking towards something very rapidly going on with the rapid progressions, and you can see the LH is very low. So here with the very, very high testosterone that is not coming from the pituitary, we have to think about again something like tumor or something serious pathology. So it was a Leydig cell tumor in this kind of the setting. So the message would be that gynecomastia would be just symptoms. You have to underroot the you have to find the reason and you have to treat that.
So again, if it's rapidly progressive and virilizing, you have to think of a Leydig cell tumor. So I think we are at 131. So we have been able to finish off the exactly at 130. This was the plan to finish off the presentation. And it has been a wonderful 2 days and 5 days for many of us who have been on the on-site course as well. I'd like to thank Dr. Manoj, who has been filling up the shoes of other people a lot. Dr. Anshul for the wonderful presentation. Dr. Vibha. Dr. Alapan again for this one, and I have to thank the entire team. Thank Dr. Nimisha and Dr. Sandeep who have been here continuously. The entire CDER team. We have got Dr. Prashant ji, Hariom, Nikhil, Aditya. Aditya has been instrumental in calling hundreds of patients. Prashant ji has been coordinating with all the participants. Hariom has been working with all the issues in terms of printing and everything. And Nikhil has been there with a lot of other support. Entire